I won't talk too much about the Commission and the healthcare work because they're far greater experts to do it. What I want to say is it's very rare in life that people take on a project this ambitious and then somehow something like COVID, remember that, comes through also, and yet the project finds fulfillment. And here we are. I realize now I'm verging towards long years ago. We made a tryst with destiny, but we did. And the hour now comes when we shall redeem our pledge. And you know, as I was walking in today, and it was so foggy, I also thought, because of course poetry should always occur to one, of that beautiful line, "Dekh to dil ke jaan se uthta hai, ye dhuaan sa kahan se uthta hai." So for those of you who don't know Urdu, look at this smoke, as it were. Is it from the living body? Is it from the heart? From whence does it arise? And Mir, it was a kind of doctor, and he was looking for a diagnosis. And that's what we're going to have today, a kind of meta-diagnosis of healthcare in India. I want to say that we'll hear a few talks in the morning, and then we'll have panel discussions. During the panel discussions, we'll open up to questions and answers, so that, because this is meant to be a conversation. But let me, without further ado, introduce someone that I've only come to know recently, but has become a fantastic presence in my life, Pamela Das. So it's really a pleasure to introduce Pamela. Pamela, forgive me, it's a very formal introduction, but I felt it was necessary. Pamela Das joined the Lancet family of journals in 2001. She's currently a senior executive editor at the Lancet, where she mainly oversees the journal's global health work. Her areas of expertise and interest are infectious diseases and tropical medicine, global health, public health, and international health policy. Her roles include commissioning, peer review, and writing editorials, as well as overseeing the Lancet's comments and news sections. She was the co-founder of the Lancet's racial equity group, GRACE, of which she is currently a member. She is a PhD science graduate in biochemistry, and prior to working at the Lancet, she spent a few years as a medical writer and journalist. We're delighted to have Pam open this session, this special day today. Pam.
Well, thank you, Hitesh, for that wonderful introduction to me. Good morning, everyone, and welcome. It's so lovely to see you all, and I'm so excited and pleased to be here today at the launch of this important commission on India's continuing journey towards universal healthcare. So I'm going to split my opening remarks. Two mics, right? I'm not going to stand so close. I'm going to split my opening remarks into two parts. A brief history of the Lancet and Indian science and public healthcare research, and the origins of the Lancet's work on this latest chapter of our association with this, in fact, my great country. First, though, for those of you who don't know the Lancet, we are a global medical journal founded in 1823. We just celebrated our 200th anniversary just a few years ago. In fact, I also celebrated a big anniversary just a couple of weeks ago, 25 years at the Lancet. Yeah, 25 glorious years, if I may add. So back to the Lancet. Our mission is the best science for better lives. Global health is a strong focus of our work. Thank you. And we view global health through the lens of not only health itself, but also, and very importantly for us, health equity and social justice. Our relationship with India goes back a long way, and over the decades, we've published some really groundbreaking research. And I'd like to just mention a few of them. In 1968, the Lancet published the first study showing that oral rehydration therapy, ORT, could greatly reduce or eliminate the need for intravenous fluids in patients with cholera or other potentially lethal acute watery diarrheal diseases. The discovery of ORS was a collaborative global effort, but it was the practical advancements led by scientists at the Johns Hopkins Centre for Medical Research and Training in Calcutta, among others, that paved the way from laboratory success to field implementation. Today, ORS is a simple yet groundbreaking solution and has saved millions of lives, particularly in low and middle income countries. Another example, and the people I'm going to mention are people that will be known to most of you here, are Abe and Rani Bang. Their innovative and empowering work in the late 1990s really showed them to be pioneers of healthcare in rural India. Their home-based neonatal care study showed that training village women to provide newborn care, including managing sepsis and birth asphyxia, reduced infant mortality by nearly 50%. The impact of that has been enormous. The Lancet honoured this paper as one of its most important publications in its 180-year history at the time. The study led to the global adoption of home-based neonatal care by WHO, UNICEF, and the Government of India's ASHA programme. Let me give you a few more recent examples, which extend not only to the Lancet, but to the Lancet's sister journals, the family, as we are now part of. The Serum Institute of India has published a couple of trials across the Lancet journals. One notable study is a randomized controlled trial published in the Lancet Infectious Diseases, which showed the protective effect of new meningococcal vaccine. That has led to WHO pre-qualification and will support broader meningococcal vaccination in low and middle income countries. This vaccine brings us a step closer to the elimination of meningococcal disease by 2030. More recently, and very impressively, there's been the rations study, reducing activation of TB by improvement of nutritional status. This was a really extensive India-based ICMR-funded clinical trial that provided the first direct large-scale scientific evidence that nutritional support can significantly reduce TB incidence and mortality. This study by the Mangaluru-based doctors has led to the WHO revising its global TB treatment guidelines, which now formally recommend food assistance as a standard component of TB care. This is a major shift policy worldwide. And just to insert a short personal parenthesis, I'm proud to have been the first editor from an Indian heritage to work at the Lancet and the opportunities that I have been given there. And I thank my boss, Richard Horton, for his vision and leadership. Another reason why I've stayed so long at the Lancet. Yeah, you've been just an iconic force for me. But going back to me, my parents wanted me to, I'm a second generation Bengali, raised in the UK. My parents came to the UK in 1968, and I still have family in Delhi, Calcutta, and Bangalore. I've been really fortunate to visit India regularly throughout my life. My parents wanted me to experience a love for this country as they had, and to develop a dual Indian-British identity. So I'm especially proud to be standing here, not only as an editor of the Lancet, but also as a daughter of my parents and of India. Okay, back to the script. Enough about me, enough about the Lancet. Our first country series was on Mexico in 2006. Julio Frank was the Minister of Health at the time. And as a health system scientist himself, he wanted to document scientifically the achievements, but also the remaining challenges stemming from the reforms he had introduced. That series has been the benchmark for all our country work that has followed in the succeeding 2 decades. The key lesson for us from Mexico and all of our subsequent country series and commissions, from South Africa to Nigeria, from France to Brazil, is that health is the perfect lens through which one can understand and tell the story of a nation. Without health, a people of any country will have a dismal future. But as health assumes a greater importance in a nation's history, so that country, its hopes and its aspirations become stronger and more confident, looking forward to its future rather than backwards to its past. India arrived at that inflection point in the 21st century. 15 years ago, in 2011, I stood here, or maybe not exactly here, but in the Habitat Centre, in this spot at the launch of the Lancet's first India series in collaboration with the Public Foundation of India. And I was going to say, I'm very happy to see the leader of that project, Professor Srinath Reddy. Is he coming? Okay. But I'm really excited to see Srinath, who really began this journey with us all those years ago. Now, that 7-paper series entitled India Towards Universal Health Coverage provided a comprehensive analysis of the country's health system. It identified critical gaps and outlined a roadmap for achieving UHC. The series argued that the timing was right for India to adopt a radically new architecture for its health system. We were privileged to present the series personally to the Honourable Prime Minister Manmohan Singh in his residence. It was an extraordinarily moving moment. Remember, it was he whose government had initiated one of the most important health reforms of recent times, the National Rural Health Mission. The series also influenced the National Health Policy 2017, which was committed to advancing the agenda of UHC and the missions of Niti Aayog, the apex public policy think tank of the Government of India. Although that series was an important contribution to the national debate and thinking about health, and technically it was a brilliant, if I may say so, analysis and summary of India's successes and challenges at the time, the political climate was not ideal. And in truth, we didn't make the progress we would have wished. But we learned lessons, and we believe those lessons are embodied in the commission we are presenting today. Because this commission begins and ends with the people of India, the citizens. This work has evolved over 6 years from tremendous commitment and effort by an amazing team of Indian scientists, public health leaders, and civil society activists. I'd really like to thank and applaud Vikram Patel, Tarun Khanna, Gangandeep Kaiyang, and Kiran Mazumdar-Shaw, who were our fantastic co-chairs, and especially to Anishka Kalita, a joint co-author who has been vital in the writing and production of, well, I'd like to say of what you have in front of you, but you'll see the executive summary and the booklet. I hope eventually we'll get to you all, but it is an absolutely fantastic body of work. and including some of our peer reviewers who I know will be presenting later in the agenda. I'd also like to thank our great commissioners for assembling this work, as well as for grappling and engaging with a really tough commission peer review process. But it's that peer review process that gives us all the confidence today that what we will discuss is offering the most reliable evidence to guide decision makers in their policy making. I'd also like to thank our funders, the Lakshmi Mittal and Family Institute, South Asia Institute, Harvard University, the Christian Medical College in Vellore, Department of Global Health and Social Medicine at the Harvard Medical School, the Azim Premji Foundation, Rohini Nilekani Philanthropy, the Serum Institute of India, Mahindra and Mahindra Limited, and Infosys. And just to end with a personal anecdote, my family story. My mother was second eldest and originally from a family of 9 siblings. She lost a brother at childbirth and cared for both sisters, one with polio and the other from sepsis until their lives were taken. The story of every family, as well as every nation, is a story of the lives of those we love. So, as you're listening to the presentations today, some of them are going to be quite technical, I just hope engaging in those debates, let's please think of our families, of those we love, because nothing could be more important. Thank you. I'm going to now hand over to Vikram Patel, the lead co-chair. Vikram is the Paul Farmer Professor and Chair of the Department of Global Health and Social Medicine at Harvard Medical School. He is a co-founder of the Indian NGO Sangath, a recipient of the WHO Public Health Champion of India Award, and has served on India's first National Mental Health Policy Committee, as well as the WHO High-Level Commission on Non-Communicable Diseases. Vikram, over to you.
Let me start by, first of all, thanking Pam for having shepherded this commission over the last 5 years. And thank you for reminding us about the peer reviews. Those of you who have ever seen Lancet peer reviews, or indeed any kind of peer reviews, would know these are incredibly challenging documents to receive. And we received 12, not 1, not 2, not 3, but 12 peer reviews. So that trauma still remains. But I want to first of all start by acknowledging what a privilege it has been to be part of this incredible commission. There are many people here who have been, without whom we would not be standing here today. And so I want to acknowledge, first of all, my fellow co-chairs, Gagandeep, Kiran Mazumdar-Shaw, and especially Tarun, who is here today, as well as all the commissioners and authors. There are 30 authors of this report. But in addition, there are many other commissioners who have also been engaged with this process. And I want to thank each and every one of them for staying the course and reaching where we are today. I want to acknowledge also that many of our authors brought into play their own networks of scholars, of practitioners, and altogether I've lost count of the number of people who have intellectually contributed to this commission, but it's roughly at least 200 to 300 people drawn from more than a dozen institutions around the country. Harvard is the only really major institution that's not located in India that has been involved. And even amongst those of us from Harvard, like myself and Tarun, we count ourselves very much as part of the Indian diaspora. So this is very much a commission that is grounded in India, and it is led by people who are from India. I wanted to just give you, in my remarks, a little bit of a backstory about the commission and, very importantly, the process. What you're going to hear after me is, in fact, the main reforms, and I don't intend to speak about those, but instead to give you a little bit of a backstory and tell you how we arrived at where we are today. So the commission was launched in December 2020. That's roughly about 5 years ago. Many of you will remember, but some of us have chosen to forget because it's really a difficult story, the pandemic. This was at the end of the first year of the pandemic. And of course, this was still a few months before the devastating Delta wave. All of us who lived in India at that time cannot ever forget what happened during that Delta wave, which really ripped through communities across this country, killing at least hundreds of thousands, if not millions of people. And it was a stark reminder of the fragility of our health system. It has to be said, this was not only in India, it has to be said that no health system in the world was prepared for what came. So, but nevertheless, we are in India, and it reminded us about the fragility of this health system. But yet also, over these last few years of the pandemic, we also saw a very different picture. And that was a picture of remarkable resilience and remarkable depth of the healthcare system. I want to just touch on two examples of that. The first example was the unprecedented ability of this country to manufacture and to deliver vaccines on a scale that one could never have thought possible. And I would say that the most formidable weapon, if I can use that word metaphorically, in that was the Asha. Pam, you referred to the remarkable work of Rani and Abhay Bang. In fact, that remarkable work, which has always been perhaps my biggest source of inspiration in my work, in fact, led to the Asha movement. Indirectly or directly, there's a continuity there. And the Asha, the humble woman who roams the villages of India, in my mind, is the single greatest innovation that has come from this country. And of course, the Commission spends a lot of time referring to the need for us to recognize this health workers' phenomenal contributions that led to them being recognized by the World Health Organization's Director General's Global Health Leaders Award in 2022. No doubt, Dr. Swaminathan, who was in WHO at the time, probably played an important role there as well. But another example of remarkable achievements in this country come from a very different end of India's diverse ecosystem, and that is, of course, its technology prowess. Many of you will be familiar. We all had to go through the COVID vaccination, go online, go to an app. That app, actually, that platform, CoWIN, again, which the Commission celebrates, has without a doubt been one of the most remarkable digital public infrastructures that is present in the world today. And indeed, it is today the platform through which India's entire immunization program and much more that we will hear about later on today has evolved. Let's be very clear about the philosophy of CoWIN. It's public. And I think this is a very important example of how India not only innovates from the Asha to CoWIN, but innovates in ways that are very equity focused to ensure that no one is left behind. But let me just dial back historically to 1947, because the journey to universal health coverage really began then. It began then as India secured her independence. And at that time, the Bohr Committee report, all of you historians will know very well about that report. It's a very interesting story. In Britain, there was the Beveridge report. In India, there was, at the time, the British Raj was here, the Bohr Committee report. And both these reports had been constituted, commissions really had been constituted to help chart a course for a more equitable and just healthcare system for the peoples of Britain, in the case of the Beveridge report, and the peoples of India for the Bohr Committee report. And interestingly enough, if you had asked me what's new in this commission, not a lot. In fact, we're basically saying the same thing as Bohr said in 1945. And it's important for us to say the same thing, if that is what is important to be said. Affirming something that was said 80 years ago, because nothing has changed in terms of the values, principles that underpin a health of a nation, it's important to say it again. But there has been a lot that has changed since 1947. Back then, the Bohr Committee, which really spoke to a very community-oriented, equity-focused healthcare system. Sadly, most of its recommendations could not be implemented, really quite simply because the Indian state had no money. It had no doctors. It had no facilities. We had none of the infrastructure that is needed to build universal healthcare back in 1947. And instead, what we were able to do was a highly biomedical, doctor-led, facility, hospital-led healthcare system that focused on certain disease areas like family planning and infectious disease, which back then, of course, were a leading cause of death in India. Instead of a comprehensive universal healthcare system, we were left with a highly vertical doctor and facility-led system. However, let's fast forward to 2026. At this moment in our history, India is truly at a pivotal point in its journey to universal healthcare. And this commission celebrates how much progress India has made as a nation over the last 80 years, and especially in the last 25 years in the new millennium. Indeed, we believe that this is historically a unique inflection point, an inflection point when the old paradigm that we did not have enough of this, that, or the other, the core ingredients that makes a health system, the doctors, the nurses, the other healthcare providers, the facilities, the technologies, the stuff that goes into healthcare, the pharmaceuticals, the vaccines, all of these things that used to usually be enormous barriers and obstacles in our imagination, all of that is already taken care of. And this is why this commission takes a very optimistic, a very hopeful position that we are not the country of 1947. We are a country that in fact has everything that is needed, not just in terms of the staff, and systems that make a health system, but very important also the political will. Across successive governments, as we document in the commission, across successive ideologies that different governments have embraced, one thing has remained constant. Over the last 25 years, every political party and every government has at least said the words that are important in terms of healthcare for the people of India as being something that those political parties and governments champion. Reimagining healthcare, as you can imagine, for a fifth of the world's population, a population that is driven by many historical inequalities and strata, a population that lives in a formidable range of diverse ecosystems, a healthcare system that over the last 50 years has evolved in very positive directions, but also has become increasingly fragmented. Trying to define a set of solutions for such a diverse country and such a huge population is not something that any one commission can do. Instead, what we have really chosen to do is to assemble data, to bring together evidence that can be the basis for a set of high-level reforms. The idea behind these reforms is that they're not intended to be prescriptions, but instead intended to be proposals that different contexts, different ecosystems, different sectors in this country can find some alignment with their own values, their own principles, and then to test these out in the subsequent years. The process that we adopted, therefore, was one that was based on defining our work around a number of different pillars of what makes an effective health system. Those pillars were the financing of the health system, the human resources that went into the health system, the governance of the health system, technology, and of course, at the heart of everything that has been, I'd say, the central guiding principle of this commission, citizens' engagement. You're going to hear more about all of these in the subsequent panels. But to continue on the question of process, because this is important, we then, each of these different work streams, which comprised a group of commissioners and authors, generated a set of research questions that were needed in relationship to that particular work stream to achieve universal healthcare. We then designed studies, and as you will see in the report, in my view, this is the most comprehensive set of data that informs India's health system that's ever been assembled. Just to give you a snippet of some of those data. We conducted theory of change workshops with more than 40 thought leaders from around this country, in-depth interviews with key stakeholders, including several who had played active roles in the historical evolution of India's health policies. We conducted the largest nationally representative survey 50,000 households drawn from across this country, specifically focusing on the experiences of those households in accessing healthcare in India, but also importantly, their aspirations and their preferences for healthcare. We gathered together huge amounts of secondary data from the government itself, like for example, from the NSSO, but also from yet to be published data that had been generously shared with us by investigators from around the world, seeing how important it was to have their data included in this commission. Our colleagues at IIM Bangalore led the development of a new index that has already been published in the Bulletin of the World Health Organization, an index that could help document the progress at district level, which is of course at the heart of all healthcare planning, right down to the district, the progress that a district is making towards achieving universal healthcare. And today that index, which is in the public domain, it's real-time online, can be used to monitor and track the progress of a district towards its goals of universal health coverage. This is just to give you literally a snippet of the huge amount of data that has gone in to inform our analyses and our recommendations. So what has this data shown? India has made remarkable progress in the last 2 decades towards its journey of universal health coverage. There is cross-party consensus, and this commission supports this consensus on the central role of the government as a financier, as a provider, and as a steward of the health system. We observe that the architecture of India's public healthcare system is unparalleled. In our view, it is the largest state-run healthcare operation in the world, which stretches from over 1 million community-based providers through to a comprehensive network of sub-centers and primary health centers, to district hospitals, all the way to some of the most sophisticated tertiary care hospitals in the world, such as, for example, the AIIMS and the medical schools across this country. The country today is the world's largest producer of human resources for health, not only enough for our own needs, but indeed probably now become the main supplier of healthcare providers in wealthy countries. It is the world's factory of medicines and vaccines, again, not only for Indians, but for the world. The technology sector is unparalleled, not only because of its tremendous ingenuity, but its ability to do cutting-edge technologies on a national scale and at costs that are unimaginably low. In fact, as a routine and regular user of UPI, it is actually unimaginable even 6 or 7 years ago that almost all our financial transactions would be done through our smartphones. And this is just an example of the tremendous technological prowess that this country has assembled, which of course, as you will hear about later, act as a catalyzer for many of the innovations in healthcare delivery that we speak about. The citizen survey showed that over 95% of all households have sought healthcare in the past 12 months. This is, of course, backed up with a lot of secondary data. And why do I say that's important? I say that's important because 50 years ago, that number would have been less than 50%. In other words, access to physical infrastructure, to doctors, to nurses, to pharmacies, to diagnostic laboratories is no longer a challenge. We have no supply side barriers. Of course, there are inequities. I'm giving you a big level picture, but generally speaking, there are no supply side barriers for general healthcare needs, and there are no demand side barriers. People are actively going to the health system. So then what is the single greatest challenge? It's a challenge facing many sectors in India today as the country has moved forward in addressing the huge access gaps, for example, in healthcare, but also in other areas like education. The focus now is not the availability of doctors and clinics and drugs, but in their quality. Quality is the single biggest barrier alongside equity. Of course, equity is a cross-cutting one, but quality has emerged as the one big area that our health system needs to focus on. And by quality, I mean the entire journey towards universal healthcare, from the quality of the training of our medical and nursing professionals, to the quality of the pharmaceuticals that our companies produce, to the quality of the care that people receive when they consult doctors. As the Commission documents, there are grave concerns about some of the competencies of our frontline providers. That's just one example. Indeed, today, this is a reason why irrational use of medication has become such a dominant feature of the poor quality of care. And let me tell you why this is important. The irrational use of medication and diagnostics is today the single biggest driver of out-of-pocket expenditure. It is a startling finding of not just the Commission, but other independent data sources that suggest, and this is a number you should take away, roughly 65 paisa of every rupee spent out of pocket on healthcare is not on the doctor. It's not on the hospital bed. It's on the medicines and the tests that we are doing in the massive unregulated pharmacy and diagnostic laboratory sector. But there's another consequence of irrational drug use. It damages the health outcomes of people who are seeking care. It's not just a coincidental finding. It actually directly affects health outcomes of the individual. And more than that, it threatens the health of the population because of the emergence of antimicrobial resistance. And of course, it therefore also threatens the health of the world. So this is one very dominant example of poor quality care. One of the Lancet's sister journals, the Lancet Global Health, for example, published these data, and these have been now validated by the Economic Survey of India, that last year, more people died in India because of poor quality healthcare than lack of access to healthcare. This is a startling finding. You're more deaths occurring because the care you receive when you go to a clinic is actually poor quality. This is also a reason why many people bypass primary care. We have on paper one of the world's most incredibly well-organized systems of primary healthcare, as I mentioned earlier, and yet people with even the mildest health problems will skip primary care and crowd the corridors of our district and tertiary hospitals, or leave the public system altogether to the private sector. And of course, this is again to do with the quality of care that people receive. And by the way, that doesn't only include irrational care, it also includes the softer, as it were, the less visible aspects of healthcare. For example, being treated with dignity and respect by the healthcare provider. And it wouldn't surprise any of us here in this room that these experiences are inequitably distributed in the population. Those who come from historically disadvantaged groups, those who come from lower socioeconomic backgrounds, etc., experience much worse quality of care than the rest of us. So in the panels, you're going to hear much more about how we address these reforms, these challenges. But I want to end by just giving you some high-level guiding principles that have been at the foundation of our thinking about the concrete reforms. There are several guiding principles. The first of those is that we transition from a doctor and facility-centric fragmented delivery system, which is focused on specific diseases, to a comprehensive, coordinated, citizen-centered system. What does this mean? It means addressing the care that is needed by the person rather than a specific disease. Second, a transition from citizens being passive beneficiaries or recipients of healthcare towards becoming active agents with rights. This commission is proud to embrace the notion that all the citizens of India have a right to health. Third, a transition from focusing merely on physical access to healthcare to ensuring that everyone receives high quality healthcare which is strongly aligned with respect and dignity. Fourth, a transition from centralized towards decentralized, citizen-centered governance. Of course, governance and accountability is a cross-cutting theme right through this commission. informed by robust, comprehensive, and publicly available timely data. Fifth, a transition from providing weightage to only provider qualifications, which is, of course, our current obsession. Do you have the right degree? Towards emphasizing provider competencies, values, and motivations. This commission takes a very strong position on empowering both the Ayush physicians as a critical resource for India's health system, but also, very importantly, the frontline workers, most relevantly, the ASHA. Sixth, to responsibly and ethically leverage the power of innovative technologies to support the reimagined healthcare system to deliver citizen-centered care. And finally, to explicitly acknowledge rights and health equity as a core value of universal health coverage, and the reduction of health inequalities as a critical metric for the evaluation of the progress of our health system. An overarching principle is that the people of India enjoy a universal, fundamental, and inalienable right to health, and that the government must be accountable for financing and operating the public sector while stewarding both the public and the private sectors. How? You are now about to hear the reforms. There were 6 major reforms. We have 5 panels. 2 of the reforms have been clubbed together in one of the panels. And as I end, I wanted to just give you a sense of the structure of the program that we have set up for today. We see the publication of this commission today as only the first step in a journey. And in the spirit of transparency and sharing, today we have these 5 panels that will be presented. Initially, each of the panels will be foregrounded by one of the commissioners or authors presenting the key reforms. And then over the course of the day, we have more than 20 panelists, 90% of whom have been drawn from outside the commission. And this is an explicit and intentional effort for us to engage with voices and actors from outside the commission. What I hope we will hear today is both a set of observations, but also critiques, alternative ideas, and suggestions of what the commission has put forward. I hope we also hear some endorsements, but that remains to be seen. What I'm hoping very much today is to hear from our incredible group of panelists. And so I want to first of all start by thanking each and every panelist. All of you have taken time out from your very busy schedules to be with us today. And finally, I'd like to thank all the authors of this commission. I'd like you all to stand up and celebrate this moment that's taken 5 years in the making. Thank you. Thank you so much. Well, not everyone's an author here, but that's fine. Everyone stood up for the authors, and that's great. Thank you so much. I'm going to hand it back to Hitesh.
So I'm not above taking author credit when I can, but don't tell the academy where I work. So you see why in the beginning I did not want to stay on stage very long, because I wanted you to hear what is extraordinary about today from the mouths of the actual experts who've been engaged in this work so deeply. And I hope you agree with me that this is a moment of great celebration, and it was exactly right to hear from them. I ventured by chance into Nehru's speech, but Vikram, with your ringing declaration and the context setting that you did, you actually charted a path that Indian healthcare has taken since the end of the British Raj to today. So perhaps it was not so, my reference, thank you for making my reference relevant. And Pamela, you also spoke with passion about the value of healthcare. And as I was sitting back there thinking about it, I was thinking the Indian word swasthya literally means to be established in oneself. When we are sick, we all know this from experience, you just don't feel quite right in your own body. And swasthya is when you do feel right and can inhabit your own body. And that is the extraordinary thing, Vikram, what you and Pamela have shown us is it's about the individual human beings, but this is an entire nation, the attempt to get an entire nation to be able to sit in its body with comfort. So without further ado, let me just move on to the first panel discussion. I want to say we don't need to take a break. There is tea and coffee out there. So anyone who would like, please don't hesitate to get tea and coffee. But let me introduce in the meantime our panel moderator for the next session, Dr. Anushka Kalita. Dr. Anushka Kalita is a health systems expert with over 20 years of experience in the Indian health sector and in the health sector worldwide, actually, spanning 12 countries across Asia, Africa, Latin America, and Europe, with a special focus on this country. She's currently Director of India Health Systems at Harvard University, and before Harvard, Dr. Kalita worked in a variety of roles, ranging from research and implementation to grant making and policy with organizations like the Gates Foundation, the World Bank, and the World Health Organization. She has a doctorate in public health from Harvard University. And Pamela, since you gave us permission to give a personal word, I want to say Anushka and I have been working together now for a few years on the business of this commission, and it has been a great privilege. She brings extraordinary expertise, and through moments of extraordinary stress, grace from which I think we've all learned and benefited. Anushka.
The clarion call of this commission is for an integrated, citizen-centered health system that is publicly financed and publicly provided as the backbone of universal health coverage. This panel focuses squarely on the public sector because that is ultimately where scale, equity, and accountability resides. First, why did we recommend this this reform? Being a citizen-centered, with the aim of being a citizen-centered, commission and creating a health system that is citizen-centered, we listen to the citizens first. And from the citizen survey that Vikram mentioned, we found that 70% of people currently seek care from a public provider for their healthcare visits, which has gone up substantially from some of the earlier data that we saw. 75% of the people want to seek care from a public provider for their future healthcare visits, which is a stated preference, and it gives us hope that when the public sector system improves, more people will want to go and seek care there. And also, majority of the citizens wanted a stable primary care provider as the first point of contact for their healthcare needs. And these are the three sort of data points that we took as the foundation to think about why the public sector system is so important. In addition to what Vikram talked about, the infrastructure, the excellent the uncomparable human resources for health that our system has. You might not be able to read all of it. It will be in the full report, but I just want to highlight. So even with the very positive, hopeful data that we saw, we do have some challenges to think of. The first is on finance. The first is on healthcare delivery. It is still fragmented, even though we have on paper an excellent, blueprint for referral and coordination. Our system continues to be fragmented. We continue to be doctor-led, and we continue to be facility-focused instead of outreach-focused. In terms of health financing, government health spending has gone up substantially over the recent years, but there are gaps, especially in certain states. Some states, of course, are already spending, almost enough to cover UHC and achieve the goals, but they're not. And there are efficiency issues across the health system. And I think all of us in this room would have numerous examples of many of those efficiency, both technical efficiency and allocative efficiency gaps. There are, of course, governance issues of state capacity, of coordination, of referral, of administrative issues at every level of care. We do have an excellent digital public infrastructure system with the ABDM, but we need to think about how to integrate that throughout. So coming to the reforms, these also just to let you know, these align to the reforms in the report exactly as the report says. So if you want to refer to them, they are there. Increase government financing and improve the efficiency of spending, including enhanced central transfers to states, especially with large deficits and low fiscal capacity. We are talking about, so whether it's new funds that we get or the existing funds that we already have, there has to be allocative and technical efficiency across the system. And this is not just by thinking about how to spend it, but also how to consolidate fragmented budgets, merge fragmented pools of resources, including the large employee state insurance scheme, the ESIS, and what can we do about it. And what we have recommended is to merge it with the general tax pool and expand it further. The second sub-reform is to implement a purchaser-provider split and to implement strategic purchasing across the system. We recommend an autonomous purchaser institution while the Ministry of Health stewards the delivery of services. And we already have the blueprint for this with the NHA and the state health agencies to a large extent, but we do talk about a clear legislative mandate, autonomy, and expanded capacities, along with robust governance with diverse stakeholder representations for accountability, including citizens on the governing board of the purchaser, which some of the countries that I have worked in globally actually have. A benefits package and provider empanelment, a benefits package that is evidence-based and is guided by health technology assessments. Both the HTAIN and HEFTA are there in order, that can be further empowered and built to help this. ABDM, an excellent DPI, a digital public infrastructure, could help with data systems to choose providers, track quality, evaluate providers, and measure performance metrics. The third reform is to build a decentralized technology-enabled integrated delivery system that we call the IDS, based on the foundation of primary healthcare. And I want to stress that the system has to be grounded in the principles of comprehensive primary health care, which we lay out very in detail in the report, but a defined catchment population-based enrollment using probably the ABA IDs, expansion of primary care personnel that can do a lot of the outreach work. So not just a reactive health system, but a responsive outreach-oriented health system, a comprehensive continuing outreach-focused care delivered by a multidisciplinary team. We talk about integration of care, primary care level as the first point of contact and gatekeepers. Of course, this will depend on quality, and as we improve through the over time, they can play more of a role as gatekeepers. Service capabilities of providers aligned with epidemiological and clinical rationale. So where should we go for regular chronic disease management, not necessarily a hospital, but probably the primary care center? And on the other hand, where should we go for deliveries, not necessarily probably a facility that does not have a blood bank or a neonatal ICU, but to facilities that have these emergency capabilities. So that is what we mean by clinical and epidemiological rationale. Secondary hospitals need to, of course, be strengthened and play a coordinating role of the IDS, including in the purchasing of services from primary care. They will empanel primary care providers from the public sector and establish referral linkages with tertiary hospitals. And of course, digital technologies throughout the system, linking all the levels for clinical decision-making and seamless continuity of care and coordination. I already mentioned this a little bit, but strengthening secondary care for high-quality specialist services is another very, very important pillar of the health system, along with primary care, because that is where some of the plateaued mortality kind of you can trace the reasons to that. So we need to upgrade designated secondary healthcare facilities, but also provide them with one from the clinical point of view, but also from the managerial and administrative point of view, to provide them with a certain level of autonomy. And this links to the secondary care level being the nodes of the IDS that we envision. Of course, strengthening capacities for specialist care through task sharing, non-specialist physicians, etc. And we have a lot of details in the report about these. And the last reform is to motivate providers to deliver high-quality citizen-centered care, and especially how do you incentivize that the primary care levels will focus on prevention and promotion, and the hospitals will also be invested in wellness instead of us being ill, the population being ill, where they make the money. So aligning incentives and provider payments to the vision and goals of UHC and the integrated delivery system is just absolutely critical. And we talk about transitioning from line item budgets, moving to global budgets for secondary hospitals, and capitation-based blended payments for primary care, along with performance-linked incentives for all levels. And these can be, these can range from patient satisfaction to clinical competence, to actually registering on the ABDM, being a part of the ABDM and sharing data, etc. Incentive alignment, again, facility-based and team-based incentives are shown to have a better impact on a multidisciplinary team approach that we were thinking of. So looking at adopting those. Quality metrics, patient outcomes, patient satisfaction focus, and of course we have talked about that. Vikram talked about that, and more. An important point that we often forget is are the non-financial incentives for providers and basically. So career progression pathways and professional development support for health personnel are equally important. So the key strategies we recommended are one, pooling and purposefully deploying public financing, and these are all related. So that's the resource mobilization, and once we have that, it's more money for us, for UHC. Once we have that money, we steer care towards high quality and efficiency through strategic purchasing. So that's how we use the money. And we use the money to deliver integrated care with population-based integrated delivery system. We anchor the system entirely on the principles of comprehensive primary health care. And lastly, we have to align the incentives with value and not volume. We also recognize that there are, of course, barriers that need to be addressed, and these are all very difficult reforms. They might already be in place to certain degrees, but they're still difficult. They're wicked problems. Of course, there is fiscal and pooling barriers to resource mobilization for health at the center and some states. There are institutional and administrative barriers, especially for creating purchaser-provider splits and consolidating pools. We have seen that from across the globe. System integration and transition barriers, especially for establishing the integrated delivery system, adopting technology. There are behavioral and incentive barriers. I don't need to stress that more. There are, of course, state capacity and institutional barriers to establish this kind of a decentralized system that we are thinking of. And last but not the least, there would, of course, be political economy barriers as well. So with that, I'll stop here and invite our stellar panelists. The good thing about having a panel like this is they don't need much introduction. I would like to invite Dr. Shamika Ravi first. She's currently a member of the Economic Advisory Council to the Prime Minister and Secretary to the Government of India. Ravi. I want to invite Dr. Ajay Tandon, who's the lead economist in the World Bank's Health, Nutrition and Population Global Practice, and he works in the South Asia region. Dr. Indu Bhushan, who is a co-author and a commissioner. Of course, you all know he's the architect of India's National Health Authority. And Professor Karthik Muralidharan, who's the Tata Chancellor's Professor of Economics at the University of California in San Diego. And he's written one of our favorite, one of my favorite books that I use it as like a Bible almost, Accelerating India's Development, a State-Led Roadmap for Effective Governance. And we've used that so much, Karthik, for our report. All right, so stop there. Shamika, I would like to start with you. So given the realities of India's fiscal landscape, what mix of public financing instruments, taxations, transfers, earmark funds, social health insurance, etc., would be most effective, in your opinion, in sustaining what we envision and in sustaining, in increasing resource mobilization and sustaining an integrated sort of public financing pool for UHC?
Thank you. Namaskar. Good morning, everyone. First of all, thank you for this opportunity to be here and meet with all of you on this very important topic. I think health, while being at the center of a lot of public conversations, it sometimes tends to fall off the radar on account of the fact that we don't look at health financing from a very mainstream public finance concerns. For instance, this is the budget week. We're terribly busy meeting with lots and lots of people with lots of ideas, and you'll be surprised how little representation there is from this segment, right? So that's number one. It will take a combination of everything, simply because it's too large a country. The federal structure lends itself to enormous variations, right? That is something you have reported, repeatedly also reported in this particular article, where different states are struggling with different aspects of the problem. Now, I just want to highlight this by making a very simple statement regarding the public finance for health in particular. We think of center supporting states with fragile fiscal health, right? But we also have to fundamentally think of the revenue generating power of a state. It's not enough to just look at the deficit by itself, because the deficit is an outcome of the state revenue and the spending. Now think of a state like Bihar. In Bihar, the revenue mobilization is very limited. the state has seen incredible economic growth, but it's largely on the back of agriculture, which is not taxed. They have a ban on alcohol, which means one other area which generates and mobilizes resources are out of the picture, right? We have a state like, let's say, Tamil Nadu, which is an industrial state, growing very well, increasing pension burden. We have a state like Himachal, which traditionally has had very healthy fiscal, having gone back to an old pension scheme, which means the fiscal deficit is out for a toss, not because of any other concern, and deficit on its own is not the simple metric that we really have to tie up with. Health being a state subject means there is an inherent incentive structure built into this fiscal structure, which then allows us to incentivize and motivate states to do what is right for what you're trying to say, right? I'm not saying that, for instance, today, if you've had the chance, I wrote something on gutka consumption in Indian Express today. I don't know how many of you realize, but the household consumption expenditure survey that has just come out annually now for the last 2 years, we are seeing that in the last 12 years, the bottom 40%, which is the catchment area for Ayushman Bharat, the spending, the MPC, the monthly per capita consumption expenditure, share on pan, tobacco, and gutka is around 5% monthly. The spending on education and health is 2%. Now, I'm trying to motivate you to the fact that we cannot talk of right to health and right to things and the state obligation while there are inherent moral hazard problems emerging. There are inherent behavioral problems. So there are rights and then there are duties. And I think a citizen-centered approach cannot then only look at what the state is supposed to do without us really looking at the data a little more in detail to then try and articulate the problems also from a behavioral, a larger public finance perspective. So those are my sort of broad opening remarks.
Thank you. Thank you so much, Dr. Ravi. And I think what you said at the end links very nicely to what we envision in our in saying that the system should be rooted and grounded in a primary in a comprehensive primary healthcare approach, which inherently kind of takes into account the preventive, promotive, and behavioral and persuasion. You know, those are kind of the control knobs in our parlance that you know, the policy levers that that we should also keep in mind. But thank you also for highlighting the differences in the fiscal capacity and the realities and the contextual realities of the different states. Ajay, I'll come to you next. The reform, you know, proposes not just sort of increasing public financing, but also being more efficient. And one of the things we recommend is pooling and you know, merging different pools with the tax revenue source. And the second is strategic purchasing, especially the purchaser-provider split. So, given your you know, global experience as well as experience from India, what are the key design choices that we should keep in mind for this to be realized?
Thanks very much, Mrs. Berg. And also wanted to echo congratulations for this very, very excellent and comprehensive commission. I was reading it yesterday and was just saying, wow. So I just want to start by making one point, complementing the point that you made in the report that UHC is a marker of Viksit Bharat. I would argue that UHC is also an enabler, right? In terms of it's an economic imperative. In terms of you know, as countries grow and develop, the health sector becomes a bigger share of the economy. It's a generator of employment, as was pointed out. It's also important for productivity, especially with the NCDs, chronic NCDs like diabetes and hypertension, that don't only have an impact on premature morbidity and mortality, but also expose you to a, you know, lifelong 30, 40, 50-year string of financial implications which universal health coverage can help overcome. So UHC is also an enabler of Viksit Bharat. And with regard to your point on the thing, I think just globally, I was just looking at the data again. We know that public financing is key for universal health coverage. Technically, it's actually compulsory prepayment, but no, it's actually public financing. We don't want to include Switzerland and the others that have compulsory purchase of private health insurance. Those tend to be more expensive, but really there is no if then but on this. Countries that are closest to universal health coverage use some diversified mechanism of general taxation and or social health insurance. And typically they have the out-of-pocket spending share be sort of 15 to 20% of total health spending, which is sort of the case in many high-income OECD countries. And this sort of is what is referred to as the health financing transition. So enabling this transition to happen is also, it's not that it's going to happen overnight, but on the path towards crowding out-of-pocket spending or making out-of-pocket spending incident on the well-off rather than on the poor. That is also a strategy used by many countries like Brazil and Malaysia. So public financing is key. I think where I might disagree a little bit is we are quite agnostic in terms of public delivery. So there's a big difference between public financing and public delivery. I'm not an advocate for the private sector. I'm just saying countries have made progress towards universal health coverage, including countries in our region. In Japan, most of the delivery is private. In South Korea, most of the delivery is private. And there are mechanisms by which you can bring in, by the way, India is one of the most privatized health systems that I have ever worked in. So ignoring that private sector, I think maybe something to relook at. There are mechanisms by which you can bring the private sector under the public financing umbrella, also to enable regulating it and sort of putting guardrails in place. For instance, in Indonesia, you talked about primary care registration. In Indonesia, you can choose to register at a public puskesmas or a private primary health care facility, and you can switch every 3 months or so. That also, so there are, there's an element of competition for capitation payments that follows. So just a suggestion that perhaps we can also look at that, and also that builds on the experience that India has had with engaging the private sector, as Indu will talk about more under PMJ and the like. So. So that's one point, and I think in general, I think as the Commission also points out, larger diverse pools are generally more preferable. The Commission points out the importance of using the monopsony power of a sort of a larger risk pool, but it's also an enabler for cross-subsidization across states, across risks, but also cross-subsidy, economic cross-subsidy, equity. Except in situations where you have service delivery that's skewed. So there are situations that have happened, for instance, in Indonesia, where there's their reforms move towards having a larger pool of public financing, both contributory and non-contributory, but the service delivery was unequal. So you're able to access or realize the benefits package much more in urban centers than in rural areas. So they had actually ended up having the reverse situation where the poor ended up cross-subsidizing the rich simply because of the service delivery differentials. It's a large country with lots of islands and differences across provinces. And so, one has to be cognizant of that and put guardrails in place to ensure that it's not that this is getting captured by the well-off simply because of where the service delivery happens or where the high-end tertiary care is. And the third point, I think that's important for risk pooling, which wasn't mentioned in the Commission, was it also encourages and enables predictability, right? Your law of large numbers. It takes what is individually an unpredictable financial situation and makes it more predictable. So you're able to then to plan and adjust and allocate resources better if you have a larger risk pool. The other point I would just sort of complement what is mentioned about bringing together all the risk pools. I think it's also very important to bring together all the benefits packages of the risk pools. Currently, there are big differences. So it's not just a financing issue, but you also want to make sure that everybody has access to a comprehensive benefits package, regardless of their economic status, regardless of whether they're prepaying through ESIS or not, and let the out-of-pocket spending and the private insurance focus on the frills, the brand name medications, the air-conditioned rooms. But everybody should have access to a sort of a publicly financed package. And again, to move towards that, including the non-poor informal sector, which wasn't as explicitly mentioned in the Lancet Commission, but India has made tremendous progress on reducing poverty. But there's a whole bunch of people that are just above the poverty line. So vulnerability they're one shock away from becoming poor again. So it's important to go beyond just covering the poor and the formal sector, but really to emphasize the non-poor informal sector. And maybe I'll just end by saying that, yes, strategic purchasing, I think for equity, for efficiency, but also for quality, as was pointed out in the beginning, very important. There are I wish I could tell you there was a method in which you can do strategic purchasing that will get you all of this, but you're right in saying that line item budgeting and fee for service are the two worst ones, which currently are prevalent in India, but countries are struggling. There are intermediate ones and blended ways in paying for providers. One has to, perhaps in some cases, immunization should be paid fee for service, so that or other preventive care, so that they don't get missed out. So I think that will have to be contextualized and designed carefully. But one thing that I missed in the report was also there's a move globally. You're trying to pay providers now, to put it awkwardly, you're trying to pay providers so they make more money or they get more money the healthier the population is. Currently, the way you're paying providers, they make more money or get more money, the more unhealthy. Now, if somebody can crack this, there's a Nobel Prize waiting to be won. But just to say, that is the big debate going on, that how do you pay providers so they get to keep more money the healthier the population is. And in that point, there's bundling of payments that's being looked at, not blending, but bundling, where you bundle, for instance, somebody who's diabetic or hypertensive, they may need care at the primary, secondary, or hospital, but you pay for regardless of where they may seek care. So even if some kind of virtual networking can be put in place, the UK is experimenting with that, but so is the US. So some form of bundling of provider payments. So you're getting the providers to work together in order to manage and keep the population as healthy as possible, or keep them seeking care at lower levels without aggravating the situation. So unnecessary hospitalizations are prevented. And I'll just end by also underscoring that for strategic purchasing, for equity, efficiency, data and governance are key. And you need to have a system that enables information flows. There's a culture of sharing data and encouraging analysis and also to monitor and make adjustments over time.
Great, thank you so much, Ajay. And I think that's such a good segue for Dr. Bhushan. Let me come to you, and we will come back to Ajay's points a little bit later. Given your experience, I mean, you're the architect of both the NHA and the ABDM, and what do you think are some of the existing policies and infrastructure in India today that we can leverage for what our commission envisions, and what should we also do differently or newer things that we should do?
Thank you very much, Anushka, and thank you for including me in this panel. Although you mentioned that you wanted only 10%, so I'm representing 25% of commission here. But as the report says that Indian health system, in terms of both financing and provision, is one of the most fragmented systems probably in the world, in developing world, and in financing, out-of-pocket expenditure actually represents the most extreme form of fragmentation, where millions of people are putting in money separately, and there is no, of course, collective bargaining, there is no strategic purchasing. And as the report also mentions that once financing is fragmented, it's neither efficient, because you can't get the best prices, and you also don't approach the best medical approach, because you just are looking at the cost of that, but also is inequitable. So now the question is that how do you reduce fragmentation in financing? And so one way is that tax finance should be increased. All the financing should be done by the government, and so the taxes go to government, and then of course there is a correlation, a negative correlation between government funding and out-of-pocket expenditure, and obviously the fragmentation is reduced. Second approach, of course, is having greater prepayment systems like social insurance, and where people are paying into a pool, and so they don't have to be paying out-of-pocket expenditure. And now the question is that how should we move towards less fragmentation? And Ayushman Bharat, both in terms of primary care, but also more importantly, PMJ, was a step towards reducing this fragmentation and bringing about 650 million people, providing them this cover. But when we started this scheme in 2018, we also realized that over years, over last 75 years, there have been several schemes which are running. Many ministries, they identified vulnerable groups, and there were schemes for those. For example, there was a scheme for BD workers, which is being run by Ministry of Agriculture. There's a scheme for people with disabilities being run by Ministry of Social Justice. There's a scheme for cinema workers who are on the fringe of cinema being run by Ministry of I&B. And those are providing scheme for construction workers. So large number, there were about 26 different schemes. And in one of the meetings, we suggested that, all these schemes should be merged. And decision was taken, of course, all the different pools should be merged. This will be a larger pool. And of course, it doesn't make sense for all the different schemes to have separate purchasing of services, having separate health benefit packages, separate systems, separate administrative structure. It's inefficient. So a decision was taken, let's merge it. So all these small schemes, of course, got merged with the PMJ. But where we got stuck was in big schemes like ESI. ESI covers millions of people. It has its own act, and it is a political economy of merging that with PMJ was almost impossible, because it also has a lot of say from the workers. But bigger than that was CGHS. CGHS, we have a very anomalous situation where government is financing CGHS and PMJ for the same treatment provided by the same hospital. For CGHS, they were paying something different as compared to PMJ. And but CGHS provides services to all the secretaries to Government of India, and also Supreme Court judges and others. So merging them with PMJ, you talk about political economy, was impossible. So we said, okay, and when we went to Cabinet Secretary for proposal with merging, he also almost laughed us off out of the room. And then we said, okay, let's not use the word merging, let's say integration. But integration was also not acceptable because, of course, integration means that in times to come, you will just merge them. So we said, okay, convergence. And convergence, and then we would ask that, please define what does convergence mean, so that it's not like threatening to any of the constituents. So we define convergence as a, like there will be one agency who will be implementing the scheme. They will be, we'll have same panel of hospitals for all of them. we'll have similar, not same, similar benefit packages. And we'll have the costing of all the packages will be same, so that it's not that for cataract, for CGHS, government is paying X, but for PMJ, government is paying X by 2. So it should be same. And so we defined the parameters of convergence. And I am happy to report that convergence is taking place not only with CGHS, but ECHS, which is a defense scheme, railways, which has a huge pool of its own, and then 7 what they call CAPF, Central Armed Police Forces, like CRPF and Border Security, BSF. So all the 7 CAPFs are also converging in all the state schemes. All the states have the schemes for their own. Sujata is here, she's gone out. So most of the states are also now converging, and actually some of them have merged with PMJ because they found it much easier. So that is being done. So now on the provision side also, there is a huge fragmentation. As you know that we have at the PHC level, sub-center level, about 52 records, 52 registers which are maintained. And of course, when the registers were maintained on paper, it was very difficult to integrate them. But many of them now have become virtual. They have become digital. For example, RCH has its own portal. TB Niksha is on its own portal. NCD has its own portal. So now, of course, they have these different portals. These portals are being developed by different donors, and they don't talk to each other. And now ASHA workers have to put in information both on these portals, but also maintain records on paper, because they don't believe that portals will remain all the time. They are still asked to report. So merging, so one person, if she or he is there in all three systems, there is no way to know that person with the NCD also has TB or has a problem with the RCH related issues. So that integration is actually extremely important. And so over time, now with ABDM, now we have the capability and ability to have that kind of integration and reduce that fragmentation. Also the fragmentation between different level of services. So not only the horizontal, but also the vertical fragmentation could be now could be addressed through ABDM. And I'm sure Kiran is going to be talking in the next session about how that integration is being planned. And I think some progress has been made, but we are still far away from the ideal situation.
Great. No, thank you. Thank you so much for that and sharing stories from the ground. And I think it's such an important link to also, Ajay, your point earlier about also a uniform benefits package, and not just, it's not just about payment rates and merging pools, etc., but it's also about, what they are offering. And I think in no country in the world, the civil services benefit scheme has been able to be consolidated and merged with the general populations. Karthik, I'll come to you now with some of the most difficult questions. Reforming the entire system, we're talking about, all the policy levers of financing and purchasing and provider payments, mainly incentives of, people across throughout the system, and also the decentralization at a not just federalism, but coming down to the district level or even below. And I want to ask you about what are the institutional and accountability structures, the state capacity concerns that we might have to address, and how do we kind of operationalize this integrated delivery system? Easy questions. Absolutely. You're on your way with the book.
So thank you. I think I'm was especially privileged to also be invited to be one of the public commenters of the report. So I have had a chance to read the whole report. And I think that comment, I think it was circulated among the authors, right? Like, it's in the booklet. So let me just start by just, commending the effort in the synthesis and, and just the enormous amount of work that went into this. I'm also, just really happy to see the equal focus on equity and efficiency, because normally, this, these two don't talk as much as they should. So this is wonderful. Okay. So let's get to, I think, the elephant in the room, right? The elephant in the room, and I'm happy Ajay went before me because I basically agree with everything he said. Okay. And so, the elephant in the room is we're talking about building this whole thing on the foundation of public provision. Okay. But the elephant in the room is the accountability in there is so miserable, right? It's not that people are spending out of pocket going to private providers because they want to spend out of pocket, right? I mean, they're doing that because the public system exists in many places on paper, right? My first study and still most highly cited paper is my All India study on teacher and doctor absence, finding on any given day that 40% of doctors are absent. And it's not just that they're absent. Esther Abhijit and Angus Deaton, I think the first time, they don't agree on most things, but they work together on this paper in Udaipur, studying, not just looking at the average absence, but showing that the absence is completely unpredictable. Okay. So which means that if you're absent 40% of the time, but the patient knows which 3 days you're going to be there, I can at least plan on that, right? But if the problem is I have to give up a day's wages, pay for the bus and go to the public facility and find that the doctor is not there, I am rationally not going to do that. Okay. So essentially the reason, and the elephant in the room, the second elephant in the room is we have from household survey data, we know that over 50% of users is private. The problem is nobody has a clue who these private guys are because they're technically illegal and therefore they don't exist in the system. Okay. So we have done this nationwide study for the first time, mapping the existence of informal providers, right? I mean, and the truth is that they exist not because they're evil and unqualified. They exist because they are there. Okay. And it's, and they are there and they are in the communities. Okay. So I think the big picture question to me as an economist is that it really isn't about the resources. It's fundamentally about system design. Okay. And so, and that's why I'm so happy Ajay went before me, because see, the public has its problems, the private has its problems. The basic problem is the public has inadequate incentives. The private has too much incentives. Okay. So, and that's the Nobel Prize problem to be solved, right? I mean, and this is what makes health economics so wicked, right? So, and before we start blaming the absent doctor, I mean, think about how perverse our public system incentives are, right? Because the doctor who works hard is going to get more patients, more workload without any additional resourcing. There's no compensation. There's no kind of component of variable cost that adjusts for how many patients are coming. So it's completely rational, even for a well-meaning doctor, to have a certain amount of effort and no more. Okay. So if you want to architect a system, right, thereby you get the right incentives for treatment without incentives for over-treatment, I think the core is exactly what Ajay was saying, right? I think what's been done in Indonesia, what the French system looks like, right, which is patients, there's absolute kind of need for public financing, and maybe there's a sliding scale of subsidies whereby, you cover 100% of the cost for the poorest, and then, there's a means testing sliding scale. But the core point, and to me, when you say citizen-centered, right? So the other comment I had is I greatly commend kind of, and I look forward to the panel on citizen empowerment and agency. The problem is, if you look at the research on education, all of the school management committees and stuff, for the most part, don't work. And they don't work because of the asymmetry of power between the citizens and kind of how powerful the provider is, who often doesn't even live in the community. Okay. So the way you really empower citizens is by giving them the ability, not just for voice, but the ability for exit, right? And so that means so you've done the first step of saying separate the provider and purchaser, but the next logical step is for the money to follow the patient. So we've done that for PMJ. So those precedents are being built, but in many ways it matters much more for primary, right? Because, and the focus on PMJ, I think, again, reflects the political reality that politicians follow citizens. Unfortunately, they don't lead citizens, but citizens also think about health only when they fall sick. We don't think about it when we are healthy and need to prevent. And so therefore health becomes salient when you fall sick. And therefore it is salient to the politician to solve the problem when it is salient to the citizen. Okay. And that's why we kind of go backwards and spend everything on curative disproportionately. Okay. So if you build a system whereby you're agnostic to public versus private, there has to be a solid public option in every case. And this is, we've got tons of research saying that the better the public is, the better the private is also, right?
That's
so you're
what we
forced
found
to
in our
get better,
data,
right?
yeah.
And so And so this is not in any way a knock on the public, right? So it's not about public or private. It's about how do you architect a system that both are able to backstop the weaknesses of the other, right? So in principle, the public sector has many advantages over the private, which is you're not a profit maker, your cost of capital is lower, okay? And the trust is higher, okay? So if despite those advantages, if you're not able to perform, that means what the private sector does much, much better is management, right?
Yeah.
So that is the single biggest thing the private sector does better, okay? So to me, the core architecture piece that's missing and which I highlighted in my comment, which I think will also help with your two other sessions on technology and on the private sector, is how do you create a payment model that incentivizes the public? So the point is very simple, right? The patient gets to register. I wouldn't let them switch every 3 months. I think that's too disruptive. Maybe it's once a year. Okay, so once a year, you pick your primary practice. That primary practice gets a capitation based on how many patients are uniquely registering. That's expected to cover a menu of services and a certain amount of reimbursement at a certain rate that doesn't incentivize overtreatment, right? And then that primary care becomes the foundation of everything and the referral, okay? Now, and the two big things you get with this is you encourage high quality private providers to kind of enter the low cost, kind of low affordable segment, which today doesn't happen, okay? So the technology piece, Nachiket, Kiran and I were on a panel in Bangalore, the technology ideas are fantastic. The question is who's going to do it? So who has the incentives to align the potential of technology to deliver these system level results? And the government is just too big to kind of do this in a nimble way, right? So what you need are payment models that encourage high quality private providers to come in and leverage all of this technology, to come in with these effective models where maybe in the remote rural areas, you need high quality nurses who are able to do the real time kind of examines and samples and even low cost testing and are able to access, specialists who are available remotely, right? So there's all these integrated models that you need to get the incentive for. So I'll just say one final comment on the commission report itself, which I think it's an excellent kind of resource. I think the main challenge to me, if I was sitting in the finance ministry reading that report, is I have no idea where to start, okay? Because it's a laundry list, right? And so my criticism is basically that, see, intellectually, I understand. There's an economist way of thinking about this in terms of marginal rupee spent. So tell me how to prioritize, okay? Which in this list is the single most important thing I should do, and give me a descending order. So sitting in the finance ministry, we can advocate for that. You can take a different view, which is to say the reason you can't do that is these are systems and that everything is integrated, and therefore the whole is more than the sum of the parts, and therefore I cannot do this piecemeal. I have to do it in a full way. But if that is the commission's view, then we're not going to get from here to there for the whole country. Then it's really important to think about what are the state and district level pilots whereby you bring your entire vision together, because then that's much less expensive and that can be done at a state and district level to give us a template for the country. Okay, so I'll stop there.
Absolutely. And thank you so much, Karthik. It really, it's so fortuitous because we were just in a meeting yesterday and we were talking about pilots and interest from the government and the Niti Aayog, who themselves mentioned about the importance of thinking about exactly what all three of you mentioned about payments and payment models and how do you incentivize, because I think that is the biggest wicked problems of all the wicked problems. And as a commission, we do take a view that it has to be comprehensive. I think our country has to move from schemes to a system, not thinking through schemes anymore. And we do want to emphasize that. So it's we don't have magic bullets. I will open it up to the audience. I know we don't have too much time, but I also see so many people that we want to hear from. Yeah, any questions to the panelists? Any comments? Any experiences? I see Dr. Sujata Sonik here. If she wants to, I'm sorry to cold call you on you, ma'am, but your experience in this is just incredible. So would love to hear from you about the reality from running a state.
Thank you. I'm Sujata Sonik. I'm a Takimi Fellow, Chan School 2018, and also a research fellow from Synthesise. And I also very recently finished my professional journey as a bureaucrat, superannuated as Chief Secretary of Maharashtra. I have been also the Public Health Secretary earlier, and my own experience, particularly I would like to share about budgeting.
is that when we sit down with the top leadership of the state, looking at budgets, the concerns there are very different. And there is no sort of public-driven demand. No? I think that's what Madam Ravi also hinted at. The second thing is that the emphasis is more on building infrastructure. Everyone wants something in his particular area. But then what happens to it? Nobody is bothered. The second thing that I learned in my tour of duty is that we don't provide for maintenance of these buildings either. So once an institution has been built, it stays there till it can survive. And then after some time, it falls into a very dilapidated state. Nobody would like to work in a dilapidated building. We forget that the health workers are also human beings and they need a proper environment in which they can flourish. Speaking of doctors particularly, I think I'm very much in agreement with what Professor Imagat has said. She has mentioned that politically, the doctors wield maximum influence. And in our state, particularly in Maharashtra, they do exert a lot of influence because they are a very precious commodity. They are required and they are needed, and they tend to get what they want from the leadership rather than giving back something in terms of performance. Having said that, it's really the frontline, lower level bureaucracy in health that keeps the system going. If they were not to be there, then our systems would not work. So moving forward, what I see is that there was one comment about how we need to build national level programs. We do have a lot of national level programs. They do a lot of work of outreach and making sure the medicine and vaccine is reaching to the needy people. We just need to strengthen those. And I do agree with what Professor Vikram Patel said in the morning about quality. That's really lacking. And I'm sorry to say, but even in the private sector, quality is not necessarily there. Last comment. We are a country that is gradually aging now. And I'm sorry to say that care for the elderly is seriously lacking in this country. People don't understand whether it's nursing care or palliative care or care for any chronic disease. People have no idea. The young doctors who are passing out, they are struggling to understand this whole phenomena that India is facing. So there's a lot of need for building quality elderly care into whatever systems we are proposing for the coming years. And lastly, I think all of you have been such wonderful speakers. I'm learning a lot. So thank you for having me here.
Thank you, ma'am. Thank you. We are at time. So let me close the panel by thanking each of our panelists. Lot of food for thought, lot of work for us for the next phase of the commission, and also a lot of pointers for my other panel moderators through the day. And if you could stay on, a lot of your questions might be addressed in those panels as well, especially on the private sector panel, Nachiket. All right, thank you so much.
Welcome back. As I said, the next course is stronger than Indian chai, however good Indian chai is. Every single event I go to in India, the chai is always listed as 15 minutes, and we all know it takes an hour. So I think maybe we need to make a change. But let me start the next session. I want to introduce Professor Vijay Chandru. Vijay is a wonderful friend and one of the most extraordinary people in India who, let me just actually read his formal introduction rather than give you my impression, because it's not as important. Vijay has served on the Faculty of Engineering at Purdue University, and he's now with the interdisciplinary research in digital health at the Indian Institute of Science, where, by the way, he has hosted us more than once as part of this work. An elected fellow of both the Indian Academy of Sciences and Engineering. He's also a distinguished alumnus of BITS Pilani and the MIT India program. He's the one of the inventors of the Simputer. And for those of you who don't know it, don't look it up now, but your life will be much richer if at the end of the day you look up the Simputer. He's a founder of Strand Life Sciences, India's leading precision medicine solutions company, which he led as executive chairman from its inception in 2000 till his retirement from it in 2018. He's a technology pioneer at the World Economic Forum and has been there since 2006. He served with the IAC of WEF on the future of healthcare from 2014 to 2016. And in his work at the Center for Health Equity and Transparency and Opford Foundation, Vijay Chandru has been committed to orphan diseases outreach with scalable platforms towards the vision of no disease orphan by 2030. Vijay Chandru.
Thank you so much, Hitesh, for this very generous introduction. I think, we just want to launch in to the topic, and we have an extraordinary panel. So, I'd like to give them as much time as possible. I'm going to just reflect on this particular reform that is in the report, which is on technology, essentially. And I would like to acknowledge that I'm the co-chair of this particular technology work stream in the Commission. Sharad Sharma is unfortunately unable to be with us today due to health reasons, but he and I worked closely together on this. Right? So, so the topic is invest in and scale up diverse technologies to catalyze universal healthcare. The convergence of advances in biotechnology, AI, and digital public infrastructure, I think Vikram alluded to it, in his introductory address. The fact that we were able to face the pandemic with the capacity to manufacture vaccines for the world, and for the extraordinary digital platform, convenes, that was alluded to, which actually allowed us to coordinate the logistics involved in vaccinating 1 billion people, right? Which all came together in some sense, just around the time that we were starting to work on the commission. So, so this actually represents a historic opportunity to realize universal healthcare, relying almost entirely on domestic resources. And I think this sovereignty issue I will bring up later in the panel as well, hopefully. So the deployment of digital technologies is actually goes across many of the reforms and that have been proposed in the report, and various aspects of integration or convergence or whatever phrases are used, I think, are facilitated by technological platforms. And I think, we heard about some of the challenges within the national health authorities, frameworks and integration and so on. And this is going to get so much easier with agentic systems, being able to build wrappers around APIs and integrate data in a very efficient way. And deployment of advanced technologies, artificial intelligence, genomics, and all of this came into play during the pandemic, right? We actually saw, extraordinary innovations happening, in the sense that we were able to track the variants of the SARS-CoV-2 virus, be able to, advise state authorities on what was coming, right? And finally, digital platforms for integrated delivery systems to facilitate payment and the various play between payers and providers and citizens, because there's also citizen engagement involved. So in some sense, the reform to invest in and scale to catalyze technologies, to have technologies catalyze universal healthcare was a clearly an important work stream within the commission. And I think while the digital platform idea we've already talked about, the health technologies, we also paid a lot of attention, and as Karthik pointed out, it was both on efficiency and equity. And so from the point of view of making sure that the health technologies were also oriented for equitable and inclusive access. And most importantly, I guess, with health data, the privacy issues. Fortunately, by now, we already have the Data Protection Act in play. So DPDP is now officially an act, and for data privacy and protection. And the widespread use of technologies, digital technologies and AI will, of course, have to have lots of guardrails. And as we go forward, I think we'll have to keep track and raise the concerns around privacy, security, and monetization. And finally, the country is very excited about innovation, right? And I think as part of the Viksit Bharat sort of perspectives, it's very clear that deep tech innovation, which is oriented towards prevention, diagnosis, and citizen-centered care, are seeing investments both by the state and by private equity and venture capital through incubators and research institutions. And these transformative tools are certainly are being developed, and their momentum will be seen as we approach 2030. The impact will be seen, I think. Just wanted to throw up these images, don't expect you to actually read them, but I wanted to point out that one of the extraordinary aspects in this report are the studies that were done, the 50,000 citizen survey, which actually pointed out that over 60% of the citizens actually want technology, right? They're actually asking for technology. And 20% are also asking for help, for technology-driven help towards treatment and being able to interact with the health system. And surely some of this is the effect of the pandemic, and the fact that their access was sometimes driven largely by technology. And the other very important little study that was done by St. John's Research Institute, Harvard, and the National Health Authority on digital needs actually went to different stakeholders. So, providers, physicians, nurses, health workers, and citizens, and actually got various perspectives on how these stakeholders view the use of digital technology. So all of this is built into the report, and so this was just to draw your attention to that. Similarly, in the report, we have some very nice graphics. You should, again, you can't read this, but there's a whole collection of components of building a whole digital ecosystem. There are also these graphical representations of patient journeys in what we might think of as a reimagined primary healthcare center. And so here you see an empowered ASHA worker whose skill levels have been enhanced. And I think Nachiket often, we talk about the Trinity effect, right? The Trinity effect is, if you recall from the Matrix, Trinity has to operate a helicopter and she just gets a download and she says, yeah, I'm ready to go, right? So can we do this for our ASHA workers? Why not? I mean, today with the power of, communication, media, messaging, and of course, naturally, language technologies all involved. This is sort of the next generation. And this is where, to Karthik's question, I think we need to do pilots to make sure that this idea works. And we will. I think that's the intent. The key strategies are represented. I should be winding up now. Obviously, we need to invest more in interoperable, user-friendly digital health systems. We need to support primary care providers, and to make the Trinity effect real, we have to have sustained investments in digital skilling and build the digital literacy. It's a generational thing. I think the younger health workers are already quite comfortable. I think we will need to make sure that this goes across. And then, of course, Health Tech Innovation Fund as a public-private focus towards, and we're already seeing some of that with ANRF, RDI, various initiatives where public and private funding are coming together, and so that we can have digital innovations at a sustained and scaled impact level, right? And some of the key barriers, federated health data exchanges for interoperability, longitudinal medical records was what physicians asked for. Administrators wanted ease of operations with digital technologies. Providers and patients wanted better clinical care access, and community health workers wanted more point of care devices that they could actually leverage. Regulatory bodies need certainly to I guess, pull up their boots a bit. I think as we have a lot of momentum with ICMR, CDSCO, and health technology assessments at DHR, but we'll need to have expedited pathways for evaluating and approving affordable homegrown technologies. And this will also, we have to address the quality issue, and I think in technology as well. And I think that's where the regulators will have to play a role, and ensuring that sovereign innovations designed for Indian conditions can advance equity and citizen-centered care. So that's basically what we had for as a quick summary of what was in that reform section. We'll move into the panel now, and I think they have slides on the panelists. So this was just to flash this slide. I just want to mention that unfortunately, Kiran Gopalvaska was called on some ECI duty and is out of town. So we have 4 eminent panelists, and can we now move into the panel discussions? So, can I invite Dr. V.K. Saraswat, Dr. Kush Parmar, Sunita Nadamuni, and Gaurav Agarwal. Okay. So I think since we have Dr. Saraswat here, and he's, of course, an honorable member of the National Institute for the Transformation of India. When I think about transformation, it always seems to me that there are three requirements to drive transformation. There's an urgent necessity, a real capability, and infrastructure in place. I think these converge in India, right? And transformation could actually begin here. And I think that's a theme that, I would request Dr. Saraswat to elaborate on, and in particular about what you see as the national focus on investments for deep tech innovation. I mentioned ANRF and RDI, but of course, the Atal Innovation Mission and Chintan was here, I think, this morning. ICMR, DBT, all of these institutional funds are in play. And of course, we'll also have Kush talk about private equity, and Sunita tell us about how private philanthropy has played into this. And the other thing, Dr. Saraswat, before handing off to you, is how are we thinking about sovereign technology perspectives in the context of health technologies, but also in the context of the new geopolitical order? Because I do think it's a time when we need to think about sovereign technology. So over to you. Thank you.
Thank you, Dr. Chandru. This is a very interesting panel where there is a rocket scientist sitting among the expert health talking about universal health care. So that's the anomaly we have. But all the same, I will try to do some justice to the subject. Friends, since yesterday, we were in our academic council where Dr. Vikram gave us some idea about what this Lancet report is. And we had some discussion as far as the issues. When I just saw the recommendations, I think most of them cover the kind of issues which we have been debating in NITI Aayog for the few years now on the healthcare. All of us know that healthcare challenges today are multiple because of the rising disease burden which is there today, because of the demographic transitions what we have today, because of the geographical inequities which exist today, and on top of that, out of pocket expenditure, as we call it, or the escalating cost of healthcare, which is important. So as a technologist, I certainly concur that technology gives solution to many of the problems. But technology should remain invisible. It's only not the face of technology, but the use of technology that will ensure that you have what we call as the expendable access, improves quality, reduce costs, and strengthen the resilience. These are some of the things. So it's like an enabler. And as for the country is concerned, technology has been identified as an enabler, not only in the health sector, but everywhere. Specifically, working through the innovation cycle in every sector, whether it is health or agriculture or medicine or manufacturing, we find that it has played a role. So to that extent, from the healthcare, when we realized India announced many programs, and all of you know that I think the survey has already indicated what all is being done. The telemedicine program, the advanced telemedicine program, and all the software packages which emerged during the pandemic, and the kind of impact that have made us Paushadi and things like that. All of them are really making some impact. But I would like to mention that what technology can do, healthcare should not take the technology to the level that healthcare becomes faceless. In fact, I was attending one seminar. So people were saying the doctors won't be there in the hospital. It will be the robots and the robotic machines which will be running the hospital. So I was the first one who said, sorry, friend, I don't subscribe to what is called faceless health. If you have faceless healthcare, that it will. No, the robot is the face. I said, the artificial intelligence, even if it goes to the generative level, will not be able to bring what are the emotions what we are talking of. And healthcare certainly deals with the emotions. So while we are all into the domain of technology enabler, I think we need to go for what is called the people-centric, man-centric healthcare system. Only thing is we can make the technology to improve the efficiency and bring what is called the various other aspects which are inefficient today because of the lack of technology. For example, health records, or for example, the telemedicine and virtual care to enhance the reach and things like that. But whenever you have a technology landscape, the most important thing is the enablers for the technology are also very important. For example, if I want telemedicine to reach to the remotest corner of my country, the broadband facilities have to come. Second thing is the cost. Point of care devices. We all talk of even in this, the recommendation is there, we have a point of care device. Now this point of care device has to be affordable. The other day, I myself was undergoing physiotherapy for my shoulder. I want to mention too. When I went to the physiotherapist, the IFT equipment imported in India costing about 8 lakhs rupees. And then when it came down to a physiotherapist coming to my home, she brought a device which is Indian done, and it was costing only 30,000 or 40,000, which has 4 features: IFT, ultrasound, and some few others. Then I said, what is the difference? So I went to the details. It's an Indian device, but it has, and they claim that it has got some 5 software-driven cycles for proving IFT. When he ran it on my body, all the 4, it had the same effect. So the quality of the device which is being produced has to be very important. In the name of affordability, compromising quality is also a problem, because then it is quantity and quality is compromised. So that is as far as the devices are concerned, point of care devices, affordability. Innovation should lead to that kind of a thing. For that, Government of India started, I was just mentioning to him that, Mr. Kumar, that we have a Bio-E3 program, which main purpose is basically to have quality healthcare systems based on biological innovations which has to be done. We have programs on devices, pharmaceutical, the healthcare devices manufacturing. We have program on cyber physical systems for healthcare, which are all required to be giving devices for that. So that is as far as the innovation cycle is concerned. And I think they are leading to great results. The point is, every innovation cycle needs to be supported. I have my friend Tarun Khanna sitting here, who started the Atal Innovation System along with all of us in Niti Aayog. It has really taken the innovation to a level that it has reached the schools and colleges. But then it comes down to real commercialization of that innovation. It is still much to be desired because the investment there. So invest in, as is the topic today, is very important, both in terms of infrastructure for healthcare, in the innovation system, and also in skilling of the people. Because Dr. Chandru mentioned about the Trinity. After all, the same ASHA worker, I mentioned that yesterday, is supposed to provide food to the children in the school, supposed to go to the house to get the health records of a pregnant mother, is supposed to go for many other, and the same person is going to go for point of care. I mean, this is going to be a huge task for a person for the kind of skills she or he will need. What is important here is a very invested program in which people are trained in multilateral skills in that. So this is in terms of skilling investment, in terms of manufacturing and design of equipment investment, in terms of doing that. And most important part in all this, because innovation requires freedom to work. And this is one sector where I find the regulatory processes in India are very, that was one of the points which you have mentioned. I have been fighting from Niti Aayog all along to, you said they have to pull up their boots. I want to say it requires a tremendous outlook change as far as the regulation is concerned. Regulation has been made a bureaucratic process. It has not been made an intelligent process which requires the inputs to control the quality. But it has become purely a bureaucratic process which has to do some paperwork to satisfy the need what is written in the document. That's not regulation. So I think we need to really look at CDSCO. We have to look at some of the other regulatory bodies. You said health, HTA and things like that. I think we have to do something about it to make sure that it happens. And finally, I would say that the three-tiered healthcare system in the country, particularly the primary healthcare, needs our maximum attention. Because if you look at that, is the one which brings about 60 to 70% of the burden. What care is being provided today through the public-private or pure private in the urban areas, in the peri-urban areas, I think is reasonably okay today if you take the survey. I don't know whether your survey has found that, but that is my perception. But when it comes down the penetration of healthcare into the rural areas, in the primary health centers, there's a shortage of doctors, there's a shortage of medicines, there's a shortage of broadband there's a shortage of unskilled there. So that is the one which needs a complete change. And we need to scale up some of the experiments which have been demonstrated by some of the major doctors in the country. I mentioned the name of Dr. Ban and his wife, Rani Ban. And there's one more couple in Maharashtra who in the Vidarbha region, by their own efforts and with the public participation, are in a position to run a very good public healthcare system. And it's a low-cost system where involvement of the population is there in taking care of the health. People who are tribal in nature, whose education levels are so poor, are in a position to actually play a role. So can that kind of a system be scaled up? Can the Lancet Commission report come out with this kind of some pilots which can be put in place in regions where certainly there's a vacuum? So I think this is what I would recommend. I fully endorse the recommendations of the Lancet Commission, but what we need is to elaborate the strategies for doing that. If we can do that in the subsequent efforts of our body, then I think it will make a lot of difference. Thank you very much.
Thank you so much, Dr. Saraswat. We will go around the panel now, and thank you so much. Right. So, Sunita, I'll come to you next. Your massive NCD study, 600 million now, is of 600 million citizens, done with private philanthropy from Dell, Tata Trust, and of course also in with the help of the Ministry of Health and So it was a private and public resources coming together and private philanthropy in particular. Please tell us about the study, the data, how this could move us towards evidence-driven strategies, how that's already being done, and also share your assessment of private philanthropy and the roles it could play in moving us towards universal healthcare.
Thank you, Vijay. So it's a pleasure to be here. So first of all, I'll start off with the National NCD program, the portal that we developed. It's called the National NCD portal. it was never really meant to be a technology project, right? It was the national NCD program was being implemented, and it was a health system strengthening project to develop the technology platform that could help run it, right? And the intent was to be able to, through this program, very unique program for those who don't know, it was basically to screen, treat, and manage non-communicable diseases, 5 non-communicable diseases, in every individual over the age of 30 across the country. So that's why these huge numbers come, right? Because it's population level screening. And it's very different because it's different from the episodic kind of care, right? Or, things which are time bound, like pregnancy or, even other communicable diseases. So this was the program that the government was running, and they needed a technology platform to help, manage this. And that's where we came in with Tata Trust to develop it. When we started this, there was an objective. The design of the technology system was to do 4 things. We basically said, how can technology help improve the productivity of the care providers? How can it reduce the burden on the health workers? Because these million plus will now have to do door to door. They have to do screening of every individual over the age of 30. How can it bring about continuity of care? Because unlike, again, episodic care, chronic disease management requires month after month follow-up, and it requires follow-up at higher levels of care, then follow-up back down at the lower levels of care. So it required a lot of continuity of care. And finally, how can you help the decision makers, at all levels, including at the care provision level, at the district, state level? How do you help them move towards more evidence-based decision making? So that was the design of the system. And now this kind of technology, when it works well, like somebody else was saying, it should be invisible, right? It should just really enable the system to do what they need to do. Where are we today? After it's been running for about 6-7 years now. So the number of people enrolled and screened is very large, 600 or something million. This happened pre-ABDM. Now ABHA seeding is happening and getting more health IDs, which makes it much stronger. And the number of people screened, I think, is like at 200 million or something. But what happens is that the challenges, and I'll talk about some of where the gaps are. The number of people who are being followed up, and most importantly, who have their NCDs under control, BP under control, diabetes under control, those numbers are significantly smaller, right? So what are these gaps in this technology system? And this is not just about NCD now, I'm expanding it to talk about other vertical programs. So one is the actual primary care follow-up itself, right? And people have referred to this in the previous panel too, about the availability of staff, the availability of medicines, the availability, just the burden that the primary care is, has to bear. So, and this is not uniform. So you have, it's obviously changes across the country. So that's a problem. The fragmented care pathways, especially with, programs like this, where you have to go across multiple levels, and all these vertical programs that you have, RCH, TB, NCD, all these different vertical programs have their own IT systems. I know this topic also came up, this point was raised that, oh, these things, they don't talk to each other. Let me assure you, it's not because of lack of intent. When we first started working with the ministry as a CSR partner, the goal was always to say it has to be CPHC, comprehensive primary health care, right? That was the explicit goal. In fact, it was not called NCD, it was called CPHC NCD, right? And saying that this is the intent, and even with the complete push of everybody in the ministry from the highest level up, and with all of us putting our effort, granted this was all, CSR voluntary effort, we weren't able to do it. It's a very, very complex problem to take entrenched vertical systems that have been running for decades and then say, let's integrate it. And this was pre-ABDM. Even with ABDM, it's not a simple, and it's not a light lift to just say, oh, now you can talk to each other, right? So I'm saying that this is a very worthy goal, but it's a lot more complex than, I think that is being made out. And frontline workers, of course, being overburdened, the 52 registers that people talked about, and even if they have vertical systems, they don't have a unified interface, so they end up using multiple ones, and it's all the challenges on the ground. You're trying to design systems that will work in local language, that will work offline, that will be resilient when things go down and then come back up again. These are very complex, programs, and people don't follow a set protocol, right? If the operational guidelines of the program say you will get screened here, then you referred, you go to the PHC, and then if there's something, you go to the CHC, you come back to the PHC. Nobody follows that. They say, oh, this district hospital, I know the doctor there, I'm going to go there. Or medicines are available here in the private thing, so they go there. And then the health worker, then there's a loss of continuum, loss to follow up, because you don't know what happened after that, right? This is the reality. Nobody's going to follow this exact guideline. So, and all this data and dashboards that come out, are people actually using all of that? First of all, the data is not shared with everybody, even outside the department, right? So that data is locked in, but even within the department at the state, district level, it's very uneven. Some people have used it aggressively for campaigns, and you could actually see how they've used those and been able to push on a daily basis how the program keeps progressing. When they did a campaign for screening, they did a campaign for health ID. But in other places, this dashboard, you go after like a year and people still don't know the user ID password, right? It's not used at all. So it's all very mixed. So the technology that we need to build now needs to do three things really well. We need to be able to leverage ABDM. We need to build that glue to really achieve comprehensive primary healthcare. Everybody talks about it. We know the importance. We absolutely need to make that happen. We need to anchor continuity of care across levels, across programs, right? And so that, and this includes giving the health worker one unified task list so that the same ASHA is not going to the same house multiple times for different programs, right? One unified task list, one unified set of enrollments, and then have one view of the patient. So if this pregnant woman who's suspected of TB also has hypertension, it is visible to the people who are providing care. And this technology can do, but it requires a lot of effort. You have to, the platform should support prevention. So we shouldn't be looking at just transactions, or volumes. We should be looking at outcomes. We should be looking at, identifying risk early, supporting behavior change. And then finally, we have to strengthen public stewardship, right? And public sector provisioning of primary healthcare, because these kinds of things of, early detection, risk screening, you have to cajole mothers to go in for like a breast cancer screening. It's not, it's not like people are demanding, I want this, and you give them a voucher and then they'll go and get that care. There's a lot of outreach that needs to happen, a lot of behavior change, a lot of follow-ups for this kind of longitudinal care. So, private philanthropy, yes, I think it does have an important role. It can provide the risk capital for this kind of innovation and iterations of, trying to come up with experiments of technology. You can develop public goods like we did, right? But it, it has to be done in partnership completely with government, and they have to take it over, because you can't run national programs with philanthropic capital, and as well as capacity building for adoption, for handholding, and making sure that adoption is the biggest gap, right? It's like a really huge gap. So this is where philanthropy can play a role. And one point I want to address with respect to the Commission's report is that, yes, it's rightly emphasizing digital public infrastructure, interoperability, and the potential of technology to integrate care. I think that what I think really needs to come in, and this is where I feel this point is missing, is that we have to place the center of gravity on strengthening the public health system first, right? We have to be using, before we open it up and integrate public, private, everybody, and then expect everyone to compete on that level playing ground, because the social determinants of health are huge, right? There's so many of these components, and then you're unfairly, and you're looking at how is that care being delivered, with all these other issues that the health sector is dealing with. So I think if we just leave it to the platform to say we're looking at scale and efficiencies and digital maturity, your public health systems are going to struggle, because that ASHA worker who's going to a remote area and just dealing with a small hamlet of 10, 15 people, that work is extremely important because they will get left out. But how will that show up on your, on the platform? So I think that if we first focus on technology for strengthening this public delivery of primary health care, including screening and preventive care, and really look at the many, many gaps like I've outlined. But if we really look at how do we invest in that? Because today, comprehensive primary healthcare is falling between vertical programs, and there's no champion. There's nobody who's looking at how do you actually make that happen? How do you integrate? How do you make all of these talk to each other? That has to be invested in. That has to be completed. Only then, I think that, it's the sequencing ordering, I feel. Yes, you need to do all of the others that are recommended, but first we need to focus on this.
Thank you so much. Thank you, Sunita, because I think it was very important to actually learn about a program that's actually been rolled out at that scale and its impact. So let me now switch to you, Kush. So you're both a physician and of course a private. Yeah. Oh, sorry. So Kush, you're both a physician and have been an investor in real cutting edge health innovation, of course, largely in North America. But would you like to share your perspectives on the opportunities for private investment in technology development that would address the kind of scale impact that we're looking for in India, and that are sort of cost plus rather than value based, models? Also, please feel free to share your incredible success with the CAR-T affordable therapy that now is actually having real impact in India. And so.
Vijay, thank you for having me. Is my microphone on? Can people hear me? Sure. And congratulations on this huge day to all the organizers, the commissioners, the authors of this incredibly powerful report. I have had the privilege of building over 150 biotechnology companies over a number of years across virtually every therapeutic area and technology category. And in part and largely due to my wife, I spent a lot of time in India and have a very strong passion for the potential that India has in biotechnology for the betterment of India and its people, and also the world as well, given innovations in India that are solutions for India inherently, I think, will be globally relevant solutions. I think one thing to remind ourselves about is the fact that, and I'll give an example here as well, is that of course, this is multidimensional. What this report is describing is many dimensions of a healthcare infrastructure to be able to be functioning at a level of a developed country at the 100th anniversary of India's formation and independence. And for that to be the case, we're speaking about many different segments of society, many different segments of the healthcare system. We just talked about primary healthcare as a huge gap. There's super specialized acute care as well that we can talk about. But one thing that we do need to understand is that to be at a developed nation, India is going to be the third largest economy in the world. And there is a degree of sovereignty that one has to consider. Because let's just imagine a future where the entire access issue has been solved and that ASHA worker is super powerful and super enhanced with AI and the expert knowledge of a neurosurgeon or a neuro-ophthalmologist, essentially. And that is what we will see. I think the barriers that we have, legacy barriers of specialization that healthcare has built over the years, I think some of those barriers will break down, not all of them, enabled by AI. But imagine that ASHA worker having an incredibly low cost, efficient camera that can look into the retina of someone and diagnose them with diabetic retinopathy. And then, she'll, ring up through her earpiece 1 mg and order the latest medicine to give to that patient. All the payment will happen behind the scenes. They'll know exactly who the patient is. The records are going to be, in the cloud, and it'll be all seamless. We have to remember that the medicine that will be available and cost accessible on 1mg's website and in your, storage facilities is likely going to be a medicine that was a standard of care 10 years ago in other parts of the developed world, right? So we have to think about holistically. I do think that there's massively low-hanging fruit that technology can enable to leapfrog. We all talk about the cell phone leapfrogging that India's seen. I think that's massive. I spent a lot of time in America in the healthcare system there. You would not want to invent a healthcare system from scratch if you had the technologies you have today. So I think India has that opportunity to leverage these technologies. And investing in those technologies, I will say, I think it's important for awareness. Technologies like that, the innovation cycle and the capital intensity is quite favorable. And India has a really robust technology and medical technology infrastructure, because fairly cheaply, this is all relative, fairly cheaply you can innovate, design, test something, and then get that on the market and prove something out, whether it's software or some of these technologies. The medicines, the intervention, the therapeutics, they're capital intensive, have very long lead times, and that requires, I think, a sovereign thinking, because we could solve every access issue. I think essential medicines essentially represent the standard of care medicines from 10 years ago, but that patient, let's just say, gets a medicine that's accessible because that medicine's gone off patent and therefore it's now accessible, give maybe that patient a bit of vision for the next 2 years before she goes blind. Whereas in the rest of the world, the medicine that is the standard of care could be giving her vision for 5-6 years, right? Think about Humira. It was a medicine that was developed and on the market in 2002 for rheumatoid arthritis. Game-changing for patients with rheumatoid arthritis. This is an antibody. Wasn't available as a biosimilar in India, I think, until 2016. 14 years as a country. Even if you could have diagnosed seamlessly and had the data of every single rheumatoid arthritis patient in India, those joints degenerated for 14 years before that medicine was made available as a biosimilar. So we need to think about that lag. It is a decade to 15 years before India has, in an inclusive way, access to these medicines, more broadly speaking. And as this report has said, healthcare cannot just be a privilege for the few and charity for the rest, right? It needs to be a more holistic, sustainable system. And look at what India has. India has proof points in vaccines that this is possible. We saw during the COVID pandemic as well. And I've had the privilege of actually being part of an effort to bring one of the most expensive medicines in the world called CAR-T medicines that can cure certain kinds of blood cancers. These are cost $500,000, say 5 crores of rupees in the US, and very expensive to make and to deliver. And we brought this technology to India to make it accessible for India. To some extent, it's a step in the direction. It's not fully accessible now, but it's at 1/10 of the cost. And from scratch, people returned from the UK, from the US for this kind of vision to bring high technology medicines, life-saving medicines to India and make them accessible to Indians. We built the manufacturing in Bangalore and worked with the regulators. It was a journey, I have to say, very complicated scientifically to understand as the regulators what these medicines are. Ran the trial in India with fantastic physicians, patients that enrolled in the trials, and made a product that is at the world-class standards in terms of 90% or so cure rates in these cancers, and is now commercializing and also reimbursed, by the way, by certain Indian government institutions and the army now reimburse and talk about the financial model, and could be a profitable enterprise by next year. I mean, really cutting edge medicine, bringing down the cost around 80–90%, and that's just a step in the journey. And these are complicated medicines. So what do we have? India has phenomenal physicians. These investments in technology will be huge in enabling clinical trials in India with quality data. We have the pride of India's industry. One of its prides is the generics industry. We know how to make medicines, okay? We have an incredible diaspora. India needs to innovate. We need to bring the 15 years down to a few years or zero, I think. And that is what China is doing right now. I think India has huge potential, and it needs to be prioritized at the central regulatory level as well, because it's a regulatory regime that's been built for generics industry and needs to evolve towards an innovation-driven regime.
Thank you so much, Push. That was great. Actually, you gave a lead-in to Gaurav. So Gaurav, your impact with 1mg as a care delivery platform, has been impressive, both in the scale and the speed at which this has come about. And clearly, technology has played an important role. So tell us the story.
Yeah, thank you. First of all, thank you for having me. Congratulations on the report. I think this is the first time that I've actually gone through 70 pages of any report. It's actually very, very well written. And I think that, I've also managed to go through because I just kept getting pulled back in because the suggestions are very timely. I think they're very, very concrete. It's something that, we've spent a better, more than a decade actually trying to imagine, conceptualize, and build. And I'll pick off of Dr. Saraswat's first comment that he's a rocket scientist. I have nothing to do with healthcare. I'm a technologist, studied computer science, worked in data and consumer internet, and then came back to India thinking that, if technology can make an impact, it's not the Bay Area, it's actually in India. And, from 2014 onwards, my co-founder and I, we've tried to build a healthcare company which brings the fundamental premise of technology bettering healthcare for consumers. Today, before I start, just to give you a sense of what 1mg does. When we started, we thought we would build an infrastructure-less healthcare company. We will ride off of pharmacies and hospitals and diagnostic labs and provide healthcare services to millions. Unfortunately, that vision came to fruition, but in a very different way, because we found that the fundamental missing layer in the infrastructure was actually quality and experience. When you go to on-ground healthcare infrastructure in India, in most of the outpatient care instances, you find quality, experience, customer empathy, if not missing, deficient. And that was not how we wanted to deliver care. So what 1mg ended up having to do was we built our own supply chain infrastructure where today, and just to give you a sense of the scale, 1mg services around 2 million consumers every month. We have our own infrastructure to actually buy directly from pharmaceutical companies. We have built our own technology infrastructure to ensure direct track and trace of medicines all the way from pharmaceutical warehouses to, let's say, when they get delivered to a consumer's home, providing consumers even trackability of those medications and where they came, what temperature they were stored at. India has thousands and thousands of warehouses where medicines need to be stored at a certain temperature, but you don't know if they are being stored at that temperature. And this is just reality. It's not something cold chain, right? So that was first part. Now, how do you get them delivered? It's only now that we're starting to get rails of what we call delivery in India. When Amazon started, they were able to use USPS to do delivery in the US. We've had to build our own delivery infrastructure as well. Today, 1mg does, again, 2.5 million deliveries. Half of them come from our own stack with our own riders, etc. We went to diagnostics. We built our own diagnostic labs because we again found that regulation, again, picking up Dr. Saraswat's was comment was, is not mandatory, right? You can open a diagnostic labs in India, and it does not have to be an NABL certified lab, which means that you don't know what control processes a lab is following to actually give you a report. And we have millions upon millions of people actually getting reports from non-NABL certified diagnostic labs in the country. So we started, we said, okay, this is not the way we wanted to deliver care. And we started to do our own diagnostic labs, started to do our own infrastructure. Today, 1mg does around 3.5, 4 million diagnostic orders every year. We follow the full supply chain end to end, where we have our own riders, they have temperature controlled boxes. These are, IoT enabled devices. They go collect samples from home. There's a trackability. You can again track and trace. Third point is, okay, we collect all this data, and eventually we didn't want to build a commerce platform. When we started, and if I could show you the original vision of 1mg, our vision was that data can lead to better healthcare outcomes, and how do we get there? But we started and we realized how naive we were because there is no data, right? There's no data, there's no standardization in the ecosystem. Everyone walks around carrying this large pile of records written on paper by doctors, hard to read handwriting. Like what the hell do you do with this? So we said, okay, what can we do today? We said we can do transactions. And over the years then, 1mg as a private player basically committed to building a standards-based digital record system. Okay, today we have digital records for over 20 million patients. We are talking about longitudinal health records. We have longitudinal health records going back 2 years for over 5 million consumers. And we are starting to build, again, what is being recommended in the report, an IDS, and an orchestrator, a coordinator of sorts, which basically takes a look at all of your data put together and says, what do you need to do now? So this is what 1mg has done, and are we there where we want to be? No, we are far, far away, because we are only delivering this sort of thing for 2 million consumers. And we have a large, hill to climb if we want this infrastructure to be available to millions of people. So, coming back to my comments on the report, I think UHC is an absolute must. But I feel that what we need to do, and if I can recommend one thing, I think the government cannot shy away from outpatient care. And if I can say that here as a citizen rather than as a private industry participant, etc., I think we have shied away from outpatient care. If you look at insurance in India, it's an inpatient insurance service. Many years ago, we made this proposal that Ayushman Bharat present, it's a beautiful opportunity to actually provide outpatient care as a benefit to a large proportion of consumers. Instead, Ayushman Bharat also has focused only on inpatient care. If you look at telemedicine, across the world, telemedicine has worked. It hasn't worked in India. Why has it not worked? Because there is no financial incentive to make large-scale telemedicine available. eSanjeevani is one where it has worked. But many years back, we had this proposal that why can't Ayushman Bharat start with actually providing telemedicine or a teleconsult as a benefit to every member of the population? And we don't have to go far to look at instances where the government has had the right ideas and gotten them to work. Aadhaar, DigiLocker, UPI are great success stories. And if I could go back to why they work, I think the reason they worked was because they were fundamentally tied to incentives. If you look at UPI, fundamental payments, the banking stack, the unbanked ability for someone to get money, get it into accounts, get loans, etc., was a fundamental incentive. And I think the biggest challenge we face with UHC is that there is no incentive. Who is incentivized to get people healthy? People are incentivized to get people to hospitals because you make money off of surgeries. But how are you incentivized to actually get someone to a doctor so that they can take better care of their health? And there is no incentive structure for that today. I think if you, again, look at the world, ACOs, value-based cares, etc., have provided mechanisms, or at least examples for how that can happen. And that would be my biggest recommendation, is that can we provide an incentive for UHC? I also feel, contrary to Sunita's comment, I felt the commission actually took a very public first stance rather than a private first stance. And, it's amazing how, two of us can read the same report and come back with very, I think that there's tremendous amount of work that the private infrastructure in India or private companies in India have done, because we are fundamentally incentivized to innovate. We are fundamentally incentivized to reduce cost, improve efficiency, utilization, etc. And I think it would be a travesty to not make use, if we look at the government as an efficient spender of resources, it will be a travesty not to use what we have built to actually provide better care to our citizens. And lastly, I feel, I'll give you an example. Many years back, when I was in the Bay Area, a friend of mine needed to get an IVF done. And I don't know if it still exists, but the US had mandated this public registry of IVF success rates, etc. So you could go look that up and you could see, by clinic, by different types of interventions, what were the success rates, and you could find a provider. And I honestly think, again, going back to Dr. Saraswat's comments, which were very, very insightful, that, regulation has to take a different approach, right? And why can't the government be a conscience keeper, getting us to report quality of care and outcome of care data, and giving citizens a right to choose based on what quality is being delivered, right? It's complex, it's tough, but I think it can be done. So, I hope we can do public and private together. We can use technology as a fundamental enabler, and we can get better healthcare for all of India. Thank you.
Right. Thank you so much. And actually, I'd like to thank all the panelists for outstanding delivery. I think it's time for lunch. If you let me just 1 minute, I'd like to end with a small. Sure.
Before you close, I thought he is going to cover that. The one part, because you mentioned in your introduction that he's going to talk about finances, and he also talked about major focus has been one on public. I think it's a blend.
Right.
Financing, because we are talking about investing. If we have to invest in, there are two elements of investing. One is the innovation investment, and is the logistics investment. The third one is the manufacturing investment. In all cases, we have to find various methods,
Right.
whether it's blended financing or mission-oriented operation. For example, if I want to have a mission like TB eradication, can it not be launched as a mission-oriented innovation program,
Right.
in which public-private partnership can be
So
done?
there's
If we-
actually a whole panel.
Okay,
dedicated
you are
to-
going to
we're
discuss
going
that,
to
but I
discuss
think it's a
that.
very important part, and I request you to give
Sure.
a major focus on it.
Sure.
Thank you.
Thank you. So just to end, maybe I think healthcare was built brilliantly a century back, but systems that have evolved to treating illness are resistant to transformation, right? And that actually cultivates health, not from malice, but from architecture. So I think the whole emphasis that I hope we will take forward now is how to architect systems that can actually cultivate health and blend, both the treatment of illness and the cultivation of health. Thank you.
Thank you for being here. As you've seen, I started out by saying it's an extraordinary day and a day of celebration for something large. And I think what you've heard so far stands as proof. And I think we have a lot more of amazing ideas, thoughts, and conversations to come. Nachiket, I'm going to introduce you briefly, if you don't mind. So for the next session, it will be led by Dr. Nachiket Moore. Nachiket has a PhD in economics from the University of Pennsylvania. His work is focused on the design of national and regional health systems. He's a visiting scientist at the Banyan Academy of Leadership in Mental Health and a visiting professor at the Indian School of Business. Nachiket has been a very reliable, very thoughtful, very data and evidence-oriented partner throughout these years. And we really appreciate it. Nachiket, please take it away. Thank you.
Thank you. Thank you very much for that lovely introduction. And I'm pleased to talk to you about, I noticed that this theme kept coming up through the day about the private sector, even though, as was pointed out by, as it turns out, a private sector person, Gaurav, that the report essentially focuses on the public sector as the principal provider of healthcare services, tax financing used by the public sector to deliver public health as a universal health coverage provider. But clearly, there is an issue that we all recognize and acknowledge that there is a private sector. But just to make sure that I re-emphasize what we are saying, that the public sector has the potential and the resources, something that might not have come out as clearly in the morning. Our research shows that financial resources of the public sector, given even current tax envelopes, are adequate to deliver universal health coverage. 13 states already spend more money from the government to deliver UHC. There are several states that need support, but the resources are not such an issue. And we think that that's an important thing to just re-emphasize. But there will inevitably be a demand for services that are not cost effective for the public sector to provide. There will be need for supplementary covers that the public sector may not be able to provide. Provision of these services using the current fee-for-service and indemnity insurance approaches, which are the dominant, we spoke about out-of-pocket, which is effectively the fee-for-service type work. We spoke about insurance, but insurance design, we have borrowed effectively from 1960s America, which is indemnity insurance. And these two offered by fragmented providers, the evidence is pretty clear that it leads to poor health outcomes and does not provide very good financial protection. We also know from the Indian experience that indemnity health insurance, there is very poor take-up of standalone product. Only 5% of Indians buy contributory voluntary health insurance on their own as a standalone product. And this number in the last decade has not changed. It has remained static. You might see aggregate premiums have gone up, but that's because prices have gone up, not the numbers of people. But there is an additional problem that the current approach will result in excess demand for hospital services, as we see, and many people pointed out in the morning. There is very nice work by Bill Shao, which shows that these approaches produce high rates of inflation because there is no natural, it's a Mark Pauli point that if you have a product that is free at the point of delivery, there will be excess demand. And if there is excess demand and there is no supply curve, prices will rise. And you see that in America, you certainly see that in India. But the additional problem is this will produce an excess demand for specialists in the private sector and therefore a shortage of these specialists in the public sector. Just to give you an example of a space in which I do my work, obstetrics, there are 30,000 obstetricians on record in India. Only 3,000 of them are in the public sector. Public sector delivers 70% of Indian babies. So 3,000 obstetricians deliver 70% of the babies, 2,700 deliver 30% of the babies. So, but this is because there is excess demand for C-sections, etc., in the private sector that the obstetricians are busy. So it could threaten our original goal of getting to UHC in the public sector, because without specialists, without, Siddesh is here, he's been telling us about the importance of surgical care. If you don't have the capacity to deliver surgical care, you will not be able to offer UHC. What are our principal reforms? There are two. One is stewarding of the private sector, because as I said earlier, the current approaches, which are fee-for-service or indemnity insurance based, are not the direction that one goes. Just from a first principles economics, healthcare markets and health insurance markets on a standalone basis are not well-functioning markets, because there is deep information asymmetry. What you find, if you allow people to buy healthcare and be consumer-oriented and allow free choice, countries like Japan, for example, discovered that they consume MRIs at a rate 6 to 7 times higher than the UK. Why? Because the consumer is making a decision. I got a headache, I need to get an MRI. Right? And the system enables that. A rich country like Japan may be able to afford this kind of movement. We certainly can't. But it does not actually produce the outcomes that we need. What we need are integrated healthcare principles which bring many of these services together to produce non-inflationary care together. So insurance and healthcare need to be combined into a product, and multiple such providers need to compete with each other. For those of us that are aware of the US Kaiser Permanente, we think that is the example that certainly from the American side looks like one. But really the full exposition of this has happened more in Europe. Why Europe? Because Europe has used, as some people pointed out, the private sector principally as a provider and not the public sector, which is why you see these examples coming from these countries. But you see this also in Colombia, you see this to a degree in Brazil, both developing countries, and Israel, for example, has run its entire health system using this kind of approach. This approach automatically prioritizes disease prevention, because now the hospital has no incentive to deliver stents that patients don't need, amputations that patients don't need, or hysterectomies that patients don't need. There is no extra money that the hospital is going to get. It only gets planned revenue that it then has to make do with all of this work. And which is why it produces an incentive that's consistent with best practice healthcare rather than excessive provision. Second, clearly the other side of the coin is voluntary insurance. What are we to do with it? We think that the insurance mechanism, in addition to being allowed, today there is asymmetry. A hospital can enter insurance, and you will hear some examples of it, but a insurer cannot enter healthcare by law. Clearly, this asymmetry has to be taken out. If you see many of the M&As that has happened in the healthcare sector, you find insurers buying up primary care practices, because insurance and primary care are natural friends. Both are interested in keeping people well, because that's how the insurer makes money. The more people show up at hospitals, the less the product is. So there's clearly, voluntary health insurance has to be used to pool and prepay some of this money, but doing it via the provision of primary care will be far more effective. And to facilitate this, regulatory hurdles in insurance legislation should be removed or softened, in line with global practice. Just to give you an example, Mirai chaired a committee of which I was a member. We looked at global usage of capital. It turns out that France, the complex, expensive country that it is, requires 15 crores to set up an insurance company. India requires 100 crores minimum. And if you count pre-op losses, 200, 250 crores is the amount of money needed. Right? There is no reason why we should be asking for this excessive amount of money to set up an insurance company when other examples around the world are running fairly safe, high-quality health systems with far lower entry barriers. What are the strategies recommended? As I mentioned to you earlier, market design in which insurers and providers compete in separate markets. So you buy insurance separately and then you buy healthcare separately is a bad design. It produces what we will call an incomplete market because of information asymmetry. And the rules, when we say markets will decide, they come from this Adam Smith notion, first welfare theorem. It does not apply. When you go to buy toothpaste in a supermarket, you know what you're looking for. So which is why price-based competition makes sense. When you go to a hospital to seek healthcare, you don't know what you're looking for. And that enormous difference produces the failure of the first welfare theorem, which won't work. We argue that bringing the two together, now you're telling customers to buy wellness services. You're not telling them to buy C-sections or cancer surgery or this or that. We think customers are much better positioned to handle this. What is the process? Again, the reality is that most countries, even the US, which started out with indemnity insurance as the dominant part of their markets, have now gradually shifted away from these kind of situations in which members pay a monthly or an annual premium, and they get, after that, all care, medicines, diagnostics, surgery, primary care is all included in that. And you can see why the incentive now shifts for the provider from providing excessive care to keeping people well. What is the key barrier to be addressed? I mentioned earlier, healthcare providers are already permitted to own insurance companies. The reverse is not happening. That's something that needs to be taken care of. The Mirai Chatterjee Committee recommended that we should move the minimum insurance capital requirement from 100 crores to 20 crores, which is still well above what the French require. But we thought it's a good number to look at. cooperative institutions should be permitted to operate as licensed insurers. My understanding, but Mira is going to reconfirm that, is that this has already happened in the latest version of the Act. And the other important thing, which again would sound a little bit strange to people coming in from outside India, insurers are permitted to reject people on the basis of pre-existing disease. If you have diabetes, if you have hypertension, if you've had a history of cancer, you cannot get insured in this country because insurance companies can tell you, sorry, our underwriting process suggests that you're not eligible for insurance. Most countries make that exact action illegal. You must take everybody into the pool. And how do they manage adverse selection? Through what they call risk equalization. Insurance companies that end up with more risky customers end up receiving payments from de facto companies that end up with less risky customers through an exchange risk equalization process run via some form of reinsurance mechanism. So this is our context. I want to now invite my panelists to join me on the podium. Dr. Viren Shetty, if I can request you to join Bindu, Sanjay, and I don't know if Alok is here. I don't see his body if he's, yeah, fantastic. Thank you. Thank you. Can we put a placard for him? Not that he needs any introduction, but certainly. So thank you all for joining me. And what I will do is I will introduce each panelist as they begin to speak. My first request is to Viren to begin the, can you put his introduction back on the slide, please? The question to you, Viren, you are a leader of one of the largest hospital systems in the country, the Narayana Health System. What is your view on how we have analyzed the problem of the private sector and the direction we think that the sector should go in order to address the concerns? And then as you speak, I also want to talk about, to request you to talk about the innovative work that Narayana is doing to reshape the health system that it itself is planning to do. And if you can include that in your remarks.
Thanks, Nachiket. One of the things I'm most appreciative of is in the report, it stresses a lot on how the private sector is part of the solution. Anyone who spends too much time online would draw a very different conclusion on what the role of the private sector in delivering healthcare would be. Now, a fee-for-service model funded entirely through taxpayer receipts cannot sustain. It hasn't sustained in the largest economy in the world. It is a dangerous path for this country to go down. Yet, this is the model that the private sector operates under. It doesn't mean it cannot. The model that was suggested, which is running integrated healthcare systems where the provider and the payer are one and the same, are the simplest way to align the provision of healthcare with the means to pay for it. The person who wants an MRI every week for their recurrent headache would be paying a very different subscription rate, if you want to call it, for his or her healthcare plan than the person who just needs catastrophic healthcare. These systems do exist across every other mode of service delivery, whether it is airline miles, whether it is entertainment on our subscription apps, whether it is housing, or even the affordability of very large ticket items such as home loans and car loans, which are financialized into a series of recurring payments. Healthcare affordability becomes an issue because most people in India's healthcare payments start out as a number that trends zero and has one massive lumpy spike once and another lumpy spike towards the end of their career. No one should be expected to pay that. Once you turn it into a steady stream of payments, you are able to make it more affordable to the customer. Now, what is the private sector's role in all of this? We didn't see the model that we had seen with integrated systems in the US, such as Kaiser, or HMO systems in Europe exist in India. So we decided to try it ourselves. And what we've created is a fully hospital-owned insurance company where a plan would be offered to customers, which functions almost exactly like an insurance plan, with the only difference being when they have a problem, I suddenly, as a healthcare provider, bear risk. So every prescription Every medicine, every test, and every surgery comes at a cost to us, the provider. Therefore, it automatically aligns without anyone having to say it, without the patient demanding that I keep that person healthy. Me as the provider are incentivized to keep that patient as well and healthy and out of the hospital as possible. With a simple tweak, you can imagine a system that aligns a multitude of healthcare service providers into a common pool that shifts the burden away from self-seeking fee-for-service care towards, as you had described.
And one thing that I know from your experience, and I just want you to comment on that, if the belief is that people will not come for primary care demand is not there, that has not been your experience, right? The early ventures that you've gotten into primary care, you've seen a lot of demand for their services.
People aren't health seeking by nature, barring a very small percentage of people. Most people are health avoidant. The long-term rate of medical adherence after 5 years for any sort of condition drops to 50%. These are well-documented studies. So it is just in the psyche that people will not seek out health. Having said that, it is also that health is too associated with the worst aspects of a person's disease. Hospitals are associated with cardiac care, cancer, dialysis, and disease. It is not health as health and fitness. It's not health as health running 10K or health as eating a healthy diet. And so that amount of reframing is something that we've done in the clinics that we operate, where we say, our job is to keep you healthy and live to the age of 100. So with that in mind, these are the tests that we need to do that will help you achieve that. And in that case, everyone does want to actively know their HbA1c, their lipid profile, their VO2 max, their bone density, their ultrasound, whether they have kidney stones or not, rather than what traditionally happens, which is a lot of institutions with infrastructure just sitting back and waiting for the demand to materialize. So what's missing is the thing that ties it all together, which is oriented around the person rather than the disease.
Thank you. That's a wonderful start to our discussion. And let me turn to you, Alok, for taking us through some of the issues that you are seeing on the ground. Alok, for those of you that don't know him, is the co-founder and EVC of the PolicyBazaar fintech. It is the largest insurance distributor, certainly in the country, I would imagine, in the world. More recently, though, despite their enormous continuing success on the insurance side, they have recently incubated a new healthcare venture to bring payers and providers together in their own unique way. And it'd be wonderful to hear from him what he finds. Prior to PolicyBazaar, Alok has worked in various cross-functional roles with Mahindra & Mahindra in GE. He holds an MBA from IIM Calcutta and has a special interest in science and technology and economic empowerment. Alok, over to you.
Thanks, Nachiket, and very glad to be here. When I was hearing your opening remarks, it was music to my ears. It's exactly what we think healthcare should be and how we plan insurance and healthcare service delivery to come together. I would just like to mention a few points which don't come out very, very easily when you look at the data. So first, we end up looking at India as a single market or single demographic. Unfortunately, that's not the case, obviously. I mean, today the private sector healthcare in India is typically geared towards a very, very good healthcare service delivery to only 3 to 5% of India. That 3 to 5% actually can get that service by paying or through insurance or whatever way they want. But if you go to any of these places, the RPOPs and the cost associated is created only for that top segment. Unfortunately, there is also a very large segment, almost 70% of India, which cannot even afford to buy insurance today. And they have to rely on government, Ayushman Bharat, and all those schemes. So, whatever private sector does today is not going to cater to that 70%. So the whole effort about when we talk about integrated healthcare is actually about the middle class or upper middle class, where you can assume the household income to be somewhere between, say, 50,000 rupees to 2.5 lakh rupees a month. which comprises about 27% of India, about 35 million people, large enough, 350 million people, sorry, large enough segment, but that's the place where somewhere insurance sector and private healthcare can come together to deliver service. Look, the way we think about it, if you look at any of the large economies in the world, the government can provide for the masses. In India, the masses is quite poor, unfortunately. So it can't take care of any middle class, which is roughly 4x to 5x of GDP of the country. Now, coming specifically to the problem in healthcare and insurance coming together. See, again, unfortunately, we are a low trust society. So when someone is thinking of buying a health insurance, if you think about, say, 20 years back, people were not buying at all. One of the reasons was a lot of people were getting that social security support from their joint family. And they thought, okay, there is a support network anyway in place, so why should I buy insurance? If you pay something and don't get anything back, and especially in health insurance, the best outcome is to never get ill, right? So you're paying money and the best outcome is never to use the product. So Indians don't like to do that usually. So when do they buy insurance? They buy insurance when they're very sure of a claim in next 3-6 months, which is a bad time to buy insurance. Or they know someone in their family, friend circle, or a colleague going through a bad experience, and it suddenly dawns on them, oh shit, I need this product. But unfortunately, this is not a top of the mind product. This is a discretionary product. It's taken us 17-18 years to get to that stage where people started to think about these products voluntarily. But even then, as Nachiket mentioned, it's a very small segment of people who end up buying this product. So even if we look at 350 million people, the number of retail policies on the lives covered by retail policies today is somewhere about 12 to 15% only out of the middle class. If you look at India, it's obviously much lower. So there's a huge amount of scope. But think from the insurance company perspective. Anyone who's buying this product today, they are not able to trust the incoming data. If you cannot trust the incoming data of the customer risk, how do you price the product? How do you create the product? So what happens in India? They create an average risk product. Average risk product in a risk category is a junk product technically. So they say, okay, you want a product based on your declaration, I'm giving you a product. But I'll do my underwriting at the time of claim. So claim process continues to be really cumbersome, opaque, and it's not tied together with the healthcare delivery. So customer trust in the claim process continues to be very low. And if you do not have confidence in claim, why should you buy the product? So the real problem actually starts in a very different way. It's not whether we have the healthcare system, whether we have enough number of insurance companies. We have more than enough number of insurance companies, to be honest. But they are very wary of taking on the customers if they don't understand the real risk that they're covering. The price points in India are really cheap. On an average per life, we are paying about 10,000 rupees, which is like what, $100, $110 per life for full year. Second, an unfortunate situation in insurance industry is the product was developed with a very wide network. So you work with 10,000 hospitals, 12,000 hospitals. If you do that, you do not really have any negotiating power. And what you're covering is not healthcare, you're covering hospitalization. So it's a wide network, narrow coverage. What Nachiket was mentioning or Viren was mentioning is actually what we need. Narrow network, wide coverage. You need to cover everything, right from preventive, home care, daycare, pre-op, post-op, everything. But that integrated model is very tough to deliver at these price points. The amount of money available with the insurance companies, if you look at the RPOPs in India, in private sector, usually big cities, we are now looking at 70,000, 80,000 rupees RPOPs. The reality is that the insurance companies only have 35,000 rupees to pay. If they do not have 70,000 rupees to pay, how will they ensure
RPOP,
that
just to clarify, is average revenue per occupied bed.
So, if that's the daily charge in a hospital today on an average, if you go to any place in Delhi, Mumbai, Hyderabad, Bangalore, anywhere. So if insurance companies only have 50% of the money to pay, they can't pay out of their pockets. And the problem is, yes, see, healthcare needs insurance company needs healthcare. But as again, Nachiket mentioned, see, the patient, we don't want to go to hospital. Insurance company also don't want me to go to hospital, but hospital wants me in hospital, right? So they will do whatever it takes. So from insurance company perspective, they are dealing with a system where frauds are rampant, over treatments are again rampant, and inefficiencies are actually helping the healthcare providers get higher valuations. Because inefficiency means higher ARPOB means higher valuation.
You're all planning to now address this issue head on. And we are very keen to hear from you. What is that plan and what are you thinking about?
So as I said, we obviously had a lot of learnings by talking to people like Kaja Permanente, Hevida, Sanitas, a lot of these people. We also looked at how NHS works. In fact, in India, one model works a bit similarly, which is armed forces hospitals. But what you want to do is integrated healthcare. You want to talk to your insurance partners, create a plan where once a customer gets that plan, everything except for cosmetic like glasses or some dental treatment, everything else is covered from day one. This will require two very big behavior change from customer perspective, to be honest. First, we want them to think about healthcare before they fall sick. It's not as easy. It takes maybe 5 years, 10 years, 20 years, I don't know. Second, we want them to trust the system, not the doctor. Today, people go to the doctor. If doctor moves from Max to Fortis to Medanta, they move with the doctor. We want them to trust the system that you come in, we'll give you the best service possible, best outcome. Lastly, I think somewhere patients are not treated as consumers. So the healthcare delivery is not designed for customer experience and filling the anxiety of the customer and their family. So these are the few things that we are trying to address.
Wonderful.
That, tomorrow if any person needs any healthcare, any service, anywhere, they are able to get that as a consumer and they are the focal point of the whole healthcare delivery.
Right. And one of your ideas is building out some hospitals or working with some hospitals. Is that one of your ideas?
So phase one, we are building out, it's a lease plus build out both the models in NCR. We want to have about 6-7 facilities, maybe about 1,200, 1,400 beds spread across NCR. We are happy to buy, we are happy to collaborate, lease, whatever it takes. See, we don't want to own the asset, we want to own the experience.
Wonderful.
So, we are not very fussy about owning the asset, but we want to run. We are developing our tech from scratch. We have already built a lot of AI layers in that tech so that consumers get the benefit, but also doctors and the medical professionals use that tech because it makes their life easy and make them do a better outcome for the patient. So, yeah, it's a very early stage venture, to be honest. I think our first hospital going live is about April. We actually bought one hospital in Noida, which is right now under integration. But yeah, over the next 2-3 years, let's see how it shapes up.
Wonderful, wonderful. Thank you for your remarks. Let me turn to you, Sanjay. Sanjay Nagral is a Bombay-based surgeon. He specializes in, let me see if I can get this right, hepatopancreatobiliary surgery. And he's the director of surgical gastroenterology at Jaslok Hospital and Research Center. He trained at GS Medical College and KEM Hospital in Bombay, both very prestigious institutions, and completed fellowships at King's College and Royal Free in London. He has over 120 publications, edited surgical textbooks, and served on ethics and editorial boards. He's also the publisher, and which is kind of also one of the roles that we thought might be interesting to bring him in, publisher of the Indian Journal of Medical Ethics and a noted public health writer. So, Sanjay, to turn to you, one of the interesting things about one part of your personality, and I'm keen to have you focus on both, is that you work at Jaslok. It's one of the oldest tertiary to quaternary care facilities, but it serves the very wealthiest of the country's population. Just so that people may or may not know this, but Jaslok is right next to the mega structure in which the Ambani family resides, for example. From that vantage point, if I may engage you, what do you think about the reforms we are talking about? Do they make sense to this community of people, or are they not appropriate for them?
Right, Nachiket. So thank you. And
let me finish the second question also, so that, in some ways you can balance the two and bring in them as you want. Is, as you think in your independent capacity, you've been a champion of ethics in medical practice. One of the ideas we've had is that approaches like this switch the incentives around. External control, regulation, price, etc., we have seen have not worked as well. If you put a price control on stents, people start putting 5 stents. It doesn't produce the outcomes that you want. So, both these questions in any order, we would love to have your perspective.
Right, sure. So thank you, Nachiket. both for having me here, but for that interesting description of the vantage point. I must, before I start, say this to the audience. Perhaps you know this a little, Nachiket, that I spent about 15 years in a large public hospital in Mumbai, and till the year 22, I worked both in the private and the public sector. That's one. Secondly, I have no false sense of loyalty to my employer. So that's why I'm here. Otherwise, I wouldn't have been here. And that's why I write. But I think it would be a little also disingenuous on my part to point out that when you use the word private sector, big hospitals, especially for urban India, you have a wide spectrum of hospitals, right? So that is, just look, for example, but also many other hospitals in Mumbai is what is called as charitable hospitals. There is a scheme of the charity commissioner, so 20% are free. And now there are a sort of relatively new breed, which are corporate hospitals. So I'm just saying that, that there is a spectrum. Now, when you sent me the reforms suggested by you, which were on your slide, and I must first confess that I took some time to understand what you're saying. And you are a huge economics brain, and I'm not. So this whole thing about how do you incentivize essentially a private hospital or a private facility to go into preventive care, to go into comprehensive integrated care. I'm sure you thought a lot about it, and that sounds very interesting to me. But as someone who has worked across hospitals, vantage point apart, but sort of a ringside view of how they think, and including how my colleagues think, how my managements think, I'm not sure how whether there would be an interest in doing this. It sounds like a good idea, but I think that then you have to understand whether the private sector would be interested in this. Narayana may be a bit of an outlier. I hope you know that many big private hospitals, private sector in India are resisting even empanelment in Ayushman Bharat. We know that. Also, if you look at the history, in general, any regulation, any attempt to change the financial model that they work in has been met with a lot of resistance. And I must share this with you that I was a member of the Maharashtra State the Clinical Establishment Act. I don't know whether it's referred to today, but is an attempt to rationalize, standardize healthcare in India. And interestingly, there was a health secretary, I think Mrs. Sonic has left, but it was around her time. And she said that your committee will also look at rationalization of costs and transparency. And we set about it in a very, very detailed manner, brought out lots of stuff, etc. And you know who opposed it? It was opposed by the members of the Indian Medical Association in the committee. So we must understand that the India's health professionals, again, there's a wide spectrum, and there are many who are doing great work outside of big hospitals, even in hospitals. But there's been a co-option. Doctors are hospital owners. So there is lots of conflicts of interest. So I'm not sure how they will respond to any of such kind of reforms or suggestions.
Just one issue, Sanjay, just to add one narrow perspective to this last question that you raised. The reality is that most hospitals are not getting the occupancy that they need. And maybe a Jaslok is always full, but if you look at large tertiary hospitals, they are not getting the beds utilization that they want. A lot of people are doing, for example, why would you go to a Jaslok or to a Fortis to do a routine delivery? This is not what it's designed for. But unfortunately, that's the bulk of the traffic. So there is an incentive for these hospitals to think about how do they build revenues and revenue streams that give them occupancy that makes sense. Otherwise, these very expensive capital assets are sitting with low occupancy. They're trying to make it up through ARPOB, but they're not getting it. And it's telling on their price to book ratio. It's telling on their market capitalizations and their market share. I mean, one thing that was very surprising to me as a banker coming into the healthcare sector that how small the formal corporate sector was. If you add the total top line of all listed hospitals in the country, all of them, it's less than 5% of the total health expenditure in the country. And a mid-sized hospital in Detroit, Henry Ford, has more total revenue than all of these hospitals combined. So there is an interest, is what I would say. While whether they go in this direction or not, I don't know. It's something for you to give us a sense of. But there is, at least the presumption is that there may be some interest. Not so much because they care about the people, but because there is a commercial interest there. And what we're trying to understand is, does the commercial interest and the social interest come together?
Right, absolutely. And I want to first start by saying that you're absolutely right that many hospitals there's too much concentration. South Bombay, for example, hospitals' occupancy rates are falling, including Jaslok, by the way. But you know what, the way I have seen it over the years is that, the way to improve occupancy, unfortunately, and that's again, poor regulation, we can even link it to ethics. And as I said, the doctors often are co-opted into all this is by indulging in corruption. And when I use this word very consciously, when I say corruption, I mean that when you can pay people to send patients to you. Indian healthcare, 80 to 90% of referrals are through commissions. This is Indian healthcare's biggest open secret. So you pay people, you create diseases which don't exist, you overcharge. So that's what they have been used to. Now, whether they will see that this is a much better approach, a much more enlightened approach, that remains to be seen. That's the point I'm making, because they are currently having a good time using all sorts of interesting, dubious, corrupt methods and keeping it going. I think the link that you're making to the ethics work, the little ethics work we do. So, Nachiket, perhaps you know this, that actually the ethics movement in India, the small but sort of the journal that we run, actually it comes from a patient's rights perspective. It is rooted in patient's rights and health rights. It's not an academic ethics. And the journal is an expression actually of that movement. And therefore, for us, access, equity are extremely issues. Any of you read the journal will immediately see that the issues we cover often are related. It's just a lens we are using to talk about the challenges of healthcare in India, and not sort of an academic discourse into very high-level ethics. What is therefore is the challenge? I think the challenge is that we are so financialized, and this has come up, but I think this is something that I need to reiterate, that we are so financialized, and the conflicts of interest, the level of co-option now is so high, that I think many of the practices, and that's the ethics challenge here, are clearly related to how people are earning money, what is their revenue systems. So it's not some moral issue, it's an issue of the revenue. And when it's an issue of revenue, therefore, how do you deal with that challenge? Again, I'm not an economist, but to me, and this is how I would finally put it and sort of summarize, I think we are actually very under-regulated in India. We are, so there is no serious regulation, whether it is prescription practices, prescription with generic. So I hope you know this, that the new ethics code of the National Medical Commission, I was on that committee, one single point on which it was opposed and retracted by government was because we said that the prescription should be on generic name. So it's still not been implemented. So this is both the resistance, but also the power of the medical profession. And somebody referred to this. I think Mrs. Sonic also referred to. I think the medical profession in India, especially the organized profession, unfortunately, should be on the side of people, patients, but may not always be the case because of their own interests, but also is very powerful. And therefore, I have a feeling that any reform which really disrupts the current model may not be very welcome and it will be opposed. And we have seen time and again this kind of opposition coming from the profession. So these are some things I want to put out there. Having said that, I think clearly we need change. We need to acknowledge that there is a vibrant, big private sector which is occupied the space which was vacated, I think, by the state years ago, and it has done a decent job. But I think now it needs to be creatively used, but also I think it will need some form of arm twisting if necessary. I don't think it's going to happen just because you suggest an economic model which you think will interest them.
With you. Thank you so much, Sanjay.
Can I add a small thing? Things are not as gloomy, to be honest. Doctors are very good and outcomes are very good in India compared to anywhere else in the world. The problem, what Nachiket mentioned, was that a lot of these facilities, which are supposed to take care of tertiary and quaternary, they are being used for even secondary treatments or even sometimes primary treatments. So if you look at the catchment area, just think about it. From Delhi NCR, look at, say, UP side, all the way to Kanpur or Lucknow, there is no large hospital. Look at the Haryana side. Whole of Haryana, there is almost no large private hospital. So if you're talking about 300 kilometers on each direction and there is no large hospital, then people are coming to those centers for everything. And yes, eventually these are businesses which have to make money, but somewhere the balance has moved a bit more towards commercial rather than service. And I totally agree that needs to change, but supply is itself a problem because it is catering to a very small segment.
With you, I think that's a wonderful addition. Towards the end, let me turn to you, Bindu, to talk about your experience. Bindu is the chair, co-founder and managing trustee of Dwara Holdings and founder of Dwara Health Finance. She has held a number of leadership roles in the financial sector and was with ICICI Bank's microfinance work and rural banking for many years. She has studied at the Madras University, at the Institute of Rural Management, and at the Harvard Kennedy School. She's published extensively and served on RBI and Government of India committees. She received the ET Prime Women Leadership Award in 2020. So just to turn to you a little bit, you've heard all the senior leaders from the health system talk about it. You yourself have built out well-being centered models of financial services in very remote parts of India with demonstrated, documented impact on poverty in the villages where you started your work. What is your overall reflection on the reforms that we are talking about in the commission vis-a-vis the private sector? The second, just to make sure that you have all the questions from me, you've built out what I think is the first self-sustaining model of integrated care at the primary care level in rural India. And you've been at it for a while to get to this point. Can you tell us more about what you've done and how you've addressed some of the concerns that you hear and you've brought up in today's discussion? Over to you.
Thank you, Nachiket. And thank you for having me here. I think the Commission's recommendations provide some very interesting opportunities for innovation and product design, particularly in voluntary health insurance, which I think has been a source of disappointment to many of us in the industry that it's been such a small piece of the action. First, in the scope of coverage, I think you're absolutely right that we cannot speak of financial protection without addressing outpatient expenses, particularly drugs and diagnostics. However, as many speakers before pointed out, there is a lot of wastage here, unnecessary diagnostics, the MRI a month person, expensive branded medicines where perfectly reasonable generic alternatives are available. So we do need to standardize and build protocols for outpatient care so that this integration actually works for insurers and doesn't become a source of financial stress. I will also say that health insurance, I think it's clear to many people in this room that it's a very unique financial service in the sense that it doesn't pay out in terms of money. The moment of truth is when a loved one is in hospital and it's really an experience, it pays out in terms of healthcare benefits. And I think the Commission is spot on to recognize that this requires a much closer alignment of insurers and hospitals as opposed to what we have now. So any reforms that make it easy to combine both functions is certainly in the best interest of the customer. I would say subject to there being sufficient competition. And that's probably something to think about a little bit, to say, how does integration not result in creating monopolies, duopolies? How can we actually get good competition among reasonably complete kind of propositions? I would also submit that to get the full benefits of an integrated model, insurers and hospitals perhaps need to look more broadly, work with entities specialized in primary care provision, who are carefully tracking patient journeys and points of friction. For example, an elderly patient who lives alone may need transportation support for a doctor visit, or in fact, even small tweaks to her home to prevent the risk of a fall. These are really important details, I think, that get lost in the overall conversation. And as we think about integration, bringing in some of these aspects are really important. Insurers should be able to compensate partners who manage hospitalization rates below a certain threshold. Finally, on the point of capital reforms that the Commission makes and Mirai Chatterjee Committee also recommends, I think it's an excellent recommendation, particularly when accompanied by sufficient reinsurance so that it doesn't become sort of a concentration of risk. Today, a lot of the initial spend is on customer acquisition. And so to the extent that we can provide licenses to organizations with existing captive bases, I think it's an excellent idea. Just coming briefly to what we are doing in this whole space and what ideas of the Commission resonate with us. We are aggregating purchasing, health purchasing in the informal sector, what Niti Aayog would refer to as the missing middle, monthly household incomes between 25,000 to 60,000 or so. So shopkeepers, self-employed businesses, etc. So we're really sort of trying to address the fragmentation there and say, can we as Dwara emerge as a large aggregator for this sort of segment? And the starting point for us was building trust as a primary care provider. Our experience in financial inclusion, although I felt very much an outsider in the health space, but that experience was terrific in the sense of it taught us to meet customers where they are at their homes and not wait for people to walk into their facilities. A typical shopkeeper or farmer working 14, 16 hours a day is not going to visit a health facility, no matter how cheap, how proximate, all of that, right? How friendly. So our care team from day one, we said we have to have health workers who visit patients at their homes. They are then supported by physicians working on a virtual basis who supervise their work and also participate in complex cases, referrals when needed. We don't own any facilities, any brick or mortar, but we've partnered with hospitals to move patients to a facility when there is need. Otherwise, we're going to work very hard to keep patients well managed at home with all of the resources and technology at our disposal. At an aggregate level, 65% of our hypertensive patients and 50% of our diabetic patients have achieved control. And this is typically within sort of 4 to 5 months of participation in our program. And we have a paper coming up with Siddesh and his team at ASER documenting some of this. Our technology work platform, and the panel spoke wonderfully about the need for many of those features. We have built workflows that is tailored to the risk of every patient, and importantly to be intuitive enough that a 10 standard, 12 standard pass health worker can actually execute protocols consistently, not trying to create sort of quasi-physicians and health workers, but to say this is a new cadre of people who will be comfortable working with technology and executing in a consistent way. We're very happy to have partnered with the IIHMR to actually offer a diploma for the first time in digital healthcare operations for health workers such as ours, not just ours, but anybody who's working in the primary care space, so that we can actually start to expect more from this cadre and they can also look forward to more professional growth. On the payment model, I know we've had a lot of conversation about this. This is really, I think, the real detail. And I would say it's a work in progress. But today, how we are doing it is we are providing subscriptions. This can be paid on a monthly or a quarterly basis by the customer/patient. A single subscription is for the first time then integrating access to the care team, i.e. the health worker plus physician. Medicines, we partnered with a generics manufacturer to provide a month or a quarter worth of medication to the doorstep of the home. Diagnostics and insurance. And insurance is being done in partnership with Care Health Insurance. All of this for the first time is a single payment, and we think is really important so that, in some sense, we effectively make the shift away from fee for service to say a single payment can address a bunch of your requirements. There are still things like elective surgeries, et cetera, that are outside this that we'll have to think about. But the goal is to say, can we bring in at least much of what the household would otherwise pay for case by case out of pocket? So to sort of the Commission's recommendations, I would say that this is a small attempt, an early attempt at actually demonstrating, building an integrated patient-centric model, starting from the home, which we are huge believers is going to be the arena for a lot of healthcare. It's not going to be the PHC, it's not going to be the private clinic, it's going to be the home of the patient, and then building outwards and in partnership with hospitals and insurers. A lot of speakers during the day, I think, asked who has the incentive to build this, why would people do this? Let me end by saying that sometimes I think incentives are overrated. I think what it takes is one powerful demonstration of a model that truly works for customers, I think delivers outcomes, and I think maybe in a small way that can set off a revolution. Thank you.
Thank you very much, Bindu, and I want to thank the panelists for this wonderful discussion. We are at time and we have panel after panel coming up quickly, so I will thank you all for joining me in this discussion. Thank you.
Hello, so we're going to start the next panel so that, because several people have to leave on time. So I want to say all the lines here say it is my pleasure to introduce, but it is a particular pleasure to introduce Kea because she was with us at the Mittal Institute for a long time and she was one of our favorites there. So it's really delightful to see her. Dr. Kea Melo Furtado is Associate Professor of Health Management at the Goa Institute of Management in India, and she heads its Center for Health Systems Design and Management. So she was an associate with us at Harvard University. She had the Bajaj Visiting Postdoctoral Fellowship, which is a highly competitive fellowship in the spring of 2023. Her expertise spans health systems financing for UHC and public health policy. She's been awarded funded projects from the World Health Organization and the Gates Foundation on the Ayushman Bharat PMJ, state insurance schemes, and community health worker payments. Previously with Niti Aayog, she has led key national policy initiatives and programs with the center and states. Her doctoral research was carried out under the Inspire Fellowship awarded by the Department of Science and Technology. Kea, I hand it over to you.
Thank you, Hitesh. Thank you so much. Good afternoon, everybody, and welcome to session 5 of today's program. Thank you for being with us. I know it's a long day and it's not over yet, but we now, the title of our session is Enabling Transparent, Evidence-Informed and Accountable Governance of the Indian Health System. And really what we're going to be looking at in this session are both reforms 5 in the Commission, which is the major governance reform, as well as parts of Reform 6. And Reform 6 is really about fostering a learning health system. And you'll see that a lot of that is really about enabling better governance. Sorry, can I have the slides up, please? So, while we have the slides go up, I think with respect to governance, those of us who've been listening to the conversation since the morning, you would notice that there were a lot of issues that kept coming up that really relates to governance. So whether we were talking about public sector reforms, how to create these integrated delivery systems based on systems that already exist, they all came down to governance issues. We talked about changing the institutional architecture through a purchaser-provider split. Just now in the private sector panel, we were talking about regulation, things like the Clinical Establishments Act. So, this is a cross-cutting theme. In reforms 5 and 6, we try to bring some of this together. And I'll just talk a little bit about it and then hand it over actually to my panelists to give you a lot more, because we've got a stellar set of speakers and with a lot more experience than even I have, obviously, in this. And I'd like to give them the time to speak. So I'll be brief. So these are the 2 reforms we'll be covering in this session. Why were these reforms included? Now, we know that in principle, India's health system is governed in a decentralized manner. There is a devolution of responsibility and power between the center, the states, and local bodies. But this potential has not really been fully realized. We have complex administrative structures, multiple procedures, which really make it you have a duplication sometimes of responsibilities, and it's difficult to fix accountability, like who's responsible for what. Sometimes it feels like everyone's responsible for something, but then there's no way to fix accountability for that particular task or outcome to one sort of entity. And so that's one issue that we face. And then really holding local health officials accountable for things like inputs and expenditure or easily traceable outputs, leading to really a low trust culture. And this low trust culture we've seen in our problem analysis can really demotivate local health officials. It achieves institutional outcomes more through tight monitoring rather than allowing for innovation and autonomy, and really demotivates. So that's one of the things that the problem analysis sort of revealed. The other was that we have a lot of institutions, we have a lot of laws. Most of us are familiar with all of these, but they don't work, right? We don't know what's happening, why are they not working, why are they not effective, and a lot of this also then has to do with what are the capacities of the people who have to implement these laws. What skills do they have? What information do they have? What data do they have? Is there regulatory capture? Is there conflict of interest? And these are really the things that very often become the problem in terms of enforcement. With regards to providers, we know that we don't have a supply side problem as much now with the expansion of institutions. We have enough numbers, but competence and quality has been seen to be a problem. The in-service support for training and building of skills, and then making sure that these competencies are reflected in the quality of care, that has been an issue that continues to persist both in the public and the private sector. And so none of these issues are only specific to one sector, they're cross-cutting health system issues. And finally, we know that out-of-pocket expenditure really is, the significant amount of it comes from medication costs, and the high medication costs are really precipitated by several governance issues, including irrational prescription practices. And so these also are things that require governance reform. So what are our reforms? The first one is really to actually decentralize governance and strengthen the capacity to implement that decentralization. We say that all our reforms, whether it is the public sector reforms for creating integrated care systems with revised incentives, the private sector reforms, all of these have to be adapted to local context. And so who's going to do this? Who's going to think about that context? Who's going to incorporate that into the design of the reform? It has to be local health officials, right? And so really making sure that they're able to design, adapt, and implement the reforms at decentralized levels is what is required. So we have to be able to clarify the roles and responsibilities of the different levels. So for example, if we're implementing a purchaser-provider split, the way our commission has suggested, what really is the role of the Ministry of Health and its departments in every state? What is the role of the National Health Authority and the state health agencies in every state? This is really important to sort of define and clarify. And then to enhance the technical and managerial skills to really do those functions. And this could be through structured leadership initiatives. We have a lot of things that have already started, like Mission Karma Yogi, which could do with more health sector specific content to really capacitate these officials to carry out these tasks. Fund flows. I think all of those of us who work in the field know money doesn't reach on time, doesn't come, it's complex. So simplifying really fund flows, simplifying the procedures for this and creating mechanisms by which there aren't delays in payments. And finally, moving from really holding local officials accountable for inputs to holding them accountable for health system outcomes, which is what really, it doesn't matter how exactly you get there, but really the fact that you produce the outcomes that are desirable. And for this, from this really flows Reform Action 5.2, which is one of the enablers, and that is to have the right kind of data. Again, a grouse that has come up in earlier panels. We just don't have the data. How do we get the data? And those are some of the conversations we're going to have. But ensuring the availability of high quality triangulated data at the decentralized level, at the district level. So whether it is data on disease burden estimates, simply things like who are the providers in this area, in the private sector, in the public sector, what kind of services do they provide? What is the quality of those services? Gaurav mentioned that as well. That simple data is not available. And how can we make that happen? If we want to hold officials accountable for outcomes, we've got to give them the data to monitor those outcomes. And so certain basic data like this need to be available. We'll talk a little bit more about how we can do that. A lot of it is about mandatory, a little bit of what someone just said in the earlier panel. I think Bindu said, or I'm not sure who said, but we have to make certain things happen and they have to be mandatory. There has to be a push. There has to be a sort of a bigger effort in making things mandatory. But making things mandatory doesn't always work. So what other incentives do we have? Mandatory registration of all providers in the ABDM networks and with state health agency data. This can happen when the state health agencies become the major purchasers of care, when the private insurers are sort of mandating empanelment that providers be registered and that they report the data. So mandatory registration through existing ABDM, HPR, HFR, and the reporting of surveillance data. This would then feed into the decision support dashboards that could be created that will analyze this data for local health officials linked to ABDM and again, state health agency data. And this would help them identify gaps, design reforms, all of that. We also say that, perhaps we need an agency that can coordinate across the multiple organizations that produce data. We have institutions that are in charge of programmatic data. We have research institutions that generate research data. How does all of this come together? And should there be one agency that sort of brings it all together? And we say that the NCDC is positioned to maybe take this role if capacitated to do so that we have actionable information for monitoring population health status, surveillance, and emergency preparedness. On provider education, we're saying that not just mandatory in-service training, which happens to some extent, but really mandatory recertification of providers. So not a one-time thing, but something that happens in an ongoing way and is mandatory, whereby, of course, and then we have we can have enabling mechanisms for them, like a national digital platform where, and this would again be connected to your ABDM registries health providers and facilities, so that if they are registered there, then you're tracking their training, you're delivering training, you're tracking it, you're enabling recertification, and you're really tracking competency. So really kind of connecting the dots across all of these reforms to feed into better data, better outcomes, better quality. With regards to the curriculum, a lot of initiatives have already happened here, but really focusing medical curriculum on primary healthcare and practicals for community-based care, really how to deliver it in the community. Also to include foundational training in alternate systems of medicine into the MBBS curricula, so that we can have what is truly evidence-informed, integrated care, and not just, based on some initiative or the other. And then, of course, NEET has already solved a lot of, issues that were there earlier, but really taking that forward to make sure that NEET also is more equitable for students coming from rural and disadvantaged backgrounds, and to focus really on competencies rather than just theoretical or technical knowledge. This is something that we also say should happen. The NMC, still has a way to go to sort of address issues of accountability. It's given powers to the states, but how do we sort of capacitate to do this even better? And then, of course, the implementation of the Clinical Establishments Act. And so again, not just saying that it's mandatory, but making it mandatory in an indirect way, in that it's required for all providers to be registered, to report data, so for them to be, providers of care in the system. And then finally, we come to the quality of drugs and irrational prescriptions. So we suggest that CDSCO be made autonomous and also considerably strengthened, so that it can do what it's meant to in a better way. We also make the suggestion on bringing drug regulation under the union list. We know there have been reports of uneven drug quality across states, because this is something that is on the concurrent list. And so different states have different quality requirements, and that causes a problem. So to standardize that to some extent, we've suggested that it be brought on the union list. And then, of course, to have updated essential drug lists, which reflect what are cost-effective drugs really. Effectiveness is important. I know people have grouses about the generics versus branded drugs, but we also have quality issues there, and we can't expect doctors also to prescribe generic medications if there's no confidence in their quality. And so really ensuring that quality is there, and reflects in essential drug lists. Also to manage, drug availability, stockouts, and quality. Digitizing drug sales is an important sort of intervention. Digitizing the data on drug sales, because it tells us about prescription practices and allows for audits of these practices. It also then helps with things like distribution and inventory management. So again, here we have things that have already begun. These are not things that don't exist at all, but and we have examples, and we provide all of these examples in the report for other states to sort of move forward on. And then, of course, deeper collaborations with the professional organizations that are important to bring this to fruition, like the Indian Pharmacists Association, where in other countries, prescription practices have been addressed to a large extent through coordinated efforts with these groups. And then, coming to Reform 6, I'll just quickly say that Reform 6 is about promoting a learning health system. And really, if you read this, you'll say, oh, this is definitely something everybody would want. But what we're saying is that this data should flow effortlessly between researchers, policymakers, healthcare providers, payers, and citizens. But we're saying that this should not be the initiative of one motivated, bureaucrat, or one motivated academic who, is chasing the bureaucrat to say, like, we have this data, we want to do this study, it will feed into your program. But we're saying that there should be institutional architectures that make this happen on a regular basis, where, all of this is connected, and so it can feed into program delivery, redesign, and all of that. I'll turn to our speakers, who will also then give us more insights into this, of how we can create these institutional platforms to make this a systemic thing. fostering synergies between the Department of Health Research and the ANRF. And then, of course, looking at the roles of existing institutions like the Niti Aayog, like the NHSRC, the SHSRCs, to really build this culture of openness to data sharing, peer learning, learning from mistakes, not being worried about when something has failed, but really trying to understand how we can sort of learn from that and move forward. So yeah, I think, really moving from a compliance-driven mindset, an approach to institutionalizing learning. I think this is what that Reform 6 is about, and it is basically underlying to effective governance of the health system. And so with that, my previous moderators have sort of talked about the barriers. I'm not going to talk about the barriers because I think we all know the barriers to effective governance. And we've got experts, like I said, who've got far more experience who will speak to these. What I just wanted to highlight quickly is that we already have a lot in place to make these things happen. We have the 15 Finance Commission recommendations that have already called for increased flexibility. We have Mission Karma Yogi. We have these institutions, ABDM. So how can we sort of build on all of this to make what we've recommended actually work in the state? So I'd like to now call upon our stellar panelists here on stage. We have Dr. Santosh Mathew, Dr. Srinath Reddy, Dr. Soumya Swaminathan, and Dr. Pankaj Bharadwaj. If you could please join me here. I'll briefly introduce, I know this panel needs no introduction, but quickly, Dr. Santosh Mathew is country lead for state systems and partnerships at the Gates Foundation. But from 1985 to 2017, he had a career as a civil servant in the Indian Administrative Service. During this time, among other assignments, he served as Additional Chief Secretary for the Government of Bihar, Chair of the National Council for Teacher Education, and Joint Secretary in the Ministry of Rural Development, Government of India. From 1994 to 2000, he was Professor of Social Management at India's Civil Service College in Mussoorie, and from 2000 to 2003, Country Director of the Leadership for Environment and Development Program in India. Welcome, Dr. Mathew. Dr. Soumya Swaminathan is a pediatrician and global health leader with over 4 decades of experience in clinical care and research. She served as chief scientist at the WHO and as Director General of the ICMR, Government of India. Currently, she is chairperson of the MS Swaminathan Research Foundation and principal advisor to India's National Tuberculosis Elimination Program. A fellow of leading global academies, she has authored more than 480 publications. Her current work focuses on climate change, nutrition, and the health of women and children. Dr. Srinath Reddy, a cardiologist and epidemiologist by training, is the founder, past president of the Public Health Foundation of India, and presently serves as an honorary distinguished professor of PHFI. He is the Chancellor of PHFI Institute of Public Health Sciences, which is deemed to be a university. He was earlier head of cardiology at the All India Institute of Medical Sciences. Professor Reddy was the first Bernard Loan Visiting Professor of Global Cardiovascular Health at Harvard and is presently an adjunct professor at Harvard, Emory, Sydney, and Pennsylvania universities. And Dr. Pankaj Bharadwaj, who is the director of the ICMR National Institute for Implementation Research on Non-Communicable Diseases in Jodhpur. Previously, he was professor of community and family medicine and head of the School of Public Health at AIIMS Jodhpur, leading the MPH program and the executive program on public health policy, leadership, and management. His expertise spans implementation research, geriatrics, NCDs, and tobacco control. A FAMS and FAI-MER fellow, he serves as editor-in-chief of the Indian Journal of Community Medicine, with roles in the Ministry of Health, ICMR, and WHO committees, and collaborations at LMU Munich, Karolinska Institute, ECDC Stockholm, the Public Health Agency of Sweden, and Johns Hopkins University. Welcome, and thank you to all our panelists. All right, so I think just being mindful of time, I'm going to sort of go into your individual areas of expertise and draw your comments on, the reforms I presented, and also because I know you've had a chance to look at the report, the overall sort of strategies that we've talked on in reforms 5 and 6. So, Dr. Reddy, if I could ask you, we started off talking about decentralization, and in a system that is decentralized in principle, what in your experience are really the barriers to effective decentralization, especially at local at lower levels of government? How can this be done in a way that's effective with also the necessary safeguards? Because when we talk to bureaucrats, we know that there is a fear sometimes of too much autonomy, and how do we sort of safeguard against misuse of that power? And if I could just also stretch that question to then say, because in India we know we have states at different levels in terms of their capacity or varying capacities, do you think the decentralization that we propose should be approached differently in different states? So, if you could sort of give us your thoughts on that.
Thank you very much. First, let me congratulate the Lancet Commission on an excellent report. When we're talking about decentralization, the critical question comes in is, who controls the money? Next question comes in is, who controls the data? And who controls the program structure? So there, the issue is, how willing are the people who hold the controls ready to provide adequate autonomy to other levels? Of course, with supportive supervision when required. At the moment, much of the money does come both from the center and the states, but a lot of centrally sponsored programs have acquired a lot of power over state autonomy. Then, when you also look at the other programs too, we find that through a variety of mechanisms, the central government has now started exercising a lot of control over health programs. And when you mention data systems, that's the next level, where the data is flowing upwards. There's no data flowing downwards. You mentioned districts. Ideally, it should flow back to the states, it should flow back to the districts, it should flow back to the blocks. If it is not happening, you're not able to take decisions at that particular level. So these are the blocks. And unfortunately, first is who controls the money, who controls the data, and what are the motivations for control? Of course, power, but also the whole issue of branding comes in. Who would like to be seen as the main disperser of benefits to people? So that's a critical political element that always comes into the whole political economy of health. And therefore, now even when benefits are being dispersed directly to the beneficiary, neither the state is really actively involved, nor is the district administration actively involved. So what started as what's called a hourglass system now has become a wine glass system. So you only have the people at the top holding the resources, and directly going to the people is good. But all the intermediary levels are, in a sense, losing their ability to influence the process. Sometimes for the good, sometimes for the bad. But unless the whole system is involved, there can be several blockages in between. And that's where we are finding challenges in decentralization. Second is personnel. Since 2007, after the introduction of the National Health Mission, about 90% of the appointments are contractual appointments. So if you're going to have the health officers, the information officers, the finance officers, the community health officers, even a large number of ANMs and others being appointed on a contractual basis, and they're going to be rotating periodically, then neither have they had the ability to develop the skills to influence the system, nor do they have a stake in the system. So unless we actually build that capacity through a regularly appointed staff and continue to enhance their ability to utilize the data to monitor the performance and improve the performance, we're not going to see this decentralization happening in a real way. Coming to the second half of your question, should there be a differentiation among states depending upon their capacity? I don't think there should be a decentralization apartheid, if I may put it that way. Every state has to have the capacity to decentralize. And particularly when we're talking about districts, every state has some poorly functioning districts. Every state has some well-functioning districts. Certainly at the block level, that's true. Even in a well-functioning state like Kerala, they've had problems in reaching to tribal communities and coastal communities. So you will have challenges. But unless you actually enable people to have the data at their hand and start influencing decision-making through appropriate monitoring at the local level, you'll not be able to consistently build capacity. Therefore, you can provide further levels of support, training, other resources to states which are not fully geared up yet. But to say that you'll have different categories of states would be invidious at this point in time.
Thank you. Thank you, Dr. I think that's very insightful. And since we're on this point about decentralization, I just wanted to take it to you, Dr. Matthew. Given your extensive experience working with government, this thing about contractual employment, which has been really the bulk of the employment in health programs now, and it's the way it's been happening for a while now. How do you see this as being something that the system can move on from? And I'm linking this to also what I originally wanted to ask you, which is about, you highlighted that a lot of the reforms that we've suggested here in governance are nice to have. We all wish this could happen, but why is it not happening? If we have all these things in principle, or we have the foundations for all of this, why is it not working? So this idea also of not contractual but full-time employment is more effective to create the institutional structures we want. Why are these such large barriers in the health system?
Thank you. Again, I had my own words of congratulations. But it's not you who said, I'm glad I'm not the one who's saying that the kind of things that you have suggested here are things that the government has wanted to do for a long time. And structurally has even done it. You take the conversion from IMC to NMC was precisely intended to achieve this, and yet it doesn't happen. So I think the elephant in the room is a certain disbelief that wholesale reforms that make the health system accountable is not possible. I'm reminded about 20 years ago, a batchmate of mine was the head of administration at the All India Institute of Medical Sciences, sir. And he used to tell me, Santosh, you can't do anything in AIIMS to even a cleaner, a sweeper, nurse, doctor, to dur ki baat. I asked him, kyun? Because at the highest position in the land, unki ilaj to yahin se hota hai. So if you try to discipline anybody, immediately the phone call will come. So it's a very it's a very networked system, and one of the most powerful of networks, because everybody falls ill and everybody wants treatment. So to me, the health system is a beautiful marketplace that functions on the basis of a currency, which is called IOU. Now, if you want to actually move forward in this, you need to exercise levers that were hitherto not available. And what are these new levers? It's a new levers of observability. You have to suspend disbelief for a few minutes if you want to make sense of what I'm going to say, and if you think I've not smoken pot before coming in. You will have to believe that electronic health records and its universality is actually possible. That alone will not do. You will have to believe that without typing in, it is possible through using passive listening, through what is now called voice scribe, it is possible to record all activities, not only between clinician and patient, but also physiotherapist and patient, chemist dispensing drugs and the person buying it. At every touch point, it is actually possible to have passive listening, AI-enabled voice scribe that gets structured data into this electronic health record. The third thing that you will have to believe, I'm saying believe because if when NASA went to John F. Kennedy and asked about sending a human to moon, if John F. Kennedy had asked, has been done before, humans would never have gone to the moon. So today we are in a situation where we are what is called evidence-led. We want evidence, which means you will look only at the rear view mirror. You're incapable of looking at the windshield. So has it been done before? No. Then don't call me here. Can it be done? I believe yes. Suspend the disbelief for a moment. No clinician, no care seeker should be meeting a clinician before triaging has happened. Case history has been captured. Not using a nurse, not using a doctor, but having the collective wisdom of the entire community distilled into an adaptive question engine. If these three things are in place, which I believe eminently so is possible, you can actually have an accountable, observable health system where 97% of the prescriptions given are need not be wrong. I mean, that was a study, it's a Harvard study, which actually told us that 97% of the 5 conditions, and the person is smiling in front of me, 97% of the prescriptions are actually wrong. Nobody's even talking about this. I used to be a very small cog in a very small finance department of a very large state. And I don't know, and politicians, why should they give money to health department if the only way they can get their electors, their voters treated, their family treated is by exchanging IOUs? So you will have to inventorize the entire system, make slots available. You will have to do all the other things that I just now said. If you do this, it's possible today, but not yesterday, to have a post-Arrow world where the so-called information asymmetry has been sorted. But one more point, and I will stop, is that you also have to play the politics of this. And the politics of this economy can be played out if we can think in terms of a population health and wellness score for a state, calculated at the panchayat level twice a year, using the biannual examination of a sample of stratified samples of different stratified by caste, disease types, gender, caste, all of those things, to generate a score plus there has to be 3 other aspects. I will not take the time here. And then use this to elevate the political attention and trigger political and administrative competition based on scores that are both valid and reliable. Thank you.
Thank you. Thanks. Thank you, Dr. Matthew, for that candid, always appreciate your brutal honesty with, things on the ground. And, I want to come back to some of the things you've said, especially this thing about the performance score and competition. We've had variations of that happen. There was a health index where states were asked to compete, based on the health index. Financing was linked to that. It doesn't happen anymore in the same way, but yeah, those experiments. But I think what you said is really important, and I want to come back to it. But Dr. Swaminathan, if I could come to you now. You had the chance to look at these reforms and you made the point very, very clearly that it is really the institutions and their capacities that will determine whether these reforms can move forward or not. And you said specifically one line that I'd like you to sort of elaborate more on, which is the institutions that need science-based strengthening are state and central pollution control boards, policy research and health technology assessment, disease modeling, and private sector oversight agencies. Given our suggestion that we have these agencies, but they need strengthening, could you elaborate on the specific knowledge, the competencies, and the methods of working for these institutions really that can make them more effective in the role?
Thank you, Kea, and let me also say what a pleasure it is to not only be here today, but to have read the report and to have been able to write an accompanying piece. Thanks to the Lancet for having invited me, and to the commissioners. And also that the fact that as you read through this report, not all of it is new or different or innovative. A lot of it is something that we've known and many of us have been saying for a long time. But I think what's different is that it's been put together now in a way that really enables, I think, somebody who's motivated, a government that's motivated to take, healthcare to the next level, and particularly focusing on comprehensive primary healthcare. I don't think there's any other way to get to universal health coverage except through comprehensive and high quality primary healthcare. So coming to the institutions, I think I've been for a long time a believer in institutions, state institutions that have a certain purpose, and that I've seen some that have worked very well and others that have not. And I think since the morning, we've also had a number of people commenting on some of these institutions, for example, on the medical education or the medical council, the nursing council, the pharmacy council, and so on. So for example, once you pass out, and medical students today are so obsessed with getting through the competitive exams that really their practical skills have taken a big hit. And so I think they're coming out with very, very poor practical skills and certainly no exposure to what they would see in a rural health clinic. And then they get thrown into a primary healthcare center and they're completely at sea. We have all the levels of health professionals that you see today. We have this huge network, not only of ASHAs, but this new cadre of CHOs. And again, they have that initial training and then they're placed there. The ones I've met are really good. I would say they're motivated, but they're overburdened with reporting, and they don't have an ownership for the health of the population that they serve. And there's no in-service mentoring and guiding. And I think, again, this point about data is, I would like to reinforce data going only up, 80 registers, now in addition to that, 10 apps or whatever, the number of apps is increasing as well. But none of that ever comes back to tell that woman on the ground what she's done well or what she hasn't, or what the health burden is and where she should be focusing, so on. So I think a reorientation of that primary healthcare team is very feasible now with the investments that have been made through the Ayushman Bharat program, but it's going to require this team approach, this accountability, this taking ownership for the health of that population. So I think our whole way of how we do education, training, and service skilling and capacity building needs a huge, and there is no institution right now, so it would require the NHSRC and the state health resource centers are not equipped to do this. So they could be strengthened, but I think we'd also need a new institution. Coming to existing institutions, I think on the regulatory and accountability side, we really need to strengthen some of them. For example, take CDSCO. Point was made by you about, so India is not yet a WHO listed authority. And for vaccines, we could be. And the reason is it's centralized. There's no state vaccine approval. So I think in a year or so, if India made the application, we could be WHO listed authority. But for drugs, it's going to be very difficult because of this state and we've seen the problems we've had with drug quality. So there are solutions to this. I don't think it's rocket science. It just needs the will. And I think our CDSCO, if we wanted to be like an FDA or an EMA, we really need to elevate the level of the person who's currently heading it and give that person much higher level of authority, but also accountability, independence, credibility, and so on, and have a lot more transparency in the data and predictability. I think is very important. We also heard about innovation, how India could be innovation capital. Yes, we are the generics capital of the world, but how do we move into the innovation space? It's only possible if we have regulatory reform. And we start, right now, we're not in a good position to look at new class products and whether it's AI-based diagnostics or whether it is CAR-T or gene or cell-based therapies. We need a very different kind of regulatory system to promote innovation. Today, China's #1, right? They've overtaken the US, I believe, in new drug, and we are something like 2% of new drugs, and China's at 25%. So we have a long way to catch up there. Similarly, we have other bodies like the food safety regulator. Now, the front of pack labeling proposal has been on the table for many, many years. But again, because of conflicts of interest and pushback from private sector, we've not been able to advance that. Now, many countries, there's evidence to show that. So you talked about having the evidence. Well, yes, we have to take that leap of faith. But even where there is a lot of evidence, we're not acting. So we need, again, a strong regulator who's independent and who's cannot be influenced. I mean, in Brazil, the drug regulator reports to the parliament. And so during COVID pandemic, when the president tried to malign the COVID vaccine development, he was one of the presidents who was against it. The drug regulator stood up to him and went ahead and approved COVID vaccines. He couldn't be fired because he reports to parliament. So that's the kind of institutions we need. Similarly, you could go on at the long list in the report as well about institutions. But there's one point I did want to make, which is very covered, but not very thoroughly in this commission. And that is the social determinants of health and the contributors to ill health in the country today. I mean, I think even this UHC index that's been developed is excellent, but it does not take into account the fact that in the southern states, we say they're all doing very well and they have high UHC index. But look at the burden of diabetes and hypertension. Look at the control rates of diabetes and hypertension. So if you take that into account, then I wouldn't say that it's a UHC doing well because you haven't done your prevention and health promotion at all. So I think we should relook at this index that's being developed and perhaps see what other indicators we need to add. Otherwise, health system is never going to focus on prevention. The other food, okay, diet, I have to mention here that today dietary risks and pollution, these are the two biggest risk factors for health today. And if we don't tackle those, we can keep building more hospitals and reforming our insurance sector, but the health sector will end up spending more and more money. So there needs to be a much bigger focus on how do we keep people healthy and well and less people getting sick. And for there, the reforms all are in these other ministries, and where the health ministry is a steward and a champion, but not necessarily an implementer.
Thank you, ma'am. Thank you, Dr. Swaminathan. What you said about having the right kind of data built into the index so that we monitor is so important. And I think this is something that many people have struggled with in terms of monitoring. And it usually sort of goes back to, but we don't have that kind of data, and where do we get that kind of data, right? If we want to add it into an index. So, and that ties very nicely with Dr. Bharadwaj and, what we'd love to hear from you, because being with the implementation research, for NCDs, for ICMR, how can we really make, I think people have been clamoring for district level disease estimates, regular estimates, and also other health data at the decentralized levels for a really long time. And we all know why we need this. So what is really required in terms of, where are the barriers there, infrastructure, skills, mechanisms, and what are institutions like yours doing to make these data available really to the local decision makers?
Thank you so much. Yeah, first of all, joining all the panelists and congratulating the Lancet Commission for bringing this important issue. Now, much has so far been said since morning, but I'm currently representing Department of Health Research as well as ICMR in the capacity of one of the center's director, and that is working on implementation research. Now, I'll share you with few examples. You said about district level data, how to generate it. What are the mechanisms? What are the prerequisites for having these? And we all know that three important things would be required for any data to be generated at a district level. Number one is that infrastructure that needs to be there. And when I'm saying infrastructure, that means men, money, material. So it's not just the institutes. We need those people who have the capacity, the skills to generate those data. When it comes to district level estimates, every time either we are saying it to the medical officers or to ASHA workers who are already being overburdened. So who is going to generate those data? If you look at the recent NHSRC public health cadre, which they have suggested, it's just an advice, just a suggestion, but by NHSRC, they've made few cadres that had, it's one of the specialist cadre, it's one of the public health cadre, manager cadre. So we need to look into this because we need to understand that what exactly is happening at PHC or CHC, we all know that doctors, apart from doing their clinical works, they've been engaged in lot many other activities, and which is actually been taking a huge toll of their own work, for which they've joined the PHC or CHC or DH, because they want to be a clinician. They don't want to be a manager at that time. It's a difference in a private sector hospital and a public hospital that if you are a clinician, you will only be doing your clinics. You are not doing something else. But in PHC, CHC or DH, they are supposed to do, except clinics, everything needs to be done over there. And I'll share you with an example. We got an implementation research. It was commissioned by ICMR, only we call it by the name of STEMI. STEMI is ST elevation. And if just for the sake of interest of all who are sitting over here, we would like to know, and the state would like to know, when these all undergraduates or MBBS doctors are being placed in a PHC, why they are not able to diagnose even a cardiac arrest. They are calling it a gas issues, and they are referring it without doing anything. It's taking a heavy toll. So now when it comes to the implementation research in ICMR headquarters Delhi, we find that these doctors, there are some issues with the competency or skill levels, but at the same time, there are some logistics issues also. So what I wanted to tell you is there are two kinds of cardiac arrest. One is ST elevation and one is ST depression, or where ST is not elevated. And if it is ST elevated, you need to thrombolize the patient and then send it to hospital. And if it is not ST elevated, please don't thrombolize it. But what these doctors are doing is, number one, they are complaining that there are no ECG machines. If ECG machines are there, they are not working. If they are there, they are not competent enough to read even an ST elevation, which they have learned during their physiology classes. And then it is taking a heavy toll, and that worked. ST elevation. So what I wanted to tell you is that, so when I'm saying about to get a district level estimates, please don't rely on these doctors or these ASHA workers. We need a kind of, people who are trained in that. And that makes sense. It's not just data. It's like every time we are hearing about AI that give us data, but if you put garbage in, the garbage is going to be out. So we need these people who are trained in data visualization, data collection, quality in data. And as I said, that it has already been suggested by NHSRC in their document that please have a kind of a separate cadre to do it. And that's been there. So as I said, the first is infrastructure. The second one is skills, which is to be there. And the third one is that enabling environment. Give them that enabling environment, which is very important. When you say about the second question, that what implementation research is doing, or my institution or ICMR is doing, what we are trying to do is that we are trying and go to the state health departments, and we are trying to ask this question, what exactly they want from us. It's not an idea which is generated from Indian Council of Medical Research. Rather, the state health officials are asking some questions. And that is the starting point of Health Technology Assessment India, or HTI, in which everybody is talking since morning, which is actually a way forward, which NICE has so far been doing for years together. So now HTIN is there. When state comes to us and they want us, whether in amoxicillin can be given by A&M when they are actually shifting these patients of pneumonia or children from PHC to CHC, they call it as task sharing and task shifting, but would it work with HTIN mechanism? So usually this IP, or what we call it this IR, or implementation research, what we usually look for is a kind of a question which should come from the community, or it should come from the state health system, and it should not be from our side. And again, I'll give you an example. We got a question from Jodhpur and Jaipur. It's a 350, 400 kilometers track. And there are a lot of trauma centers. A lot of trauma centers are there. But the question which State Health System Resource Center, the state asked us to do as IR, that can we do something to know that out of this track, if there is an accident, where to go, where not to go? Can we geotag them? Can we get a kind of an operational value, whether they are functional or not? Just on the map they have been seen. It will delay, a kind of a patient being brought to the trauma center. So IR, what I wanted to tell you is, in summary, is that now it's the time when implementation research should not be an afterthought of these national health programs. Rather, it should be a kind of a core value or core research, which should be a part, inbuilt, embedded, with a kind of a dedicated funding mechanism, the capacity which is to be built. Yes, DHR, ICMR, you also talked about ANRFs. Yes, these are the organizations which are there to support. But yes, ownership and integration of this IR in the national health program is very important.
Thank you. Thank you, Dr. Baldwaj. I'm going to come back about the integration of implementation research, because that feeds very well into our recommendation on a learning health system as well. And how do we institutionalize this so that you don't have to keep going to a state government and saying, like, do you have a question? Like, this should be sort of an ongoing sort of process, right? And I'll come back to that. But before we go there, one of the recurring themes also has been, provider quality, competence, and the quality of care. And I think that has come up throughout. And so, I'd like if we could talk about that a little bit more with regards to Reform 5. We've made some suggestions about how to ensure, better provider competence through mandatory recertification and things like that. Dr. Reddy, if you could, given all your work in this area, what are your thoughts on what we've said may be one way to do it, but what are the additional mechanisms that are really necessary to equip providers to deliver high quality care? And this is across, again, the public and the private sector. If you could share your thoughts on that.
First, the first is to situate the training itself in a location where much of the training can be community connected. If we only train people in the rarefied environment of tertiary care hospitals in big cities, people are not going to be familiar with or sensitive to the needs of primary care. So if much of the training can be imparted in the district hospital, which has to be strengthened, of course, in the process, and with parts of the training, certainly in primary care, a good part of it, and part of the training in tertiary care, then there is a greater ability to deal with the actual problems of the community. The second element, of course, in terms of ensuring that the provider training is appropriate, is to also encourage team-based training. We train people in silos, doctors separately, nurses separately, technicians separately, healthcare workers separately. Whereas, especially in primary care, but even in hospital settings, people have to function in teams. Neither is the emotive element of team functioning, nor the practical element of combining their own observations into decision-making is something that's ever taught. So I think this is an element that has to be fostered definitely in terms of ensuring that the health professional education becomes absolutely useful. And of course, continued connectivity with new developments is going to be important. Continued professional education is going to be important. One of the issues here is in terms of the family connection that is being recommended by the National Medical Commission now, that undergraduate students are being asked to engage right from the first year by visiting the families and getting connected with them. This is high time actually. But the problem is you're throwing a first year medical student into the community without any seniors being available, and neither are they able to understand fully what's going on other than just gather some data, but come back without any idea. And the community is left disconnected because if somebody is coming from a medical college and they're expecting some sort of care element also, nothing is happening. So you have to bring in the senior medical students or others coming in, and they have to become a part and parcel of that. And your team-based training can begin with that element as well. But since I'm having the mic, let me just conclude one thing. There's a certain amount of naivete in what has been recommended about the National Medical Commission in the report. If I quote, the report says, we recommend restructuring of the National Medical Commission. This would involve creating an independent accreditation board appointed based on merit and professional expertise with clear guidelines and accountability mechanisms. Appointed by who? You're left that blank. Because NMC would jolly well say, defenders of NMC would say, people are now currently having the medical expertise, that they have the credentials. But unless the appointing authority is selecting the right kind of people who are not only professionally competent, but are capable of exercising independent judgment and taking the medical education, health professional education on the right lines, you're going to have a problem. Now you've seen that college in Jammu be recently being de-recognized within 1 year of recognition because of some issues related to minority students being admitted. You definitely need to ensure a greater independence. Okay, now let me, since I have the mic, let me end with two parting messages on the report itself, relevant to the whole report. First is we have to work with what we have. I completely agree. So if the perfect is not possible, perfect the possible. The second is regarding data. I think we have been discussing a lot about data, the unwillingness to share data. And I believe it's time to remind everybody in a position of responsibility that India's national bird is the peacock and not the ostrich.
Wow. Okay. I don't know whether I can continue. I mean, that's a perfect sort of conclusion. At the same time, we're almost out of time. Can we do one more, Dr. Swaminathan, just to sort of end this conversation, tying it back to the learning health system? You played a role in institutionalizing processes when you headed, ICMR to make these to create a learning health system. And I just wanted to hear your closing thoughts on how do we create these, systems so that they're not again dependent on a motivated bureaucrat, a motivated researcher, and certainly it's something that's sustainable, really.
Well, I think I also agree that with Dr. Reddy and with many of the speakers, I think we do need a culture change. In addition to all these reforms that we're saying, we need a culture change where it is the learning health system becomes a norm. That is, any program or policy of government that is implemented must undergo periodic reviews, periodic analysis of data, periodic feedback from stakeholders, not just the implementers of the program, but people whom it's impacting. And based on those and on expert advice and so on, it has to be constantly being. I'll give you a recent good example I saw. Karnataka government, when the new government joined about 2.5 years ago, they put in place 5 schemes for women. Okay, these were all schemes that were free bus, free public transport travel. There was one on subsidized electricity. There was one also on, I think, ration, some DBT. Then there was one on skilling. So there were 5 schemes. Now, 2.5 years later, they've done an independent external evaluation of these 5 schemes. And they actually had a dissemination event, which was open to everyone, to the public and to media and so on. And I was present there. So I found that a very good practice, that they very openly and transparently, and
overall, I think the reviews were very good because they talked about what it's done for women, but they also said it's not enough. It's not going to empower women just because you give them free transport or give them a monthly DBT. In addition, you've got to do X, Y, and Z, and the government is now mulling it over. And so I think this needs to happen with all programs, especially ones which are large, very big investments being made, whether they're at the national or state level. So I would say that, the culture change needed here is that strong governance should not be about having the perfect evidence, but having institutions that can learn, adapt, and remain accountable to citizens, as evidence evolves.
Thank you. Thank you so much to our brilliant panelists. And on that note of a culture of openness, transparency, and the national bird being the peacock, I'd like to close this panel. Thanks, Hitesh.
So this is our last panel. It's really been an extraordinary day. For someone like me who is not an expert in healthcare, in fact, I'm not an expert in anything at all, I'm deeply taken by how extraordinary the depth, the detail, the thinking behind everything has been. And it comes out in the sophistication and the subtlety of the presentations. So it's been a great takeaway for me, and I'm sure that this last panel will be no less. It really gives me great pleasure. It says that right here, but it actually is also true. To introduce someone, occasionally you have a chance to introduce someone whose name is particularly who they are. So she could be Chand or Chandani or Chanda, but in fact she is Poonam because she is Purnima, she is refulgent at all times, no waxing, no waning. It's always Chaudhary ka Chand in her household. So Poonam Mutreja is the Executive Director of the Population Foundation of India. And for the last 40 years, she's been a strong advocate of women's health, reproductive and sexual rights, and rural livelihoods. She has co-conceived the popular transmedia initiative, Main Kuch Bhi Kar Sakti Hoon. I, a woman, can achieve anything. Before joining PFI, she served as the India Country Director of the John D. and Catherine T. MacArthur Foundation for 15 years, and she has also co-founded and led the Ashoka Foundation, Dastkan, and the Society for Rural, Urban, and Tribal Initiative, Shruti. An alumna of Delhi University and Harvard University's John F. Kennedy School of Government, Poonam Purnima Chaudhary Ka Chand serves on the governing council of the several non-governmental organizations and is a regular commentator in India and globally for television and the print media.
I was so worried what he's going to do to me. And yes, he did succeed in the introduction, but your Sanskrit and your interpretation of Indian names leaves me with a complex. Okay, so this is the last session today. And I want to do a quick poll and see how many of you are just dying to go home and get hold of your computers or family or a drink, and how many of you want to stay. It's a very confusing choice. Come on, guys, show to Vikram, all of you want to stay. Yeah. Okay, and I'm very honored to be part of this commission, not because there are great people in this commission only, but it's called the Commission on Citizen-Centered Health System of India, and it is the first health-centered report the Lancet has done. Why did it take you so long is my question. And I hope every report of yours is going to be citizen-centered, and that you will do a report just on citizens and their expectations. So let me start. Let me start with, because you haven't, many of you don't have either the executive summary or the Lancet Commission report, which will be sent to you soon. It's very appropriate that this photograph is a Jan Samvad, a people's assembly from Nevada, Bihar, where members of the community are interacting at a health center with the health leadership, the bureaucracy, and the technocrats. And I have to say, while I'll be introducing Amarjeet Sinha later, he is the guy who pushed us into Bihar to do this very challenging work. So let me start by given the reform empowering citizens to be active stakeholders in the health system from a citizen-centered perspective, the first time I had the privilege of meeting, and Amarjeet was there, and perhaps you were there too, I was facing almost 100 either NHM directors or principal secretaries of health at a meeting in Delhi, which the health secretary had convened to talk about community action in health, which is one of the 5 pillars of NRHM, the National Rural Health Mission then, and NRHM now. And I could see the tension in the room. I could see the senior bureaucracy looking at us in PFI and the secretariat saying, these guys are going to hold us accountable. So I came instantly with the slogan, we are talking about bringing public into the public health. And I saw a comfort across the room. And that's exactly how I would describe what we attempt to do. Let me also start with the simple proposition. If universal health coverage is our goal, then citizens cannot sit on the edge and have to be at the center. They have to sit at the center. For a long time, we've changed health systems for people, but much less often we've designed them for people. This reform is really about correcting that imbalance. The reform action is grounded in a citizen survey, lived experiences, and the AGCA, which is the group constituted by an order of government when NRHM was designed, and other NGOs-led initiatives under the National Health Mission. Ensuring that the health system is shaped not just for people, but by them at the core. What is empowering citizens to be active stakeholders? There are 4 reforms we are suggesting here. Shifting citizens from passive survivors, being passive survivors. And when we empower citizens, we are not talking about consultation as a formality. We are talking about a shift in roles. We are talking about about what this means is participation in planning, participation in monitoring, and participation in accountability. And this is not limited to one program or one level of care. This cuts across the entire health system. This is also about institutionalizing mechanisms to redress grievances and find citizen-centric solutions, therefore. So why now? And let me pause here on why this reform becomes unavoidable. The Lancet Commission, as Vikram mentioned in the morning, conducted a citizen survey of 50,000 people, which tells us something very revealing. And I want to acknowledge Sapna Desai and Arnab Mukherjee, the 2 commissioners who led the survey. So in the survey, it's very clear people still trust public healthcare providers. They prefer them for both outpatient care, 65% of the people's preference was for outpatient, and inpatient, it was even higher, 73%. At the same time, only a small proportion of people felt financially protected, which is 28%. And finally, health rarely influenced people's political voting, how people voted. That's something we have to think about. But yet, when we ask people what they want, they are very clear. They want government officials to be held accountable and responsible for healthcare of the communities. These findings show us a clear gap: trust without voice, expectation without real leverage. In districts that perform well on UHC, the gap is of course smaller. Hence, local ownership matters, decentralization or decentralized governance matters, regular dialogue matters. This is the evidence pushing this reform forward. So why these? We have a large number of platforms in India. Already, we have 550,000 platforms, which include village health sanitation committees, Rogi Kalyan Samitis, Mahila Kalyan Samitis, etc. And these platforms do more than spread awareness. They create feedback loops. They make providers visible to communities. They make systems accountable where they function well. We see better access to quality services, which is the big challenge, as was raised by Vikram and many others this morning. And also we see longer facility hours. We see more regularity in doctors coming to the center. We see fairer distribution of services, and where they do not participate becomes symbolic. So there is ample evidence that the citizens' engagement works. And that's what we have brought to this report. And I believe that is new. There's ample evidence that citizens work. We see this clearly across states. And I'm going to take some examples from states. In Kerala, decentralized local governments conduct social audits and that shapes staffing decisions. In Meghalaya, village health councils draw on traditional leadership to anchor prevention and monitoring. In Tamil Nadu, women volunteers clean households, support referrals, and follow up care. In Jharkhand, I'm not only talking about southern part of India, in Jharkhand, participatory learning led to a large reduction in neonatal mortality going at 24, the decrease was 24%, the reduction. In Chhattisgarh, patient support groups improved adherence in chronic care. So the evidence and lessons were consistent. Engagement works when it is close to services and when it is not imposed from above. Reform strategies that are recommended. So what should we do differently? 3 strategies are recommended here under this reform for a meaningful citizen engagement as active stakeholders. Let's dive deep into these 3 strategies going forward. So first, we have to invest in capacity and not just structures. We must shift power to communities, enabling real roles both in planning, decision-making, and of course, service delivery. Support community oversight and accountability. Conduct district-wide Jan Samvads, which is people's assemblies or people's dialogues, and a Jan Sunvai, which is assembly style forums. discuss health needs, service gaps, and solutions in very transparent and open settings. Use consultative processes for the right to health legislation at state level, include civil society and marginalized group in all deliberations, provide sustained financing and invest in training for community members and local leaders, ensure participation of elected panchayat and municipal representatives, link health dialogue to local planning and budgeting processes. Include citizen groups in autonomous purchasing governance, link providers incentive to patient feedback and experience. The goal here is citizens should shape health governance, not just be observers. So second, we have to address the information asymmetries. Citizens need clear information on entitlements. They need visibility into systems performance. They need credible grievance redressal mechanisms. And towards this, what we really need to do is to enable access to personal health information, use digital health records to help citizens view, manage, and share the data, support simple consent-based access through mobile and OTP systems, and use QR codes, feedback, apps, hotlines at facility level, protect patients and staff who prefer safety over quality concerns, set up citizen-led complaints commissions at the district level, and RKS Rogi Kalyan Samiti does exist. Hold annual district grievance settlement days to reinforce transparency. All these recommendations are also coming from the practice and evidence, and create ward level citizens forums linked to urban PHCs, offer flexible outreach for migrants and informal workers. And finally, we tested the IVR system, which is the integrated voice response in Bihar, dashboards, facility level feedback tools, etc. But accountability has to remain human at the same time. So the third, the health system has to confront inequities head on directly. Social determinants shape who engages and who benefits, and this was brought up by Soumya and many others, how the social determinants impact health. And so to address social determinants of health, aligning service priorities with the vulnerable groups, the most vulnerable groups. And both Mr. Jhalani and you will recall that we developed a vulnerability index together when the health of the urban poor was rolled out. I think it's time to take that out, dust it and use it. So recognize how caste, gender, income, religion, and living conditions shape access as well as outcomes. Plan care around the needs of low-income households, migrants, Adivasis, and other excluded groups. Ensure services to not vary by ability or pay or social identity, ability to pay or social identity. Link healthcare services with transport, nutrition, housing, and sanitation interventions, and train health providers to identify the social vulnerabilities and respond with empathy and guidance, support them to map vulnerable households and guide patients through the care pathways. Finally, enforce regulation and grievance systems focused on provider and insurer practices. this level of coordination needs leadership and political commitment, of course, at the highest level. We all know that. And I'm going to end here because we have a great panel. Actually, my slides are valid. I was on time. We have a great panel who I'm going to invite to join me. And we have people who are architects of the NRHM, people who have nurtured NRHM and then NHM. And it's a great pleasure and honor to invite Mirai Chatterjee, my co-chair on the Citizen Stream. Oh. I'll go here. Mirai Chatterjee, my co-chair in the Citizen Stream. Prashant, yes. The bios will come there. Where are the bios, guys? May I invite you, Mr. Manoj Chalani, and of course, Amarjit Sinha. So I'm going to start with you, Mirai. Can we have Mirai's bio on? Absolutely necessary, but I do want to say the most necessary while the formal bios come on. I want to say that Mirai is not only the co-chair of this stream, but also a colleague and a friend who has been part of the advisory group on community action. And we have been fellow travelers for 18 years, rolling out the community action program. But Mirai does much more, as all of you know, much beyond AGCA and what we've done together. So I'm going to introduce the panelists as we ask questions. We had the formal, Mr. Jahlani, the formal discussion that we had with you was we will ask each of you to speak for 5 minutes, and then I'll ask a question. So we are reversing that. I will still ask the question if you can include it in your presentations. I've had an opportunity to discuss so with the others. So Mirai, as a commissioner, you were part of a process, the 5-year process that brought together empirical evidence, lived experiences, policy, ambition across very different contexts. In your view, what must government do to ensure that such reforms move forward and are translated into institutional mechanisms more firmly than we tried to do together?
Thanks a lot, Poonam, and I'm delighted to be here and with my colleagues from SEWA as well. First of all, I want to say that I'll be focusing my remarks on our theme, citizens' engagement. But I want to preface it by saying that I'm a votary of full architecture. I think we've had enough of piecemeal and we've been hearing about fragmentation. So citizens' engagement is in the center, but it's part of a larger public health architecture. When I was thinking about your question, Poonam, the main thing that came to mind was the whole issue of partnerships. It's not possible for government or the private sector or even us in civil society to reach where we want to reach UHC on our own. So partnerships are key. And what we've seen over the years in SEWA and also in AGCA and with many other fellow travelers in civil society is that there have been a number of partnerships, and some of them have been fruitful, some of them haven't worked. But one of the things I've noticed is that there's a lot of stop and start, including the AGCA. We had a long history together. We have a toolkit. We know what we have to do. But unfortunately, that isn't really going forward, and hopefully the states are taking it forward. But on partnerships, a couple of things. You mentioned the information asymmetry. I think one of the things we've seen all these years and what we hear from MOs, medical officers and people at the sub-centers, A&Ms and so on is that they're so busy, they don't have time for preventive health education and health awareness. And I think that's where partnerships could be useful. And particularly by Ashas, by what we in Seva call Agevans, who are grassroots women leaders of cooperatives, self-help groups, union leaders, youth clubs. I mean, there's so much activity, civil society activity, fortunately happening in our mohallas and in our villages. And I think very easily they can be harnessed into this. In fact, they're already doing it. We have the brilliant example of COVID when women were told by their families, their husbands, their menfolk, don't step out of the home, it's too dangerous, what are you doing? But they were out there on the front lines and they were recognized for that as well. So I think that would be my first suggestion, that even if not institutionalizing, at least encourage and support these kinds of efforts. And of course, I would be very much in favor, as many have said, of not only recognizing Ashas, but institutionalizing that further by giving them more responsibilities and proper remuneration. It's high time now. The second point I'd like to make on institutionalizing and partnerships is facilitation. I think it has come up a little bit in the morning, but our experience is that even though we have all these services and schemes, they're very difficult to access for many, particularly the poorest, the most vulnerable, like informal women workers with whom my colleagues and I have been working for some time. 3 barriers. One is the information asymmetry that you've already mentioned. Secondly is documentation. It does find a place in our report, but I cannot stress this enough. I remember one of my Seva sisters, Jyoti Ben, who was a widow for more than 40 years, and she didn't have a death certificate. And it took her 1 year and facilitation by local women to actually finally get the pension so she could buy medicines and so on. So I think these are very important. There are common service centers in our country to help with the digital, the documentation, and so on. But still, there is a gender digital divide, as we all know. And one of the responses that we've been trying to say to government, which could be institutionalized or encouraged, is what we call Seva Shakti Kendras, which are basically facilitation centers, hubs for information, health education, health awareness, and also information about schemes, and then actually linking them and helping them with documents. And in this regard, a recent innovation, which I haven't even had a chance to speak to you about, is the creation of an app, which we call a digital health passport, wherein women's documents are digitized and then they're seamlessly linked to their DigiLocker. And now the next step is from the DigiLocker digital integration so that every time they don't have to upload their documents. So it's a work in progress. It took a little bit of time to get off the ground, but about almost 10,000 women now are linked in this way and growing. So I think the role of what we call voice organizations, membership-based organizations and others is very important. A third thing that I think could be very useful for government, could be institutionalized, could be encouraged, is innovation. We've talked a lot about how people are innovative at different levels. I would like to focus on innovation at the grassroots. What we see is that our citizens, they may not have got fancy degrees, but they are so talented, they're so creative, they have tremendous insight. For example, Nachiket spoke about insurance. Microinsurance, that was an idea that was brought to the world by grassroots women, not just in India, but in the Philippines and South Africa and so many other countries. And then that, of course, gave rise to various other schemes. Similarly, Jan Aushadhi, my colleague Ila here is from the health cooperative. The whole idea of low-cost pharmacies, that came from civil society and some governments like the Rajasthan government. So this kind of encouraging innovation, getting feedback from the ground on occupational health, mental health, oral health, the gaps in comprehensive primary health care would be very important. So some mechanism, of course, there are Jan Samvads, as you mentioned, but I think information and feedback from the ground has been very important to develop new programs which are institutionalized. Another example are the Deen Dayal clinics. For years, we have been saying informal workers don't work 9 to 5. Try, 6 in the morning till 8 at night or more. So why not have the clinics opened up so that they are the hours of work of working people of our country? And I'm happy to say that that has been done in our city. A few more things, because there was a lot of talk on social determinants of health. And as you know, we did discuss it with the co-chairs a lot, and we felt there was already a commission on the social determinants of health. Why not build on that? But I think here, what we've seen is that people at the grassroots, like ashas and civil society frontline workers and Anganwadi workers, they converge. Nobody tells them you have to go and do this and that, because they want to get the work done. They want to reach people. But where we need the institutionalization is sort of a blessing, if you will, or a sort of directive from the top. And I know Amarjit ji tried this in the state of Bihar, where all these things at the grassroots, at least early childhood, water and sanitation, nutrition, some of these come together, at least to make a start. So there's a lot more to say, including about the committees, the AGCA, where a lot of capacity building needs to be done. Yes, the committees are in place. There are 55,000. But I think we need to be honest. How many of those are active? How many of them are doing what they could do? Huge potential if their role is expanded. And that's, I think, where some of us can help. And that kind of thing, which we did in AGCA, does need to be institutionalized. Thank you.
Thank you. Thank you. Thank you, Mirai. Thank you for stressing and re-stressing the need for partnerships and voice and learning from the pilots at the grassroots. I'm now going to come to you, Prashant. Dr. Prashant, I don't see the bios coming up, so I might as well read it. I see myself. You don't need me, you need the bio, guys. Come on. So Prashant is a medical doctor and a health policy and systems researcher with broad interests in social equity and planetary health. He's from the Institute of Public Health, Bangalore. And we had a conversation. I've never had the privilege of meeting you. I only met you on the internet, unlike the other three panelists who I know well. So look forward to getting to know through what you say and future. Thank you.
Sure, sure. Thank you so much for this opportunity. I'm guessing I might be here because...
1 second.
Yeah.
I failed in my duty. I've sent you
The question, yeah.
So how can the state redesign health institutions so that empowerment is anchored in individual citizens as a rights-bearing subject? What institutional shifts are needed to make individual freedoms and health entitlements real and enforceable?
Thank you. Thank you very much. I'll certainly address that question, but I just want to also acknowledge that this being the last session, I think initially I was wondering why is the citizen session? I think Mirai also brought it up towards the end of the day. But I think it's, not citizen session, the community engagement and citizen engagement session. But I think it gives a little bit of a big picture view on listening to all of the recommendations and trying to locate it within the lens of citizen centricity, which has been the intent of the commission. And I suspect I'm here because I was also one of the reviewers. I hope that can be discussed. So I had a little bit of two iterations of reading the report. But I think, as is my role, I would like to look at it from a critical lens. I think there's so much to celebrate there. And I'll leave all of you to read it and celebrate the wonderful things that have been said in the report. And I thought it might be useful to, like Vikram invited us in the morning, to also look at it from a critical lens so that we can deepen and practice it better. From that, I offer a few reflections which will address the issue of institutionalization. For me, I think one thing that has been a little bit incoherent is why citizen centricity. And to some extent, I see several places where arguments are made not only in the report, but in wider discourse, that citizen centricity can improve efficiency, or it can improve effectiveness. People make arguments about how coverage can improve if communities or people are involved. I think these are very poor reasons for us to be talking about community engagement, because citizen engagement, and I'll talk about the distinction what I see with community engagement, and I really want to hear thoughts from others on this. Citizen engagement is, after all, an expression of democracy, isn't it? It's an expression of citizenship in some sense. If I am able to engage, not only whether a platform is provided, but I have the freedoms and abilities to claim that platform and voice and obtain what I wanted from that voice, that would be the full circle indeed of democracy itself. So I wanted to premise that, because oftentimes, even in the morning, there was an argument made about how the revenue issue and how sometimes it can lead to inefficiencies. I think this has to be kept aside because it's an important value of the system itself. In terms of institutionalization, I was a much younger doctor when the AGCA process was going on, and I was practicing in an Adivasi setting in southern Karnataka, and it was fantastic. The fact that there was a group that was pushing for community engagement from the top, I think that is very vital, because I feel like we have moved a few steps back by not having sufficient top-down push for a bottom-up process. Because without that, I think systems go into a space where they create engagement without anything, right? You know, engagement happens, committees happen, there are minutes written, people meet, etc., in the Yogi Kalyan Samitis, Jan Arogya Samitis, etc. But it's not really translating into space and a voice where real action on health can happen. So I think the key really is, how do we go beyond the activity into really creating true engagement? And there I feel the role of national government and the role of state governments in owning community engagement and not leaving it be to these groups. If we talk community engagement these days, everyone says, yeah, JS mass is happening, no problem, minutes are happening, people are coming, etc. But it's being done in a very instrumentalized way, and I think that's important. Third one on institutionalizing a culture of engaging communities. I think Dr. Soumya brought it up. I think I feel when I look at the things, because I continue to do some community health work, what I think we have not given is the software of doing community engagement, because we have done ASHA training, A&M training, etc., etc. But like the commission highlighted the work of participatory learning and action, PLA. I think it's fantastic, because not only PLA, there are many such models across the country where people have figured out how to do community engagement. And many of us who do it, we struggle with it. And we know that community engagement is not the beautifully romantic process where you invite, you create a space, people come, they claim it, and they say, oh, I need ABC, fine, we'll give you XYZ, and then everyone is happy. It rarely happens that way. If you throw open the space, people come at you with difficult questions. And I feel somewhere engagement of that kind, which used to be happening, I mean, at a relatively young age, I think I've become a little bit of a hopeless romantic. It used to happen, I thought, when I was younger, but I feel like engagement is becoming more transactional, like the airline engagement, where we are customers. I'm treated with dignity, there's the namaste, there's nice, and there's nice pleasantries. It's not really engagement, So that's I think, how do we get to that culture where engagement is in the part of that? And maybe last two comments. I'm aware I'm taking too much time. The last one I felt is on the idea of citizen, and this is a little bit of a philosophical reflection. Maybe it's a sign of times that collectives and communities morph into citizen, and I don't mean it as a very pointed critique at the commission itself. I don't think, I think it's very important. Individual freedoms, like the gender folks have shown us, like the feminists have shown us, achieving individual freedom is so important, and individual centricity is extremely important. But what about collectives? And the reason I say this is, so many, I mean, for just one example, we work with Adivasi communities, and one of the important reasons why they are not able to achieve their health rights is because forest rights are not achieved. So there are entire neighborhoods which remain without roads, mobile connectivity, and the digital mission, etc., because forest rights are not available. Now, it's quite possible that we can engage them in our health committees without it actually helping them overcome these wider structures. So how do we move? I worry that in our move towards individual freedom and the empowered individual citizen, we forget that a lot of action on social determinants of health has to happen at collective building, at community building, at building a sense of kinship and solidarity across people, etc. So I think we should, in the way we define citizen centricity, we have to locate citizens within that wider constitutional principle of fraternity and collectives. And the very last one is the role of private capital and corporations in framing citizen rights and citizen health is increasing. And I think it's also had very good things. There are several nice things that are coming out of CSR and the interest that corporations and private capital takes in the healthcare industry. But it also tends to frame the engagement in certain ways. And I think we should all be critically aware. There's the whole discourse on commercial determinants of health in addition to the social. So I feel like we should make conscious effort that the Commission's citizen-centric frameworks are purposefully conscious of these interests, and purposefully they make space for an opposing kind of interest, which does not get entangled in the corporations and private capital. Thank you.
Thank you, Prashant. You know, the commissioners, and especially the last few days, the conversations as we go euphoric that 5 years is over and we've done the report. Everybody, starting with Richard, Vikram, and so on, have been saying our work begins now. So community engagement, while we may have documented whatever experience there is, our work really begins now. Not just the advocacy, but actually bringing life to these institutions. Yes, training modules have been framed, designed. It takes 2 years to get one approval, you know, and the challenge of Mira's hair went white, but mine didn't for genetic reasons, but we have struggled and worked so on this community engagement, but we would have, the reason we are still enthusiastic, alive, and ready to go is because we worked with two of the most wonderful JS policy, both Mr. Jhalani and Amarjeet. We reported as AGCA too, so I have two bosses. Mira, we have two bosses sitting amongst us. Let me start my question to you, Amarjeet, first. Amarjeet, as you know, was one of the architects of NRHM. He was not only one of the architects of NRHM, I'd say he gave, if it's possible to be part pregnant, he did. He gave birth to, with others, gave birth to NRHM. And also, very importantly, he nursed it. And not only he nursed it, he continues to document. Last month, Amarjeet had the audacity to release 6 books on the same day. One was focused on health, one was focused on education, reforms, nutrition, climate change, and one, we had the proud privilege of documenting in one of the books, the community action for health. So Amarjeet continues, he's a bureaucrat with a fire in his belly. I don't know if you've heard that expression, but Amarjeet, over to you. And the question, I think you don't need a question, but if you could talk to us about in 2005, when community action for health was a significant pillar, thanks to you and other colleagues. What were the most important political enabling factors, political, institutional, or societal, that made this program even possible? And where do you want to see it go now that we are lending voice and rearing to take this forward with more alacrity.
Thank you. In fact, before responding to your question, I just wanted to make a few remarks around community action, the point that Prashant also flagged. You know, for public services, and especially in a country where public services are notorious for non-performance or inefficiencies, it becomes very necessary to hold it accountable. How do you hold it accountable? Unless you hear citizens' voices. Now, citizens' voices don't come on their own. Empowerment, agency, and decentralized community action never happens on its own. It has to be made to happen. How do you make it happen? Now, this is where the civil society engagement becomes very important. In making it happen, that concerns of citizens are fed back into the system. Now, anybody working on any public system, he needs a very independent, transparent feedback on what works and what doesn't. In the absence of forum like this, you will not be able to get that. And that was the thought process behind the advisory group on community action. When we wanted the best of civil society organizations working in health, a little distance away from the Nirman Bhavan, sitting quietly at the Population Foundation of India and working to look at primary health centers, community health centers, what are the services, what are the challenges, what is likely to make it better. Now, as time evolved, and again, after a long innings in education and then health, I spent many years in the rural space. And in the rural development space especially, the work with women's collectives, Mirai engages a lot with them, but women's collectives, the Rural Livelihood Mission, which now has more than 100 million women in rural areas. Now, one issue that we need to understand when we're talking about institutionalizing, and especially when you were showing your slide on vital determinants of health and community action, I would have been happier to find some greater insight on a possible Panchayati Raj self-help group partnerships, women's collectives and elected leaders working together, because the constitution has given them a mandate. 29 sectors in rural and 18 in urban. I know that but when the PRI and SHG work together, Kerala, we celebrate the elected leadership and the local government. That local government may not have been as effective as it has become with the presence of the neighborhood household groups in the form of Kudumshri women's collectives. In a manner, there's a countervailing presence of a community organization and elected leaders together are held accountable for a system. And if you want to hold somebody accountable, decentralized community action, untied funds, they have to become a part of that whole process. Just a small suggestion, try and see, because the earlier session, Santosh, I would say, was looking at technology as a solution to everything. I beg to differ. Technology is only a means, it's not an end in itself. We have made that mistake so many times, we still want to make that mistake. Yes, technology enables many things. But in the absence of that last mile facilitation, many things get stuck. One of the strengths of the Rural Livelihood Mission has been these 500,000 foot soldiers, women who were poor, who've come out of poverty, becoming a community resource person for community mobilization, becoming a community resource person for agriculture, Krishi Sakhi, becoming a community resource person for animal husbandry, a Pashu Sakhi, becoming a banking correspondent Sakhi. I'm giving these comparisons because we've reached a stage where we actively, both for education and for health. Currently, I'm involved in a study on public report on secondary education. We've just completed our work on Delhi. Urban areas, it was mentioned, we need to do something about urban. I'd only say the earlier you get familiar with the underbelly of urban, you'll realize what the challenges we face. It's a completely new world. At least I can say in my case, there's been a lot of learning just by visiting these households. when you realize that 15, 16 people are living in 2 small rooms, how can children study there? I'm raising these issues because urban is a bigger challenge. Friends, if we really want to move in, and there was a talk about panchayats and how they can, the ranking of panchayats and all, many points were made about health index. I think it's time to move away from fragmentation. I think Mirai also made that point. There is something called a Panchayat Achievement Index, which the Ministry of Panchayati Raj has been working on about 216 different parameters from the Sustainable Development Goals. And since it is community validated, and since both the women's collectives and the panchayats have a role there, we do get a sense that some of that is able to capture the ground reality as exists. Can our interventions for community action engage with those processes, engage with the larger decentralization mandate? I do agree in the urban, the last level of community elected leaders of ward is far too large. It is not conducive to community action. You need basti level elected leaders in urban for it to be effective along with the community organizations. So clearly some of these institutional questions, I would have been happier to more focus on many of these areas, because the lessons from Kerala are also lessons of this kind. I would just like to, by way of a last point, we are currently engaged also in another study, a public report on collaborative governance, where, Elena Rostrom, a lot of the work of a lot of other thinkers, economists, how exactly, when do non-state actors have a consensual decision-making role? Are we providing that? Because I think in some manner, the time has come to reflect on many of our lack of success or lack of quality outcomes, whether in schools or health centers or Anganwadis. When we reflect on it, we will find that decentralized community action is a factor. And there is the 2023 RBI study, which points out that provinces which have devolved authority to local governments have better health and sanitation indicators. They are also the provinces where the per capita consumption expenditures, a proxy for incomes, is higher. These are also regions where the human capital is better, where the multi-dimensional poverty rates are lower. If all these go together, then clearly decentralized community action ought to become central to every sector, especially health, nutrition, drinking water, education, and so on. Because these are the sectors, whereas Professor Ashoka Modi at Princeton says, when he says, India is broken and hard to fix, these are the questions he raises. How do we make a difference here? Can we make a difference by actually attacking the challenges of community action? And again, as I said, empowerment, agency, decentralized community action does not happen by itself. It has to be made to happen, which means your whole thought process has to be very different, which recognizes the agency of local communities in determining the kinds of health systems that cater to their needs. Thank you.
Thank you. There is so much you've said that clearly, if you were still in the health ministry, we could have taken on. But I hope outside the health ministry, we will have the voice to take on, to take us forward. And, even more than from the successes. And that's something within AGCA, when we evaluated our own work, we criticized our work much more than we appreciated to create a change. I want to, last but not least, come to the person who really nurtured the NRHM as over 30 years of experience in public policy, Mr. Manoj Jhalani, and socio-economic development with a focus on health always. He served as secretary, he has served as JS and then as additional secretary and special secretary, Ministry of Health and Family Welfare from 2012 when I joined PFI and started coming to you to 2019 when he left to join the WHO. But the good news is his experience with WHO Zero is going to give us what has worked in Asia and are we the best? Sorry, no. Okay, so Mr. Jhalani, as I said, we reported to him when he was GS. We went to him even more when he became additional secretary. And I would, if I may take the liberty to say, a very quiet but determined bureaucrat from and had the privilege of really being supported in every way, including when we said violence should be a public health issue. Mr. Jhalani was receptive and tried to bring us in. Thank you.
Thanks, Poonam, for such a nice introduction. It's always difficult to come after Mr. Amarjit Sinha. But coming to the issue that you raised, I mean, firstly, I'll just build up on what Mirai and Prashant and Mr. Amarjit said. One is that, health systems are for the people. So they naturally have to be people-centered. I'm slightly deviating from citizen-centered to people-centered, going by the spirit of Vasudhaiva Kutumbakam, There could be non-citizen migrants, etc. Now, the other thing is, we need to look at health in the larger things. And there I felt that the focus on universal health coverage, which is largely then focused on service delivery, improving access, quality, affordability, etc., to more on the health for all, which then really brings in the multisectorality, multisectoral action. I would have believed that maybe our focus should have been on health for all. We heard people talking of preventive health, promotive health, talking about social, economic, environmental determinants, commercial determinants of health. So I think, and then, the things that Mr. Amarjit Sinha was talking about will really factor in much more when we start talking in terms of health for all, rather than looking at the dimension of just the UHC. The third thing I felt was that it is high time. We are talking about, citizen engagement and engagement, we talked about, raised some experiences in terms of, so engagement happens in terms of information, engagement happens in terms of consultation, in terms of collaboration, and then finally more in terms of as empowered agencies, okay, where they really plan and take decisions and hold providers accountable. So on this spectrum, when we see our experience, we are largely on stage 1 and 2, information sharing, also in terms of consultation, and all our field workers, Ashas and Anganwadi workers and ANMs, etc., have been doing a great job in terms of generating demand from the community, enhancing, say, institutional delivery, vaccination coverage, ANCs and all that, and family planning coverage. But really, we have not moved to where citizens really are not the passive beneficiaries, but really having the agency. And I think that's a time where we need to really move towards right to health. So I noticed, it's right mentioned, it's implicit there, but I thought we could have been more ambitious in terms of trying to emphasize in terms of moving more towards, explicitly towards right to health, where then the people or the citizens then are really not a beneficiary or a passive recipient, but really have the agency and they are entitled and they have the rights, and the state becomes a duty bearer to provide the rights. We had if you look at the SSA experience, we had the Sarv Shiksha Abhiyan, which was implemented, prior to the DPEP, and then 2002, under Right to Life, Constitutional Amendment Act was introduced that we will have, within the right to life, right to free and compulsory education. as provided under an act. And that act came into being in 2009 with the rules in 2010, and then the Right to Free and Compulsory Education Act came into being under Right to Health. Okay, we don't have under Right to Life, but we don't have Right to Health, which is so close to Right to Life. The multiple reasons for it, including the fact that public health and hospital being a state subject, etc., etc. Although, I mean, one could argue that there could have been occasions because besides the I think ICSER, that covenant, which India is also signatory, says that we will progressively advance right to health. So, you know, to give effect to that covenant, we could have done it. But anyways, I mean, we could certainly create an enabling space and encouraging states to really create right to health. Now it's a good time where, with all the investments that have gone in under NRHM, NHM, etc., we should be able to at least assure a basic level of health services. We could begin with that and then incrementally move over, but that will help establish systems which will then make a paradigm shift from people being an agency and people entitled rather than being the beneficiary. And I think we looked at global evidence. I mean, WHO study says that 164 countries where they studied, it has had a positive bearing in terms of improving the maternal and newborn child health outcomes, and also in terms of responsiveness of the system. But I would agree with what Prashant was saying, that health systems exist for people. So this is not a goal that this will help in terms of achieving something. This itself has to be a goal in itself. So I mean, it really is to be on a higher pedestal, that this is the objective of health system, that people are at the center. In terms of, you know, what Mr. Amajit Sinha sir was mentioning was around various opportunities of decentralized forums for collective action at the community level, and trying to leverage all those you know, forums that exist in terms of self-help groups and whole gamut of collectives that exist. And it'll be good to really look at the potential of trying to leverage them. The big question here is, how do you create, I mean, you know, this issue came up, Prashant said this must be pushed from the top, and there's a need for this to get created. But how do we create an incentive in a political system to really want to empower the citizens? I can say bureaucracy will never be keen, you know, when I was talking about the entire spectrum of engagement. So they'll be very happy with the first two part of it, where information sharing is there, consultation is there, because that helps in terms of demand development, but they would not like them to be held accountable. And my friend who served in Africa, he was saying that a lot of these development partners were having a meeting, and they were talking about community empowerment and all that. And then the director finally said, "Have you ever seen mouse belling a cat?" See, I mean, we need to get more real in terms of we need to be really creating an enabling thing. And the other thing is, like I heard when Mr. Sinha was mentioning about this Panchayat Achievement Index or Empowerment Index, when we are trying to measure progress, you know, is there any measure or indicator which is looking at the people-centeredness of the system or the empowerment of the citizens? Okay, is there an indicator? While monitor IMR, MMR, I look at all the gamut of output services, but we really need to identify those indicators which can be easily tracked, and based on that, states could then be incentivized. You already have an incentive pool within the NHM and RHM, 30% of the resources, which could then be utilized to encourage states to move in a direction of empowerment of, say, Panchayat Index, etc., etc. And so those could be some ways to encourage states to move in this journey of empowering citizens and engaging with the citizens in a more meaningful way. Thank you.
Thank you. Do you think the Niti Aayog and government is ready for this indicator? And do you want to ask Richard if he's ready for perhaps a global commission, not just an Indian commission on right to health? Thank you very much. I know we've run out of time, but I do hope, and I would like to, half a minute? No. Okay. So I knew I had a few seconds, so I wrote down what I'd like to say. So what kind of health system will we pursue? How will we bring honor the public and people of India? At this point of time, we are focusing on. So what I'd like to suggest, the way forward, not just the way forward, how do we choose the path? And the path, I'm inspired by Desmond Tutu, the great Desmond Tutu, who walked the path of radical empathy, courageous truth, and unflinching hope. So we go, I hope, with a lot of hope to implement collectively in collective action a lot of the recommendations.
Thank you. Thank you. That reminds me, of course, that's an echo of Amir Khusro. "Bahut katin hai dagar pani katki." So the moon did shine in full refulgence for the last. You can applaud. I was not wrong. It was a great panel. Thank you all very much. So we're approaching the end. I'm sorry to tell you that we're approaching the end. And you know, when there's a fireworks show, what happens at the end? You think just about everything has exploded in marvelous colors. And then there's this incredible set of explosions at the end with the entire sky lights up. And that's what we're going to have now. So let me just, Richard, I will not read this very long introduction to you, but I do want to say the sophistication of my team is such that in all other cases, it has always been my pleasure. But in this case, it is my honor. And I do want to say it is my honor to welcome you to the stage. Dr. Richard Horton is the editor-in-chief of the Lancet, and the Lancet, I think many would say, is the world's leading medical journal.
You made it to the end. We're almost there. And I am so immensely grateful to you for holding out for this last few minutes of reflections on the day. Now, there have been lots of opportunities for thanks throughout the course of the day, but I want my chance to say thank you. And I really want to begin by offering my sincere thanks to the whole team, to Vikram, to Poonam, to Taran, to Anushka, to all the commissioners, to Hitesh, thank you for your MC role, which has just been fantastic today. I also want to thank my colleague, Pam Das, who's really been the person who's been at the front end of this. I'm just the hanger-on. I work for Pam. She's my boss. And it's a real pleasure to have the opportunity to thank all of you for your contribution. Now, look, this is in some ways terribly embarrassing. You've heard the most amazing panels during the course of the day, and now you've got me, and I am merely a student of India, and I don't bring any expertise at all to the discussion. So my observations are as a passionate outsider. We're meeting on the almost eve of your Republic Day, January the 26th, a day that commemorates the adoption of your constitution and your transition to a republic. Now, as a student, as a visitor with a passionate interest in India, I find it interesting to frame our discussions today against the values and the commitments that are expressed in one of your country's founding documents. because I see that there's a conversation that's taking place between this commission and your constitution. There are lines of communication between the two documents. Now, much is made, and you just heard a little bit about it in this panel, of the importance and the interpretation of Article 21 about the protection of life. And the Commission indeed refers to Article 21, actually. And when you get the full report, it's on page 26. But there are three further principles in the Constitution that I think we should underline. Number one, the right to equality. The right to equality before the law for every single Indian citizen. Article 14. Second, the responsibility of the state to secure a social order for the promotion of the welfare of the people. And I quote, a commitment that justice, the word justice is there, justice, social, economic, and political, shall inform all the institutions of the national life. And the health system is a social institution. So Article 38 refers to the health system. And third, the promotion of cooperative societies. The state will promote the formation, functioning, democratic control, and professional management of cooperative societies. Isn't that what we've been talking about all day? Article 43B. So, equality, justice, and a cooperative society, a trinity of constitutional values that provides a foundation for our commission, and which this commission embodies. But I don't want to be naive. I want to be realistic about the world we're in today. Rewind. It's 2005. I'm sitting in St. Paul's Cathedral to celebrate actually, that year's G8 meeting. Remember, that was a time when Russia was welcomed to the Club of Nations. The G8 was to be held in Glen Eagles in Scotland, and it was to signal the importance of the United Kingdom government's Commission for Africa, which had just been published. It was a supremely optimistic vision for the African continent. Remember, please, this time, the Commission on Macroeconomics and Health had been published in the year 2000. It identified a finite set of diseases as the origin points of poverty and the barriers to economic growth. The creation of the Global Alliance on Vaccines and Immunization, also in the year 2000, that since then has immunized over 1 billion children and averted over 20 million deaths. And just a few years later, in 2002, the creation of the Global Fund to fight AIDS, tuberculosis, and malaria, a fund that has saved over 70 million lives, currently over 25 million people on antiretroviral therapy, over 7 million people treated for TB every year, and over 160 million insecticide-treated bed nets. The point is that 20 years ago, we were creating transformative institutions in this world at a moment of unprecedented optimism. And it led in my country in 2015, for the first time, an achievement of the 0.7% of gross national income target for overseas development assistance. But my goodness, how long ago that seems today. So what about today? The clearest statement of the predicament we face, I think, is in a wonderful book. It's a short book. I only read short books now. Giuliano da Empoli. Anybody read The Hour of the Predator? Go and read it. Published last year. He writes, In this new world, everything that needs to be settled will be settled by fire and sword. Peace has been replaced by war, multilateral negotiation by unilateral force. We live in an era where attack seems cheaper than defense. There are no rules anymore. Defenders of freedom are singularly unprepared, and although we possess more information than we've ever had before, we seem less capable than ever before of predicting what will happen next. The age of hopeful globalism from 2 decades ago has given way to an era of narrow nationalism. And we are seeing the achievements of those 2 decades begin to fracture. The Global Fund and Gavi failing to meet their replenishment targets, the World Health Organization diminished, even humiliated, and multilateral treaties being incinerated. So I do not want to be naive, but it is into this politically more toxic space and time that we are launching this commission today. And yet, despite the forces outside of this room, I am extremely optimistic about what we can achieve together. And let me give you 5 reasons why we are going to succeed. Number 1, quite simply, the evidence in this commission. Immensely strong public support for a public sector. The fact is, the people are with us. Strong public trust in government. Second reason, it can be done. 2 decades ago, I did a lot of work on women's and children's health with WHO in Geneva. And we were particularly concerned about the stubbornness of maternal mortality failing to fall in so many countries around the world. What have you achieved? Wow. Your maternal mortality ratio in 1997-98 was around 400 deaths per 100,000 live births, way above the world average. India was suboptimally performing, let me put it like that. By 2023, the latest data, that number had fallen to 88 maternal deaths per 100,000 live births, way below the world average. You achieved something in 2 decades in India that no other country has achieved. That is a transformation beyond any reasonable expectation. You did it through a combination of interventions, the National Rural Health Mission, which we just heard about, antenatal care, facility births, a whole array of factors. The point is, it can be done. Third, India can afford it. Just in the last 10 days, the World Bank and the International Monetary Fund have released their latest economic growth data for all countries around the world. India is the fastest growing economy of any comparable country in the world today. You're expecting a 7.2% growth. This is World Bank figures, 7.2% growth for 2025-26, 6.5% next year, 6.6% the year after. That is the kind of growth that we in the West dream of. But you are delivering it year on year on year. And those might be underestimates if the impact of technology and artificial intelligence really hits, and if you manage to renegotiate the terms of your tariffs with our friend in the United States. The country has the fiscal space to invest in health if it chooses to. Fourth reason, your strong and vigorous democracy and civil society. I just had the opportunity to visit the Jaipur Literary Festival. Wow. It was the best literary festival I've been to in my life. Vibrant in every possible way. Debate, argument, reflection is in this nation's DNA, which gives the country the freedom to learn from any other country in the world. If Srinath was here, I think Srinath had to go, but in his book, a copy of which he very kindly sent me, he talked about how important it is for India not just to be a representational democracy, but for the country to be a participatory democracy. And that is, of course, what we just heard about in the last panel. And the final reason why I'm optimistic is that there is a very interesting dividend from the demise of globalism. The argument is that globalism put global interests above national interests. And as a result, nation states broke their obligations to their peoples. International trade became more important than national development. Public expectations about what the state could achieve and deliver diminished. So the national interest took a back seat during this era of globalism. But the present reassertion of the importance of sovereignty over supranational governance means that we have an opportunity. And that opportunity is the return of the nation state. And it's a moment to invite the nation state, to invite national governments, to reconnect the state to the citizen, politics to the people. Now, in the spirit of that renewed partnership, I have 3 observations about further avenues that the Commission might wish to explore. It's kind of my little bit of peer review of the Commission. First, dramatic improvements, and I mean dramatic improvements in health, can be achieved early in the path to universal health coverage. You don't have to wait for universal health coverage to be reached as a destination before you can make progress. This was the message of our 2024 Lancet Commission Global Health 2050. And Srinath, if he was here, I would praise him because he was a co-author of that initiative. The trick is to prioritize conditions and interventions that contribute most to mortality and mortality reduction. And if you do that, we judge that you can halve premature death by 2050, very close to your Biscuit-Barrett target date of 2047. Second, and it's been mentioned sporadically during the course of the day, but I really want to underline it at the end. Let's not forget the contribution of the education system and what it makes to health. In 2025, we had our second Lancet Commission on adolescent health, and that argued that multisectoral actions on mental health, on nutrition, and on sexual and reproductive health are all needed and can be secured by coordinating health and education systems together. Schools and the staff in schools have an absolutely decisive part to play in the early identification of health problems. Schools act as platforms for interventions, and if we could get interministerial collaboration between health and education, we could deliver huge and so far unrecognized benefits. And the third area, the third avenue that I think could bear further reflection is around specifically the issue of gender equality. Now, this is touched upon in the section in the report on social determinants in health, but I just want to re-emphasize the importance of gender equality and the contribution it makes to advancing health. Sarah Hawkes and her team in the Lancet Commission on Gender and Global Health showed last year the evidence for health inequities between men and women is long-standing and widespread, and the health community commonly overlooks the role of gender in shaping health outcomes. Let's not overlook it anymore. I'll give you an example. I was out on the balcony getting some quasi-fresh air earlier today, and a very kind delegate came up to me and we had a very interesting conversation about child marriage in India and the contribution that in some states, not all, but the contribution that some states, child marriage makes to gender inequality and adverse health outcomes. She spoke to me about the importance of social norms in the country and how it's important to address those social norms. So there's, I think, areas of further work that we could look into. Now, I'm sure many of you, if not all of you, read Amartya Sen's and Jean Drèze's book from 2013 entitled An Uncertain Glory. You'll remember that the subtitle of that book was India and Its Contradictions. And I think these contradictions have been fully expressed, very clearly expressed in the commission you have before you. Now, Amartya Sen and Jean Drèze argue that the lives of those left behind during India's astonishing economic revival had received far too little attention. They argued that there's been a surprising, indeed extraordinary tolerance of inequality, that poor health is perhaps the biggest adversity facing India today, and that there was an opportunity for a reorientation of India's democratic dialogue, including recognizing the pivotal role of the media in that dialogue. So is such a reorientation possible in that dialogue? And again, I want to be optimistic, but not naive. A writer I admire greatly, Hannah Arendt, who was a philosopher who escaped Germany before the Second World War and went to live in the United States, wrote an essay in the New Yorker in 1967 entitled Truth and Politics. And it's so relevant to the times we live in today. She observed with disturbing resonance that truth and politics are on rather bad terms with each other. Well, boy, they sure are on bad terms with each other today. She observed that no human world, and I quote, will ever be able to survive without men and women willing to say what is. But factual truths are vulnerable. She writes, the chances of factual truth surviving the onslaught of power are very slim indeed. We're seeing it today, every day, the vulnerability of truth. Hers, like ours, was an era of what she called organized lying, an age of propaganda, one characterized by mass manipulation of fact and opinion. This is 1967. No social media. Elon Musk was only 4 years old at the time. But the same predicament prevailed. So just as we might feel in 2026, Arendt was writing 60 years ago that it was factual reality itself that was at stake. And when I wake up every morning and turn on the BBC radio news, it feels like that. Factual reality is at stake. Truthfulness has never been counted among the political virtues, she suggested. But here comes the reason for optimism again, because facts are very annoying. They are willful. They are strong. They are stubborn. They are coercive. They are despotic. Facts are beyond agreement and consent. And in their stubbornness, facts are superior to power. Take that, President Trump. This commission is replete with strong facts and stubborn truths. And these facts and these truths will win out. Now, our commitment at the Lancet to you is to support an afterlife for this commission. We are not going away anywhere. This launch and publication today is not the end. It is simply the end of the beginning. And so now we move on to phase 2, expanding the coalition. We met yesterday with Professor Vinod Paul at NITI to talk about a collaboration that we might be able to create together. Stronger monitoring, better data, creating platforms and spaces for deliberation, enabling active participation to advance the vision of this initiative. So let me now end where I began, thanking Vikram, Taran, Poonam, Anushka, and all the commissioners and contributors. Friends, I know your intention was not to write a prescription. You wanted to create a conversation, a dialogue. And based on the extraordinary panels we've had today, I think you succeeded. But don't forget these 4 words: life, equality, justice, and cooperation. Your constitution wills it. Let's build the coalition to deliver it. Thank you.
Thank you, Richard. Thank you. So I know most of you did not believe me when I said the ending is going to be fireworks of that. So I hope you have more faith and confidence in me now. Richard, thank you so much. Just a quick word maybe at the end here from our colleague Tarun Khanna. Tarun Khanna is the founding director, faculty director of the Mittal Institute. He's also a professor at the business school at Harvard, where he studies entrepreneurship and the ways in which it leads to economic growth and solves major problems around the world. Tarun, may I ask you to come up for a minute or for many minutes?
Well, Richard has always been a tough act to follow, and since my voice is almost gone completely, I can officially plead an excuse for not doing so. I don't have much to say. I mean, it's just been an extraordinary delight to listen to all the panelists, and Vikram and I had to go to a side meeting along in the afternoon, and we were commenting to each other in the car that the quality of panels has been extraordinary. So many thanks to all the panelists, all the people who worked on this. I'm sure Hitesh will offer his formal thanks, but just the, of course, the Lancet team, the PFI team have been extraordinary. And the Mittal Institute team have all been just truly exemplary, down to every single person that you see outside, making sure that the proverbial trains run on time. Thank you, thank you, thank you. Richard just mentioned that we are going to be embarking on, I guess the opposite of the end of the beginning is the beginning of something, but not quite the end, not the beginning of the end, the beginning of the interim something or the other. And it just made me, it made me reflect on what the beginning felt like when Vikram and I had a phone call during COVID in 2020. And he proposed, of course, I knew what the Lancet was. I'm an applied mathematician. I don't know, I mean, I know about the Lancet and I've read the occasional article in it, but I'm not a health person, even though everybody in my family, you'll be relieved to know, is a medical doctor. I'm the black sheep. So, you know, so we persuaded each other this was a good use of time to do this. And I'm so grateful. The reason I'm bringing this up is I think it's very important for us as a collective, and I endorse the admonition that we should be broadening the collective as much as possible, being very inclusive to different perspectives. But it just seems to me that the initial conditions of how we set the terms of that ongoing collaboration are so important. The one decision that we made was that back in 2020 was that we would try to represent as many, if not all, facets of society, not just, maybe it's a bit unfair for me to say so, but looking at it as a non-health outsider. It looked to me like the previous commissions were primarily from the medical community and primarily from the public sector, leaving out, as we've heard, despite the private sector being unregulated, the facts on the ground are that a significant proportion of outpatient care, and in fact, even inpatient care, a sizable proportion is done by the private sector. So it just seems, frankly, silly to leave out the private sector. It's just not something that by design is going to take off. But the point I'm making is that I think one of the most, perhaps the main consequential decision that I think we made was to have that very inclusive table. And I don't want to go into any details, but it really, I think I need to salute all my commissioners, all my fellow commissioners, for being such good sports with dealing with points of view that are completely antithetical to their own in many instances. Even sometimes, dare I say, violently against what they believe to be their principles. I may not agree that their principle is the right one, but that's neither here nor there. They did believe it, and they had the confidence in the rest of the people around the table that at least these are people of good conscience and good intent and good faith and good values, and that they would bring their best selves into the conversation. So that's really all that I want to say. And I hope that, I'm just so grateful for being part of this journey. And it's lovely to see a final product, even though customs won't release it. There's India for you. Sooner or later, it's online now, so we all have access to a printer if we prefer to consume content physically. It's just been a privilege. So thank you very much, and please stay involved in any capacity you wish. Thank you.
Thank you, Tarun. So I just want to take up 1 minute. I know I'm all that stands between you and your homeward journey, but it's important to acknowledge, as Tarun said, all the people. Look, there are really too many people, but I want to say, especially to our partners and for us at the Lakshmi Mittal and Family Institute, the Lancet, the Population Foundation of India, Lok Swasthya Seva Trust, and Friends of Mewar, who helped us make this particular event possible. And you heard earlier the larger list of partners who had actually been with us on this journey over the many years. It takes a village, in fact, many villages, and it could not have happened without all of those villages. I also want to say that our team here, along with the team at the Population Foundation, have really done an extraordinary job of putting things together. So can we just please have a vote of thanks? Both our team and the PFI teams are fantastic, and because there are so many people, I will not name everyone, but I want to say that I've never worked with people as dedicated as that, and they've got they did such a great job. And really, I want to end by saying congratulations. I began the morning by saying that we are here to celebrate. And there is something to celebrate. It's been an extraordinary journey through some very trying times, a few crises. But as I said in the morning, it's not often when you start out with this kind of ambition and you achieve such a great measure of it. If this is the end of the beginning, I'm very happy to be along with all of you for the rest of the ride. I'm sure that the road is long and there's so much to do. Richard, thank you for your passionate words as you were talking, especially as you were talking about doing things. I was reminded of a very beautiful verse from the Bhagavad Gita, and maybe that's the best way to end, which is to say, Karmani eva adhikaraste ma phaleshu kadachana. Your entitlement is only to the act, to doing what is right for you to do. And the fruits, leave them to whatever, to God, to chance, to destiny. And so that's where we are. Thank you all very much.